Okay.
Good morning, everyone, to this week edition of the workshop for the musculoskeletal physiotherapy. Today we are starting by 9:30 as earlier stated, and the presenter is already with us here, Dr. Abba Mohammed from Radiography Department, Bio University, Kano. So we are going to start without wasting much time because of the. Yes, sir, you can start.
Okay, good morning, colleagues. Happy to be here with you on this session where we are expected to dwell and discuss on the principles of radiological principles of musculoskeletal examination in physiotherapy. I expect I'm new among your midst, but I'm a friend of physiotherapy, and I'm really privileged for the organizers to see me fit to make this discussion. So within the next 1.5 or 2 hours, we will carefully, diligently discuss the medical imaging perspectives as far as the physiotherapist is concerned for musculoskeletal examination. I'm a lecturer with the Department of Medical Radiography here in Bayero University, Kano. So when we starting and at the end of this course, our discussion, we're expected to have at least these 5 basic objectives. We should be able to have a clear understanding of the fundamental principles and techniques for musculoskeletal imaging modalities. What are the range of equipment? What are the range of imaging options we use to assess the musculoskeletal structures? And if we list them, what is their philosophy? For us in radiology, understanding the basic concept of the image acquisition for each of the imaging option is very essential in understanding the particular type of image we are assessing. So one structure, you will understand that one structure will have different kinds of appearance across the imaging modalities. So we should be able to understand the principles. We should be able to interpret and also be able to objectively analyze radiological images of the musculoskeletal system, those relevant to physiotherapy practice, where you need to make informed decision regarding the kind of treatment option you will decide based on evidence-based features in radiology, clinical assessment that you are doing. And you should be able to apply these radiological findings and be able to enhance your decision making, which will definitely influence treatment planning. And if we get it right, of course, better patient outcomes will be essential. And we'll be able to educate our patients too. We should be able to have a sound knowledge about these imaging options and the radiation hazard that comes with each and every one of those imaging modalities. For us in imaging, in radiology, of course, we pay more attention to the radiation hazard than to the beauty of the images. Ironically, the higher the radiation hazard, the better the image quality. But we try to optimize to say, okay, let us get the least quality image that will have diagnostic information at the same time getting the lowest or giving the patient the lowest radiation hazard. And we should be able to collaborate with other radiology stakeholders in all to rally around the patient to see that at the end of the day, the patients get the best. So these are an overview of what at the end of this class discussion, we should be able to acquaint ourselves or update ourselves with. I hope I'm communicating, please. You hearing me, please? Can anybody hear me?
Yes, sir.
Okay, all right, thank you.
Please, can you make it slide in slide
Oh, it's not slide.
So that the...
Is it better?
Yes, it's better now.
Good, thank you. Now, so this is a course outline of what we will discuss. Introduce imaging musculoskeletal system, anatomy, physiological function as a mechanism, then range of imaging modalities we used to assess the imaging modalities. Each will highlight the applications, its advantages, and its limitations. Then the general principles as far as you are approached to any radiological image to make meaning out of it. What are those basic principles you need to put at the back of your mind? This principle at the back of your mind. These principles are all around. They must be and consistent. And never forget the radiation hazard, because we request radiological investigation. So we should be mindful once we are sending patients for any radiological investigation, mindful about the consequences of possible radiation hazard and what at your own level you can do, okay, to reduce the hazard or even change to the best or safest imaging option. Then we will have some cases, illustrate some case studies, okay, of common musculoskeletal osteoarthritis, ligamentous injuries, fracture, dislocation, infective processes, and traumatic conditions. Then we will move to correlating radiographic findings with the clinical presentation, because it must go together. Okay, your clinical presentation and the radiological findings are essential before we can have a prior radiological diagnosis, which would come at the end of the day influence your treatment regimen that you institute. Then we have to integrate this as far as in your management, and what are those limitations, challenges when assessing musculoskeletal images. We conclude and then remember our takeaways. So by way of introduction, the musculoskeletal system is a very important aspect in the human body, because it participates in functional abilities, locomotion, and other things. Because of that, it's very prone to wear and tear. And for us, imaging plays an essential role in the assessment, in the diagnosis, and then ultimately in the designing of the treatment, best treatment plan for a wide range of these musculoskeletal conditions. For you, physiotherapy practitioners, since you come in contact with this kind of range of conditions, you have every right to have the understanding of the fundamental principles of producing and assessing these images. Of course, if you have this understanding, your decision-making will be integral. You will optimize the patient care. And then at the end of the day, our therapeutic outcomes, the patient benefits most, as against when you are doing anything without an objective assessment. So here, we aim to equip ourselves with a comprehensive overview, highlighting the main points of radiological principles pertinent to musculoskeletal imaging, to physiotherapy practice. So anatomically, the musculoskeletal system consists of bones, consists of joints, ligaments, and tendons, and then some associated cavities filled with fluid. Each of these structures perform a particular function. The derailment of any of this any of these structures may result in pathology. And in imaging, what we do is basically we assess morphological changes. Not so is usually quantitative analysis, mostly in radiology. So it's things that you can see. If you can't see, you can't make a radiological diagnosis. So it's something that is obvious, something that is not hidden. So, of course, bones have a trabecular or medullary pattern and the cortical pattern. Of course, in imaging, a very important thing for us to highlight here is in imaging, we look at the atomic density of a structure that influences its appearance on the radiological image. Let me come again. In radiology, we look at the atomic density of a structure, an atomic structure, which influences its appearance on a radiological image. So between the cortical part of a bone and the medullary part of a bone, you know that the cortical part of a bone has more atomic density. The atoms in the cortical part are higher, more denser, more compact than the medullary part of the bone. So when you request for X-ray, you will now see that the cortical part of that bone or long bone is more brighter. Let me use this English term. It's more brighter, it's more whiter than the medullary part. So you can derive a relationship that the denser the anatomic structure, the brighter it appears on a radiological image. Because the bone, cortical part of the bone, external part of the bone is more thicker, more denser than the medullary part. You can chew the medullary part of the bone, but you can't chew the cortical part of the bone. Why? Because of the atomic density. And X-ray on the image, it also follows that relationship. So the whiter an area it is on an image, the more denser it is. Yeah, I'm talking about atomic density. And so also the lighter a structure is an atomic density, the more darker it will appear on a radiological image. So this is very important, please, rationale we should put at the back of our mind. Did we get this? Our 37, 38 participants, are we together, please?
Yes, sir.
Yes, sir.
Okay. Good.
Yes, sir.
Thank you. So you can see between bone and water or fluid, which one should appear more denser or more whiter, and which one should appear more darker? Joints, which has a fluid, like a synovial joint, which one should have more density, which one would appear more brighter?
The bone, sir.
Bone, very good. So areas that we can see fluid, we don't expect those areas to be white. If you see those areas where we expected that is synovial area to be filled with fluid, and we are seeing white area, that is an abnormality. Or in the cortical part of the bone, where you should expect it to be completely white, we are seeing density of fluid, appearance of fluid. We will now say, no, this is abnormal, because a normal bone should have entirely that white, compact appearance. So if you have fluid inside the cortical bone, is a problem. That's abnormal. That's pathology. So this is the general rationale for approaching what's it called? For approaching radiological image. Or you can see a fluid appearance inside a muscular tissue. That is abnormal, because you then expect to have a fluid density inside the muscle. I hope we get this rationale. So this muscle can appear as a result of muscle tear, okay, tendon retraction, and so many other things. You understand? So everything you ask yourself, why is this appearing white than this? It's simply because this is more denser than this. If it's less denser than this, but the less dense is appearing more white, then you will now say, no, it's a problem. It's an abnormality. I hope we get it. So we'll go to we will discuss that in due course with illustrations on the images. Okay. Now we are beginning gradually to apply this concept into imaging. Basically, in general terms, we have four common reliable imaging modalities or options used in assessing the what? Musculoskeletal structures. We start from the basic to the most complex. The most basic is plain radiography, the common x-rays that we know, planar radiography. Okay, now this imaging option is very common, readily available, and is usually the first line modality, basic first line modality for assessing the musculoskeletal system. Okay, it is relatively cheap, and usually it is limited in its application, limited to bony injuries. Bony injuries, and illustrates, gives an indirect explanation about the joint spaces. We know the surfaces of a joint is formed by a cartilage. So once we have a joint space that is formed in between the bones in a joint, we expect that that joint space is representing the space occupied by a cartilage. So absence of that space on a plain X-ray gives us a clue that there is a degenerative condition involving that cartilaginous structure. So that's why I say indirectly give us information about cartilage, but we don't view the cartilage, okay? But basically gives us information about the bones. Is now understood. Because of that, you can easily diagnose fractures, dislocation, and some degenerative conditions involving the skeleton. Okay, but it is basic, it is cheaper, and is mostly available and very cheap to maintain, and is popular. Is now understood? So if you have a patient with a complaint of a fracture, I believe if it's a simple, non-complicated fracture, we should start from this basic point, which is X-ray. It can do the job for you, plain radiography, or suspected dislocation, okay? Usually is a first-line imaging modality. Now, we go to an advanced one because we are in a digital age, everything is computerized. So ability to, how do I say, to manipulate, to post-process, to optimize the information using X-ray is limited. But CT is a computerized form of the plate radiography, whereby you can process the image, you can handle the image, you can change the image in different forms, and you can see the image in different plane, either axial, either coronal, either sagittal. You can all manipulate it in order to have a general view of a situation, and usually applied in cases of what? Complicated fractures. Okay, it has best soft tissue, best bony detail. The resolution on CT images are far better than that of X-ray for bony part of the bone, for bony part of the skeletal, musculoskeletal system. It has high sensitivity for bony aspects of musculoskeletal system. But nonetheless, soft tissues can also be imaged, but with low spatial resolution and other associated internal organs. So it's just an advancement of radiography, but with a computerized way, and it gives you an ability to see the particular pathology in different planes. Unlike in X-ray, it's only in the coronal plane you will see, but in CT, you will see it in axial, you see it in sagittal, the problem, and you see it in coronal plane. All the planes you can post-process, okay, and to appreciate what you are seeing without any incision onto the patient, okay? Now we go to the next one, but of course it's more expensive than a planar radiography. Then we go to another one called MRI. okay, magnetic resonance imaging. We said CT has the highest resolution as far as the bony part of the musculoskeletal structure is concerned, bony part. MRI, on the other hand, has the highest resolution as far as soft tissue is concerned. So CT is good in bone detail, while MRI is good in what? Soft tissues detail. You understand? So if it's really a cortical problem, CT would have done the job for you better. MRI is very terrible as far as bone and bone resolution is concerned. Cortical part of the bone is concerned. So, but you see muscles, associated muscles, ligaments, cartilaginous structure, tendons, all right? MRI is a household name, has a higher spatial resolution, and also it illustrates muscular tears, okay, strains, and other inflammatory conditions, such like bursitis and co. But what is its limitation? Its limitation is that it's not widely available. It is very expensive, and it is difficult to maintain. Okay, so for us as physiotherapists, if we have a patient that has a basic, okay, I think it makes more you make more do an X-ray. At most, we can manage it.
Fine, you doctor.
Go and do CT that will 40, 50,000 naira. Okay? Or go and do MRI that will cost you over 70 or 60,000 naira, as the case may be on your location. I hope we are communicating. So for you as physiotherapists, requesting the ideal examination at the best appropriate time is very essential, and that underscores the need for this training. Okay, the next modality is ultrasound. Of course, it's a common modality for us, usually largely applied in obstetrics examinations. We like expertise, sufficient expertise in musculoskeletal is a field on its own. Okay, and it simply uses sound waves to assess this musculoskeletal structures. The advantage it has, ultrasound, is that it gives us dynamic information, dynamic view of ongoing processes in a joint. The mechanism occurring within the joint is dynamically seen on a real time. Okay, so it's applicable too for visualizing soft tissue structures, and it's also limited in associated bony injuries. It doesn't have poor image quality as far as bony structures are concerned, but associated soft tissues is a great modality as far as the ideal technique, the ideal equipment is utilized. All right. Okay. What I forgot to say here, are we together? What I forgot to highlight here is that of all these techniques, of all these 4 imaging options, there is the kind of radiation that we say is ionizing radiation, or a more harmful type of radiation. And there is one that I would say non-ionizing, okay, radiation. So the previous slides, because they all use X-rays, because they all use X-rays to acquire the image, and we know X-ray is a potentially harmful kind of radiation. These modalities, X-ray and CT, uses ionizing radiation. So we should have great concerns when requesting for any kind of examination related to this. And we shouldn't be periodically requesting, except when there is sufficient justification. We'll come to that where we will discuss. However, these modalities, MRI and ultrasound, you can see they do not use X-rays. The kind of radiation or wave they use are harmless, are non-ionizing. All right, you understand? So we should consider these applications when ordering for our patient, especially those people that are at high risk of radiation hazard, like a pregnant woman, like a child. All right, they are at more a risk of radiation hazard, and we should be cautious or be mindful or measure the benefit or the relationship before now requesting for this examination, except when the options are exhausted. So having highlighted these 4 imaging modalities, what are the principles for approaching them in order to extract as much information as we can for a particular condition? One, there are 4 of them. One is that we should have supportive understanding of the image acquisition processes. All right, I told you one structure like bone can appear different in MRI, can appear different in CT, can appear different in MRI, can appear different in X-ray, can appear different in ultrasound. So the first thing is, once you are approaching an image, ask yourself, what image or what modality image is this? CT images appear, look somewhat similar than MRI, but they are different. And you can end up identifying a structure like a patella, and you're now saying it's a fat part. It's a patella fat part. And you can see at the end of the day, you will make a wrong diagnosis because you will be saying there is no fluid in the joint. Whereas you are just saying the cartilage, cartilage structure that shouldn't have a fluid density. All right, so understanding the image acquisition process is very essential. All right, understanding the next one is understanding the view you are seeing. If you are an approach view, what view is this? Is this a PA view? Is it an AP view? Or what plane is it? Is it an axial view? Is it a sagittal view? Is it a coronal view? Please have this at the back of your mind when approaching any kind of radiological image. Having understood, having answered those 2 basic questions, what modality, what plane, or position, and the next thing is you must have a thorough understanding of the normal anatomy of each of the musculoskeletal area. It is only when you know the normal that when you see the abnormal, you can now pinpoint and suspect, no, this is abnormal, this is abnormal. So we must be familiar with the contour, with the orientation of a normal, with the appearance of the normal bone joints, normal bones that makes up the joint, and normal articulation, normal associated soft tissue structures with their cause before you can now draw a conclusion. Then I say, no, there is an abnormality here because the normal shouldn't be like this. So if it's like this, then definitely this place has a problem. And what structure is in this place? This place likely is a ligament. So if there's a ligament here and is abnormal, we begin to, and then we now correlate it with the patient's history. He's a football player, that he was just playing ball, he went to the next thing. Somebody should help us mute. Somebody should mute. Who is that, please? Okay. Then the next thing, it's a football player. For him, he just got a shot, and then he had a knee pain, severe knee pain. And then you will now marry it. Okay, knee joint, this, and then it could be this. And there is, so you can see how we can now marry. Then the next thing is radiographic signs. When we know the normal, are we there? When we know the normal, whenever we see the abnormal, we will now draw conclusion and say, yeah, definitely this is abnormal because there shouldn't be soft tissue swelling, there shouldn't be fluid in this location, or the fluid is excessive, all right? Or the structure should have been there and it's not there, or joint space is narrowed, whereas it shouldn't be narrowed. We will see it in our case, study. Each of this sign has a characteristic feature that will aid in a diagnosis. And then we correlate with clinical findings, as just like I have said, which you handle their patient history, their physical examination, or other techniques you adopt in physiotherapy to come to an informed diagnosis. All right. So we'll move to the next slide. We move to the next slide. After all this, I said radiologic radiation concern. In radiology, we pay a lot of emphasis on our patients. A lot of to our patients. Just like I've said, high-risk patients, we now say, of course, this is a first-line radiography modality, but high-risk patient will now say, please, it's better we do another examination. And the difference between it may be in cost implication will be minimal. Like instead of doing X-ray, go and do ultrasound. You understand, because of your specific condition. So even when we have the patient that is at low risk, we always protect the patients. And what do we do? There's a concept, universal concept called the ALARA principle. At all times, radiation worker should give radiation to the patients as low as reasonably achievable, but it shouldn't be so low that it will impede or affect. Or whenever I always give this illustration, you have a phone. Most of us target to have iPhone 14, but somebody with iPhone 11 or 9 or 8 can still have his images. The images will also be of ideal, of normal quality that is of comparable to any other thing. I don't know whether you get it. Okay, that his images will be what? His images will be of similar quality, not similar, of lower quality, but they will be appreciable. So rather than you insisting of iPhone 14, you can keep your iPhone 8. And your money that you used to offset to buy, you can do it for other things. So this analogy I always give. Somebody with iPhone 9, his images will be good in his camera. He will still resemble himself. I know that he snapped himself. But of course, everybody argue for iPhone 10. So it's not always the best quality. In radiography, when you have the best quality, you also have the highest radiation dose. And when you have the highest radiation dose, it means more consequence for the patient. And these symptoms will be emphasizing at a much later time in life, when he has even forgotten that it was due to radiation that he's developing the symptoms. Okay, so this ALARA principle should be applied from the requisition point, that when you are requesting for this examination, radiological examination, what is the implication of radiation dose? Or you've done it last week, you've done a follow-up, we now say, okay, do it this week. No, let's wait next week so that at least the radiation accumulated dose will be lower. Is that understood? Then another concept which we do in radiology is dose limitation, which we will always apply. All right. Some softwares, we work with softwares that they will tell us this dose we given to the patients is high, but we can only continue if there's sufficient clinical argument, and that you have to input your name, your details before the machine allows you to continue the examination. All are a form of modalities to limit us, to remind us of radiation protection. And we should be able to educate our patients. There is not always to go to radiology to do the examinations, except when there's sufficient justification. And even when there's sufficient justification, the benefit that you will extract from the product of your radiological examination far outweighs the potential risk from the radiation hazard. So it's only when we educate our patients and tell them at the end of any radiological examination, this is the cumulative dose that you had received, in order for the patient to also keep track of his information, of his radiation dose. We rarely practice, okay, here in this part of the world, but it's very essential we do it. And of course, we monitor both our patients, but our staff, to see the accumulated radiation exposure. I told us some of these things begin to manifest way long after you had even forgotten that it's due to radiation dose. But if we monitor ourselves, we are cautious of all these things, we can directly be attributing some of the radiation sickness, radiation in the sicknesses to radiation hazard. So radiation is harmful, nonetheless, but it's also beneficial when carefully adopted. And that is what underscores the need to always utilize the use of professionals as against quacks who will simply have been saying they've been working in an establishment for 20 years. They've seen how this is done, how is this done, without measuring or integrating the implication, possible integration. Okay, so we are going down to case applications. Imaging features. What are those radiological features for musculoskeletal disorders? This explores the common features, identifiable features for us in physiotherapy, which we will be dealing with these images from day on to day on. I must remind us that most of these things are not easily appreciable. We are practitioners, so it does underscore the importance of this lecture. Continuous training, continuous practice will now develop what we call the radiological eye for us to develop more competence and be able to see the unseeable radiological feature to the common man. All right. So common musculoskeletal disorders and their radiological appearances. Of course, common fracture, dislocation, osteoarthritis, and the bony tumors. I need to remind that point I had earlier on. I said, all right, that in a bone, the cortical part of the bone should appear completely white throughout its length, isn't it? Isn't it? So in a fracture, there is a there is a complete breakage of that bone transversely. Most times it could be oblique, it could be whatever, spiral. Now, if there's a fracture, it means there is discontinuity in the cortical part of the bone. And if there's discontinuity, we know a normal bone shouldn't be discontinuous. And if we see that line, we call it the fracture line, which shouldn't be there and is easily appreciable. Okay, depending on the severity or angulation or the displacement of the fracture, because that fracture line is indicating something that shouldn't be there on a good day. And that fracture line, because it does not have the density of the bone, that fracture line will appear white or black. It will appear black. You understand? So, and it's very clear when you write on a white, when you write using black on the white, it's very clear to be appreciated. Is that understood? So this is the rationale for this little fractured bones, and it's easily appreciable using X-ray. Dislocation usually also occurs at the joint. Okay, as a result of an alignment of joining bones that makes up the joint. Okay, displacing it with different configuration. It could be anterior, it could be posterior, it could be right, it could be left, depending on what the mechanism for induction. So it's only when we know the normal anatomy of the tibia and the femur, or the scap or the humerus and the ulna, that is when we can only know, there is a dislocation. If we don't know the congruency, if we don't know the alignment, definitely there is no way we can make an informed decision that there is a dislocation. We can't close our eyes. There is a dislocation if we don't know the normal. So it underscores the need to really practice the normal. All right? Then osteoarthritis. Osteoarthritis is a condition usually affecting degenerative condition, usually affecting the cartilage of the bone, leading to, in progressive cases, it leads to the erosion of that cartilaginous and even the grinding of what the surfaces of the bones that forms the joint. Example is the tibia and the femoral condyles. Now we know that since there's a problem with the cartilage, but in X-ray we don't see the cartilage. What represents the cartilage is the joint space, isn't it? The space between the femoral condyles and the tibial plateau. So when we do an X-ray and we don't see that space, rather we see the femoral condyles very close or in contact with the femoral condyle and tibial condyle. When I say, there is narrowing of joint space, possibly the lesion of the cartilage here, definitely this is a sign of osteoarthritic condition. And there are other features that I'll show you on the image, what we call subchondral sclerosis as a result of fibrotic nature of the surfaces of the femur. So that is another analogy. All right. Or bony tumors. All right, bony tumors. Just like what I have said, if you see a fluid density, a blood density inside the white area of a bone, that white area, that dark area or that fluid density shouldn't be there. So it's an evidence that fluid is collecting in a particular part of the bone, what you call light changes. Okay, or there could be even a bone growing inside a bone, a metastatic one growing inside the bone, and one focal area of that bone will be more whiter than the rest normal kind part of the bone. Those area we call it sclerotic area. All right, lytic bone destruction, and since bone is white and it's been destroyed, it's becoming black. So that's it. Or sclerotic, since bone is white, it's been sclerosed, becoming more thicker. That sclerosis is becoming more thicker. And as it becomes more thicker, that area becomes more whiter on the image as a sort of focal lesion, usually irregular in nature because the metastatic. Okay, and we can now say it could be osteomyelitis, lytic changes, or even sclerotic changes. It could be a bony, okay, tumors. This is just general. We have more to illustrate. Are we communicating? Am I communicating, please?
Yes, sir.
Yes, sir.
All right, thank you very much. Thank you.
Go ahead. We're following.
All right, thank you. I had one terrible experience. I was having a virtual class, was having lecture over 50 minutes. I never knew. I was just talking to myself. So that's why I like to be here that we are together. Okay, well, let's continue. So this is a case. Our first case here, having explained the mechanism of understanding radiological image. Okay, we are now approached with this image. And from the previous slides of principles for approaching radiological image, what was the first thing I highlighted that we should ask ourselves before even approaching the image? Can anybody hear me?
Yes, I think the type of image used for machine.
Very good, very good. What imaging modality? Now, what if I tell you that this is an MRI image?
I think it's an X-ray.
Okay. Why do you say it's an X-ray? Good.
So I can see the image clearly, and it's AP view for the first one.
Okay. All right. So you can see, if I had confused myself and I say this is an MRI image, I'll also ask myself, why do I say it's an MRI image? Okay. Now she says a planar radiography X-ray image, yeah. And then I ask why she says a planar radiography X-ray image. So this is not MRI because MRI does not produce image of the bone clearly. Did I say that?
Yes, sir.
X-rays and CT has higher sensitivity for the bone. I said that. And here we can see, we are seeing more detail, more spatial resolution for the cortical part of the bone. I don't know, can you see my cursor? Can you appreciate my cursor? It's rolling.
Yes, sir. Yes,
very
sir.
good. It's moving, right? I want to illustrate so many things. Now, here, this presumably, okay, we have agreed this is an X-ray. X-ray of where? The shoulder, of the ankle joint, or the elbow joint?
Knee.
Looks like knee.
Looks like knee. Why do you say it's a knee? Yes.
Because of the joint relationship.
Aha. So this is a format we developed. Exactly. So this is the format. What modality? After what modality? What region? What view? Please don't forget these things, okay? What imaging modality? What anatomical region? What view? Now, of course, this is the knee, all right? Knee joint. Now, having seen the knee joint, my cursor, where's my cursor? Good. You can see my cursor? This is the knee joint, right? Yeah. This is the distal 1/3 of the femur having the lateral and then the medial femoral condyles, and then to the tibial plateau, isn't it? On a good day, we know that this femoral condyle shouldn't be this close to this tibial plateau on the lateral femoral condyle, because we know there is a structure in between it, giving that joint space. Are you with me?
Yes.
So because of that, we now say, so since we can't see, and you can see it is more severe on the lateral side than on the medial side, even though the medial is so narrow, but it's more severe here on the lateral femoral condyle than on the medial. So the degeneration of the structure occupying, making that joint space narrowing, is more severe on the lateral compared to on the medial side. And there is that evidence, that's one. So narrowing of joint space severe on the lateral surface compared to the medial, even though the medial it is. The next feature, another feature we are seeing, is that this tibial plateau, you can see, is thickened. What we call that, this is the evidence of what? Subchondral sclerosis. That the femur is brushing the tibial plateau. The tibial plateau is brushing it, and a good day it shouldn't be there. And so it is sclerosing, it is dying. The tibial plateau is brushing itself. You understand? It's hindering blood supply there. The next point is, you can see these spikes here. A pointed, blunt end, sometimes pointed, sometimes it's blunt end, okay, bony growth at the margin of either the tibia or the femoral condyle, called osteophytes. These three features are classical features for osteoarthritis. Can we see it here? Can we see it here, the osteophytes? Can we see the subchondral sclerosis? Can we see it? When we now produce this image for a baby, for a child, you can see the joint space will be for a normal adult. We'll see the joint space is increased. It's not as if it's narrowed. All right. Osteophytes production, narrowing, subchondral sclerosis. You can see here completely in contact. No joint space here completely. Are we together?
Yes.
So that's about OA. Now, certain soft tissue structures in
hello, sir.
Yes.
In one of the slides here, one of
Yes.
the pictures, the joint space was not narrowed but increased.
Which one?
I can see if you look at it, if you compare.
Okay, are you saying this? Are you saying this?
Also, you don't know where
this one?
Yes. And
this
yeah.
right?
Yes.
Yeah.
Yes.
What caused about increase here is because at the time when they are producing the X-ray, the weight of the patient was transmitted more on the medial side. So if the weight of the patient transmitted on the lateral side, here will also be narrowed. You can see there is evidence of osteophytes here. So the cellular here is still closing. Here is still closing. It's still narrowing, because look at the osteophytes is still attaching. That's a very intelligent question. So here, if the weight is transmitted more towards the medial side, this space will be narrowed. And if this space narrowed, this space will be increased. But in all the surfaces you can see, there are osteophytes. This osteophytes is evidence that they are brushing each other. Is it understood? Mr. I say, is it Mecca? Ike?
No, it will be fine. Thank you, sir.
Ifeanyi. Did you get it, please?
Yes, sir, I got it.
Because that is why I say understanding the principle of production. It can be done when the patient is standing, or it can be done when the patient is sitting. In fact, when we have a suspected osteoarthritis, it's best to be done with the patient standing. so that we can see the degree of the narrowing of the joint space. But now in practice, most of the times people don't tilt the ideal, they don't acquire that. So when you do it and the weight of the patient is transmitted not evenly on the medial side, it will be narrowed. If it's more on the lateral side, the narrow lateral side will be narrowed. But in all, we can have this second feature of the osteospite reduction, both in the lateral and both in the medial. But this patient condition, you can see, is more severe on where? On the medial, because the subchondral sclerosis is more brighter here than on the lateral. Is that understood?
Yes, sir. Yes, sir. Go on.
Thank you. Thank you very much. Then next slide is soft tissues. Okay, so there are injuries common to, yes.
Sorry, about the increased joint space. What if there is a bony malalignment, or maybe like a deformity of the knee, maybe like Genu-Valgum or Varon?
Then that you would take into cognizance that condition, and even during the process of image acquisition, you will see that. So you take that cognizance, and the alignment of our film will not be the same. So the joint space you can see here, you can see the joint space on the medial plateau, the joint space on the lateral plateau. You can see they are somewhat on the same plane, but in that deformity, you can see one would be the joint space will be diagonal. One would be higher than the other. But you can see these two, each of these joint space, they are somewhat on the same plane. Can you see it? But that Genu-Valgum or Genu-Valgus, they will be oblique. One will be much higher than the other. And the tibial plateau too will now be, that part will not be transverse, horizontally lying.
Okay.
Did you get it?
Yes, sir. Thank you.
All right, thank you. So we move ahead. Ligament injuries, muscular injuries, imaging features. Now, of course, ligamentous. Yes.
Sorry, I was muted. I wanted to ask, can we see what it is look like on the X-ray and the previous slide?
What?
This is the fourth item on
the fourth item. I didn't get an image where the cyst is, but usually at advanced levels, you have, it's just, where's my cursor? At advanced level, if this continues to progress, as usual advanced level, because we know there's blood supply here, isn't it? So if there's blood supply here and the patient continues to move, as he continues to move, he continues to grind this subchondral area, and blood will begin to collect at just the subchondral level. So since blood will collect at the subchondral level inside this bone as a result of the brushing, the grinding of this tibial femoral condyle, we now say there's evidence of subchondral cystic collection. Okay? Maybe before the class runs out, I may source for one image with the subchondral cyst, okay, and illustrate for us. Let me see. Maybe before the class runs out. Let's continue. Okay, you will see it. Are we together?
Yes.
Yes, sir.
All right. Then we move again. Ligamentous injury, we say we can't use x-rays to see the ligaments, soft tissues, right? Sort of muscular tissues. So usually ligamentous injury, MRI is the gold standard. Okay? MRI is the gold standard. Why? Because MRI doesn't produce images of the cortical part of the bone. It only produces images of soft tissues, isn't it? So those soft tissue areas deep inside the bone, since MRI doesn't have problem with bony, so bone does not interrupt the production of the signal of those deeper soft tissues. And because of that, MRI is ideal for assessing those deeper soft tissue musculoskeletal structures. And it can easily reveal ligamentous injuries, partial or complete tearing, or even rupturing. And how? In MRI, we explain structures not in their density, but in their intensity, in their brightness. Okay? or joint effusions, fluid collection, and then abnormal fluid effusion. Okay, muscular assessment, because muscles are more superficial. All right, ultrasound and MRI are also good in assessing those structures, either tears, ruptures, or anything are revolving around muscular issues. And since ultrasound use sound, we regard them not in their density, but in their echogenicity. So we can see areas of hypo or hyper echogenic areas. A structure like a liver or musculoskeletal structure like a muscle will have a uniform, homogeneous echo texture. But when we see a focal, one focal point area having a different echo texture, we'll now begin to think problem. What could be the reason why this area could have this problem? It could be tear, it could be hematoma, or any edema collection, all right, or fluid collection. Okay, so imaging features either MRI or CT, depending on the clinical indication of patient's complaint and patient status. Is that understood? So we continue on them. Now, one of the common ligamentous tendinitis issues is what's it called? Rotator cuff, okay, of the shoulder, usually involving supraspinatus tendon. Here, we can't use X-ray. We can't use X-ray to evaluate the tendon, because X-ray is not good in assessing soft tissue structures. All right, it's only, we said, only ultrasound or MRI, and MRI is the gold standard. Now, MRI too has over 50 different forms of images. Over 50 different forms of imaging, but the most common one are the T1 weighted image and the T2 weighted images. Now, if you want to be assessing pathological conditions, the T2 weighted images are the ideal reference, gold standard forms of MRI images for assessing pathological conditions. Why? Because in T2, fluid-like structures appear bright or hyper intense. Okay, fluid-like or cystic structures on T2 images appear white. Now, what is special about fluid appearing white? Usually, most pathological processes usually are associated with fluid production, be it inflammatory, all right, be it traumatic, whatever, there is some extent of fluid production. So in area where you should expect not to have a fluid density or a fluid intensity, and those areas you are having that fluid presence, all right, then you can now draw your conclusion that because white is easily seen on a background environment, you can now easily begin to deduce and make your inference. Now, this is an MRI image here of the shoulder. And how do I know it's an MRI image? Because you can see the bone. This is scapula. You can see I cannot appreciate the architecture of bone, unlike in X-ray. So that is why I know that this is MRI. Unlike in CT, I cannot appreciate the medullary or the trabecular pattern of this bone. And this is a classical feature of the humeral shaft, head of the humerus. So this is a classical feature. And then I can see within the joint, you can see the surrounding surfaces of fluid production. So this is supraspinatus muscle, and that's the tendon extended. You can see the tendon here is very dark and continuous till where it attaches on the head of the femur, of the head of the humerus. Can you see it continuously? No interruption in signal intensity. Usually it is of low signal intensity. You can see the tendon is more darker than the supraspinatus muscle. You can see it, tendon. Now look at it here. That's a spinatus tendon. Look at the extent of fluid collection also. You can see it's minimal, isn't it, on this? Now, what on this image, can we see that this is the head of the femur? That tendon or that dark area that produces from here to the attaching certain surface of the bone. Can you see that tendon is missing? Rather, the area is now replaced by fluid signal intensity. And on a normal day, we know that fluid intensity shouldn't be there, or even if it's there, shouldn't be extensive in this respect. So evidence of hematoma fluid collection is an evidence that this tendon has retracted, creating a space where there is a bleed and collection of fluid has settled. You can see the fluid up till the lower surface of the head of the humerus extensively. Can you see it also here? More emphasized. You can even measure the degree of the retraction of the tendon. You can see here completely taken over by fluid. Can you see the fluid outlining the entire extent? But here, this image, you can appreciate it if it is T1, because on T1, the fluid will appear what? Dark. So when you want to assess pathological structures, please ask of T2, T2, T2. Is that understood? Am I communicating, please, everybody?
Yes, sir.
Let me hear your responses.
Yes,
You are
sir.
doing well.
Yes, sir.
All right, so T2, as far as diagnosis, as far as assessing pathology is concerned. Are we together? Of course, and then that's the extent of that degree of displacement. For you as physiotherapists, you will decide what kind of treatment regimen, what kind of modification, what kind of exercises, or even if there is need for referral for surgical intervention. We go to then another issue of a soft tissue pathology, musculoskeletal issue, a very common one. Okay, we mostly encounter. This is what in the knee or the cruciate ligament, usually the ACLs, footballers' issue, right? Isn't it? Now look at it here. On this, are we together?
Yes, we are.
Can you see my cursor?
Yes.
So this is an MRI image. Is this a sagittal view, a coronal view, or an axial view we are seeing before us? Is this a sagittal view or a coronal view?
Is this sagittal view, sir?
Thank you, because that's our rule. Identify the modality, identify the view, what region. So this is the region of possibly the ankle, or the shoulder, or the elbow.
The knee joint, sir.
Very good. This is the knee joint. Yes. Yes, this is the knee joint. Why do we say it's the knee joint? Because we can see
the patella, we can see
patella, very good. We can see the femur, we can see the tibia, we can see, you can see the joint space here clearly. Not like that was also arthritis condition. Can you see it? It's more emphasized here, the joint space. Very good. Now you can see the ligament traversing from the posterior part surface of the intercondylar fossa to the anterior surface of the tibial plateau, transverse, moving obliquely and anteriorly. Can you see it? So hypo intense, isn't it? Yes. Here the patella, you can see the fat part and everything. Now look at it in ACL. But what about in this image? Where is it? Where is it? We can't see it, so it's not there. So it's torn. But look at this. This is just an evidence of its retraction. This, can you see my cursor? This dot is an evidence of the head of the tendon that has been retracted since it's under pressure. You can see it's very straight and oblique. But if it is torn or partially torn, it will be loose and it will not be this oblique. Or completely absent. Yeah, completely torn. Okay. Are we together? Aha. Look at this one now. Look at this one. Can you see? Is it completely oblique? Is it under pressure on that tendon? It is there, but is it under tendon, under pressure? No,
Yes.
it's not straight. It's not straight. It travels irregular. Since it travels irregular, it means it is partially torn. It's weak, losing its function, losing its laxity, even though it's there. So with continuous stress, this can come completely and eradicate. Here, you can see we cannot see it even to completely. Look at the head here. This is the end here. Because it's only fat we are seeing. These are all fat. Are we together? Look at it here. This here are retracted also. That's the end. You can see here, this one is broken completely. Can we see it? You can see
Sir.
it came in, but here there is structural discontinuity and then continuous here. There is complete rupture here, complete cut. Appreciated? Is that appreciated?
Yes,
So it is best for ACL. For ACL, it is best appreciated in what view? Sagittal view or coronal view?
Sagittal.
Sagittal T2. Sagittal T2. Okay?
Yes.
Good. Then subluxation, of course, is a common thing you handle already. Usually happen in joints, displacement of the joint. We have highlighted that, right? Is it? Isn't it? We have highlighted this subluxation of the joint. All right, and we will determine which outcome treatment you will do. You can see here, isn't it? It gives you extent and then the degree and the direction to which that is displaced. All right, then fracture. Yeah, you can see it. So with imaging, you can see how clearly the bone detail is compared to MRI. You can see the cortex, you can see the medullary part, you can see the alignment with the ankle joints, you can see how many bones are involved in the fracture and the orientation of this fracture. This, once you assess, you now say, okay, which one you will first treat, and then which one you should be careful and not to touch, because you have now seen with the aid of imaging how it could be useful to decide which kind of immobilization technique, pain management, and so on and so forth you can decide. And look at the derailment in the joint space, in the joint congruency. And you see it is more displaced to the lateral than to the medial. Well appreciated. This is obvious, all right, by fracture. Usually it's very easy to see. Tendon usually also, Achilles tendon can be seen, and MRI can also be seen, okay, with an X-ray. You can see a complete tear, okay, rupture, completely rupture of the tendon. You can see it. This is an MRI. You can see how the space between this tendon, the cut segments, is so bright, very easily seen on T2 sagittal. All right? All right? MRI. Disc herniation, isn't it? Yeah. The annulus fibrosis ruptures, and then usually it can rupture anteriorly or it rupture into the spinal space posteriorly. And usually it's also seen on a T2 sagittal. All right? C2 sagittal. Don't pay attention to C2, T1 axial, T2 axial. T2 sagittal, you can see that there is protrusion of the L5S1 into the spinal space anteriorly. You can see it's also bold posteriorly. You can see that's also bolded posteriorly. And there's lots of signal of the intervertebral disc compared to adjacent signals. You can see it. So obvious kinds of discs are prolapse, isn't it? This will decide at the specific level what you will do, and then even to conserve the spinal cord. All right. Then ultrasound, very valuable. Does not use ionizing radiation. Is very good for characterizing or identifying cystic and solid issues. So suspected joint effusions, suspected joint inflammation with loose bodies, ultrasound is a very good candidate because it gives you real time. Okay, and you manipulate. You can apply pressure to see that fluid, is it compressible or is it fixed? Isn't it? Or does it have an associated bursa to communicate with? So the extent of fluid collection can easily be seen. Fluid on ultrasound appears completely black. That is a non-infected fluid. But an infected fluid will appear black, but with white debris inside it. White debris inside it. All right. So look at this. This is an ultrasound. Okay.
Sir.
Yes.
Excuse sir.
Yes.
Please, can you take us back in that MRI of the spine?
Okay.
My question is, how do you identify, let's assume, somebody that has lumbar spondylosis or any of all these spinal issues, listhesis, spondylolisthesis? How do you identify it using?
Okay. All right.
Yeah.
All right. So this is not this won't give us for it. I just narrowed it because it's liberal disc, and it skipped my mind to be candid for this spondylosis. But usually, what we do is we assess the entire. There is what we call longitudinal orientation of the entire spine. The lumbar normally is lordotic.
Yes.
Normally, usually people with spondylosis, they have a reduced lordotic nature of the spinal arc. This anterior curvature is reduced, and because it's reduced severely, we now say because there is strengthening of what's it called, the lumbar, usually as a result of muscle retraction, many things, please, obvious kind of what? Spondylosis. Did you get it?
Yes.
Okay, it's with experience and with time that one will be able to okay. While in spondylolisthesis, okay, usually there is this anterior displacement, okay, of the one of the vertebra. There is that the complete, there is a focal localized displacement of the vertebra forward, thereby derailing the curvature. This one is not, there is what you call prevertebral line. Prevertebral line is a line that runs through the arc of the body of the lumbar or any vertebra, okay? And if there is any derailment, any vertebra that runs anterior to this line, we now say there is a spondylolisthesis at maybe L2, L4, or whatever, okay? But in spondylosis, there is not the anterior displacement, but the curvature of the entire vertebra is reduced. Did you get it?
Yeah, I'm hearing.
Okay, so in spondylolisthesis, one of the vertebrae moves slightly anteriorly, displacing the alignment of the curvature of the vertebra. But in spondylosis, okay, the entire vertebra, no one moves, but the curvature of the entire vertebra is reduced.
Okay, so you are saying that the loss of lordotic curve results in
spondylosis. Okay. But in spondylolisthesis is a forward displacement of a focal vertebra.
What of the degenerative changes?
Degenerative changes is reduction in intervertebral disc. This one, just like this one, I don't know if you can see from your distance, the distance between this intervertebral disc and this are somewhat the same. Are they the same? Between this and this. But what about this? Is it the same?
No, sir, it's reduced.
Which one is narrower?
No. That one, this one, the one where your cursor is.
This is evidence of the degenerative change. With time, it will begin to develop osteophytic changes. That subchondral sclerosis feature will begin to develop here because the bone will begin to gradually be grinding on itself in its neighbor.
Okay.
Is that appreciated?
Of course, yes.
Thank you very much.
Okay, sir.
So on ultrasound, I said dynamically, we appreciate all these things. Okay, and it can give us fluid clue to understand this change. Is fluidy in nature, this pathology, are they fluid or are they solid tissue? If they are fluid, we'll begin to think of fluidy or cystic pathologies. If they are solid tissue, we'll begin to soft tissue okay, or solid pathological conditions. And that is how we derive our differentials. All right. So, and in cystic conditions, it can also give us to say this cyst is clear or this cyst is infective. An infective cyst contains white echoes inside it, just like this one. But look at this one, it's very clear, no white echoes inside, isn't it? So this is a clear effusion fluid, but this is a clear infective fluid. Can we see it on ultrasound? And it's fluidy, isn't it? Because fluid is appear completely black. And these are muscle fibers. Muscle fibers, look at the prefemoral pathway. So these are muscles anterior to the femur, isn't it? Now here, this is ultrasound, MRI image, sagittal view. You can see fluid on the suprapatellar bursa. Can you see it? Extending the synovial fluid completely, isn't it? So this, of course, you can see this fluid has collected beyond normal. So this is a clear case of joint effusion. It's more than normal, okay? And look at the signal intensity, very bright. So this is a clear case of joint effusion, okay? And of course, the patient will be in pain, severe pains during the image. Acquisition. So on muscle fiber to develop the eye, requires one to develop competence in the radiologic, what's it called? Radiologic eye, okay? But with time, when we practice, we'll appreciate. Look at the fiber. Can you see my cursor here? Can you see the longitudinal striated muscular fibers? Can you see them here?
Yes, sir.
Can you see them here? But they are not here. And then it continues above. Anteriorly, can you see the striated muscular fibers? If you see a careful eye, there is longitudinal bands, striated fibers. Can you see it? But inside the middle here, we don't see it. In fact, rather, we see a focal hypoechoic as if fluid, hypoechoic as if fluid, then muscular fiber, hypoechoic. I don't know, can you see it? So here, completely here is an abnormality. You can see it where we drew these arrows. It has interrupted the homogeneous appearance of a normal muscular fibers. So this is how we develop to now say, aha, because of this abnormality, there's a focal irregularity within this mass. We normally measure the depth from the anterior, from the subcutaneous tissue till this level. We now give the measurement for surgical guide and anything, and I'll say there is focal. Most likely is a muscular retraction, muscular tear, and there is evidence of fluid collection. All right, evidence of bleed, hematoma. Can you see it? Fluid collection inside the muscle, fluid collection inside the muscle, fluid. Can you see this one much clearer? All right. Okay, but it needs time, it needs competence for you to appreciate this. All right, so muscular tears can easily be seen on a high frequency ultrasound equipment. Is that understood?
Yes.
Good. So we have to collect clinical findings, radiographic findings, and clinical findings. Patient history is very essential because if you take patient history, it gives him he was playing football and then he made a shot, and then the next thing he can't walk, in severe pain. That was the end of the football. You can now begin to draw clues. Then you do your physical examination, which you are very competent, I believe, on, and then you conduct your radiological examination, specific area. After marrying the physical examination, after taking the history, you recommend the ideal physical radiographic examination that you will do. You now harness the findings. You integrate the findings with your physical examination, taking into consideration of patient history, and then you will now decide what best approach you will do in order to manage your patients. So that is it. Integrating all these things plays a very essential role in the management. So harnessing as much information as you could from your patient during clinical assessment, during patient history, harness enough as you could. Where you have doubt, 6-second opinion, superior opinion, so that the patient will get the best management or treatment outcome. It saves time, it saves energy, and speaks who you are as a physiotherapist. You monitor the progress of the patient. So at the end, what are the challenges or limitations of musculoskeletal imaging? Despite all its limitation, of all its advantages, it has limitations. And what are the limitations? Requiring you to approach images objectively without bias and with all optimism requires time and competence. So expertise is very essential, and that underscores, as I have said earlier, that underscores one of the importance of this engagement, where we update ourselves, we learn further, and we practice, not just use this session and then we keep it. Constant practice makes perfection. And really, you'll be happy when your patient appreciates you that he has recovered on the shortest possible time. So you can only be achieving those results if you give your patients the ideal team, okay, and you also strive to develop yourself. Of course, never insist on making radiological images on things you can't see. I said it's only when we can see that we can now report, but you can only see if those images are of diagnostic value. All right, so some of these conditions are not normally easily appreciated. So when you practice, you now begin to develop competence and even derive the differentials or the variability or the apparent forms to which each particular condition manifests. We should also consider cost when you are requesting for the radiological examination. The modalities that are safer and that give the best results are excessively expensive. So let's consider that. And modalities that are cheaper and can answer patients' condition, let's prioritize them, okay? Looking at justification, okay, and optimizing cost, especially when the benefit of that examination outweighs the potential risk. Despite these three limitations, MSK is invaluable for you, for us in management of musculoskeletal conditions, because there are conditions that are reoccurring. So to conclude, understanding these principles are essential for you, physiotherapists. Communication is very essential. You need to have the knowledge for interpreting images, for you to integrate it with the information for your patient management to decide the treatment plan and therefore get the best outcome. So anatomy, you don't play with it. Rehearsal, you don't play with it. Knowledge and the best approach, systematic approach to radiological images, knowing the advantages and limitations of each of these options, knowing the common signs of these conditions, marrying it, developing a ideal protocol for approaching them, and then guiding you to do the best, institute the best treatment regimen will be the surest way in order to give our patients, okay, the best. So thank you very much for your time. Thank you for listening to me. We'll just expect questions before I leave. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you. Thank you very much.
President,
The money must be complete, though.
Sir. Hello, sir. I have a question, sir.
Please go ahead.
Thank you, sir, for this very wonderful presentation, sir. We really appreciate, and it will add a value to our clinical practice. Thank you so much, sir. So my question goes to now in this era, times to confirm or to rule out the post in a patient.
Please, I'm having, your network is breaking. To save time, can you write it on the chat box so that I think the moderator will read out? Because your network, okay. I am getting you in pieces.
Okay, sir.
I believe it's your network.
Hello, sir. Can you hear me now?
Yeah, I can hear you now. If it's okay.
Now let me go straight. So, what are the clinical, apart from the clinical signs we see in our examination? in case that a patient present with the sign for cauda equina, which is a red plaque. Is there any pictures that we can see in an MRI to confirm that at our level? I know it is at expert level, but at our level, if we look at the MRI, is there anything that we can see to suspect apart from the clinical sign and symptoms patient presented with? Thank you, sir.
Okay. Usually that is except when we have obvious morphological damage to the spinal cord that can be picked on MRI. All right. Without it, nobody can close his eye and say this is a cauda equina syndrome. Okay. Except when the lumbar plexus, there is evidence of damage to them. Could be as a result of trauma, could be as a result of mass, okay, arising from the lumbar or arising from spinal canal, indenting it, okay, closing the lumbar canal. Then we now say we can see this deformity within the lumbar plexus, which could had led to the development of cauda equina. Okay, so usually requesting patients for MRI on account of suspected cauda equina is to assess the morphology of the lumbar plexus of nerves. If there's any gross that you can see with the naked eye on MRI images, you can now derive that it was caused as a result of this. But without that, you can't rule out. You can usually have an MRI report that says normal lumbar, whereas you have a clinical sign of a cauda equina syndrome. Did you get me?
Thank you, sir. Thank you, sir.
Thank you very much.
So much.
Any other question, please?
Yeah, hello, sir.
Yes, thank you. Yes.
Yeah, thank you for that presentation. I want to just ask before I join. I think you have already
Mr. Efan, your network is also bad.
Oh, can you hear me now?
Okay, much better.
Okay, I said before I joined, I think we already done with shoulder pathology.
I did shoulder.
Yes, shoulder.
Yes.
Before I joined, you are done with that. I don't know just one. You can just give another one.
You don't know?
I'm asking, can you just summarize? Before I joined, you already done with that. Before I joined.
Okay, can I just summarize it?
Yes, sir. Just what you said there.
All right, so shoulder usually the common pathology involving the shoulder. It could have dislocation, it could have subluxation, but soft tissue is usually the what's it called, tendon tear of the supraspinatus rotator cuff. Okay, and then I said MRI is ideal candidate for assessing that, and when we assess it on a coronal view here, not a sagittal view. Coronal view, all right? And then I gave the clue that it's on T2 weighted, since if there is any tear, we expect to have some significant production of fluid. That fluid is a marker that there is injury inside on the shoulder joint. So marked presence of fluid, absence of the tendon connecting the supraspinatus to the supraspinatus tendon, attachment is a marker that say, okay, this is a issue involving the shoulder joint, and you marry it with the clinical sign. Or even we can see the tendon, but then the patient is in severe pain. I will now say the tendon is still attached, but the patient is still complaining with what's it called of pain. I will now say there's either tear or there's a loss of laxity as a result of pain, and it will now give you clear on what kind of management treatment to institute. Ifeanyi.
Okay, all right. Yeah, thank you so much. Thank you so much.
Right. Somebody in the question asked when is T1 weighted image useful in MRI? That's a very an oversight for me. I didn't say it. MRI T1 weighted image for. So basically T1 weighted image, because usually to say T2 is for fluid pathology assessment. Sorry, T2 is for pathology assessment. Usually T1 is for anatomy assessment. So for you to assess the normal anatomical structures, you assess it with T1. For pathological structures, you can assess it for T2. However, that pathological area, you can also acquire to see it on T1. Okay, so T1 is simply a background morphological assessment image format. All right, gives you like a negative view of an area. T2 gives you a positive view with pathological, highlighting pathological structures. All right, so T1 mostly, if you want to assess anatomical normal structures, T1. If you want to assess pathological structure, T2. But you can still use T1 to assess pathological structure, but it will be low yielded. The information harness in T1 is lower. Why? Because T1 fluid is dark, and you want to pick more fluid, or you want the image to show you more areas that is fluid, because more areas that have fluid have more tendency to those areas that have pathology. You understand? But in T1, of course, normal area, fluid is fluid, as dark as dark. All right? So that is it. Somebody, all right, thank you. Apart from imaging, how will you know someone has a subluxation of the shoulder? I think that is your question. For me, whenever I had there is a suspected subluxation, is to go and do plain X-ray to confirm. In my language, some people understand. I say ganiya koiji. Seeing is believing. Okay. All right. So Miss, I don't know, Miss or Miss Ekene Oguneye. All right. I hope I've answered you.
I have a question, sir.
Thank you. Hello, sorry, please. The batteries for the facilitator runs down, so he said I should apologize on his behalf. The battery of his computer. So we are sorry about that. So we will just have like 5 to 10 minute break. Professor Shokumbi will soon join us and start. Okay. Yes. Professor Shokumbi will take over any moment from now. The slide for this first presentation can be found in the WhatsApp group.
Good morning, everyone. Please just give me a response if you can hear me.
Prof, we can hear you. You are welcome.
Excellent. Thank you, sir. So,
Good morning, sir.
Oh, good morning.
Good morning, sir.
Good morning. Nice
Good
to
morning,
be
sir.
here. Good morning. Nice to be here with you colleagues. Let us rub our minds together on what we can do to further improve our practice, especially in the orthopedic and manual therapy. And I'm talking about no other thing beside radiological imaging. I have like 3 presentations. I hope I'll be able to go through all of them. That's why I especially appeal to the presenter that they will afford me the opportunity to start a little bit earlier. So we can take the first presentation, and after that we can have a break. Then when we come back, we'll have the other 2 presentations. Right? We cannot underestimate the importance of this topic, especially in radiological therapy. I've been in a place before where I was practicing, a state in this country, in a teaching hospital, and at a point, my colleagues were requesting for radiological investigations. And the CMAC of that teaching hospital, in annoyance, because the radiologist, he summoned those people that were making that request into his office, because he's not prone to having physiotherapy sending a request. So he summoned them to his office and gave them a very simple imaging to read. He said, you people have been ordering requests. Oh yeah, read this one. Do you know how to read it? And I tell you, it was so embarrassing because none of my colleagues were able to read it until we interfere and we're able to convince them that we can read all those ones that are pertaining to our work. Then they then now give permission for me to be ordering and not any other person. But what I do is to ask my colleague to order and put my name so that the work can still go on. But what I'm trying to say is that if this colleague have been able to read, maybe would have been able to save ourselves from that seemingly embarrassing situation. So when we're teaching this topic, it's not as if we want to take over the responsibility of the radiologist, but we need to know everything about the cases that we manage. Anyways, let me not waste much of the time because we are so time limited. Let's go into the slide. The first thing we'll be discussing is the learning objective. What are the learning objectives? It's my sincere wish that at the end of this course, participants will become familiar with various medical imaging modalities. We'll be able to demonstrate a very good understanding of which one of them and the advantage and disadvantage of at least those modalities that we commonly encountered in orthopedic practice. And then we'll be able to recommend to our patients not just the correct modality, but the view that will give us the kind of thing that we want. And at the end of the day, we'll have a better understanding of radiographic imaging. And then when we have a better understanding, we'll be able to integrate diagnostic imaging into proper physiotherapy practice. Okay, so these are general learning objectives. I still have specific objectives. What are the specific objectives for this presentation? You know, now physiotherapists have been fighting battle as first practitioner, and I think we have gained it, even though it's to different extent in different countries. But as a first practice practitioner or a private physiotherapist or a physiotherapist within primary care, the responsibility of diagnosis, treatment, prognosis, and research lies on you. If you are in primary care, you are in private practice, you can't rely, you might not see a radiologist that will be able to read an image for you. And if the patient doesn't have a report, sometimes the report is not even very accurate. And if there's no such report, then how do you manage your patient? So the specific objective is to enhance our clinical readiness and our clinical skill as a first contact MSK physiotherapy, working with the primary care and private practitioners, so that we'll be able to use radiological investigation as part of our role in order to make diagnosis, treatment, prognosis, and of course, in research purpose. All right, so that's this plan to the specific objective in musculoskeletal physiotherapy practice, not too different from the one that I stated above. Now, in MSK physiotherapy, there are different things we use radiological imaging for. We use it for diagnosis, just like, you know, patient will come with this and that, and we have to be able to diagnose very well with what they have brought and plan our treatments. I'll give you a very good example. If a patient comes with MRI of the lumbar spine, a low back pain patient, come with MRI of lumbar spine, and is showing posterior-central disc protrusion. The disc has herniated, and the disc is going posterior-central, all right? There could be posterior-central disc herniation, there could be posterior-lateral. And the approach to management of these two cases, even in manual therapy, they are different. If you use the wrong one, the pain will aggravate, and patient will think you don't know what you are doing. So you see, we need it for diagnosis. We need it to plan our treatments. And we can follow up on radiological imaging in order to be able to deduce the prognosis. So we need it for all these reasons. And we also need it for research. Gone are the days when physiotherapists don't touch diagnostic ultrasound for treatments or for research. Now we use it for treatments.
Madam.
Whereby when we're treating, please turn your microphone, keep your
Madam.
microphone. I can hear somebody speaking, calling madam there. Please mute your microphone.
Madam with banana.
Please, a colleague calling madam with banana, please mute your microphone so that other people will be able to hear us very well. Thank you very much. Thank you. I said these days, we also use it for treatment. You might be treating a patient, for example, in core stability exercises, and you use diagnostic ultrasound on the multifidus muscles, as you can see on this diagram. So the patient will be seeing how the thickness in their multifidus is changing. And because they are seeing it, they will be able to put in their best effort. Putting in best effort will translate into better clinical outcomes. So, and we also do research. I've just run a research with one of my PhD students whereby we find out the effect of core stability exercises combined with audio, combined with physio biofeedback using diagnostic ultrasound, the real-time ultrasound imaging. And we're able to get that doing it with real-sound ultrasound imaging provide a better incentives that leads to better recovery. So you see now, gone are the days when physiotherapy don't touch diagnostic ultrasound. All right. So we use it for treatment. We use it for research now. Now the relevance of this topic also, you find it in several countries, you know, in Europe and Australia, physiotherapists there do order for imaging and they interpret imaging. It's a common practice there. And for many years now, the military physiotherapists in the US, they directly refer patients for imaging study. And now it has become a practice for accreditation. Before any facilities could be accredited in the United States, they must have diagnostic imaging facilities. We have not gotten there yet. MRTB has not made it to be so, but we will get there. All these things we're talking about are doable, and we are doing our best to entrench the same standard practice abroad in our dear country, Nigeria. So this also emphasizes some relevance, why we need to have this knowledge. So without wasting much of the time, let me just go to the imaging modalities. You know, there are many imaging modalities, yes, but you'll also agree with me that the one that's come across our way in musculoskeletal physiotherapy more than other is the X-ray and MRI. So majority of my presentation today will be based on those two modalities, but we still have other ones like ultrasound scan and the rest of them. But we're going to focus majorly on X-ray and MRI because those are the ones that we encounter more. If we want to dwell on others, believe me, sincerely, 1 week will not be enough for me to handle this topic. So I have to narrow down in terms of modalities to the one that we commonly encountered. I have to narrow down to giving more details on joints that we more commonly encounter than those ones that we rarely encounter. Okay. So in order to meet up with the time and derive maximum benefits from this presentation. So we're going to go to X-ray first, all right, or radiography. Radiography refers to the use of X-ray to view uniformly composed material. And you know our body is made up of non-uniformly composed material. The substance in the bone is different from substance in the soft tissue. Okay, the substance from one soft tissue is also different from substance in the other soft tissues. That's why you find X-ray very useful, all right, to view non-uniformly composed materials. In medical field, you know, its use extends to both medical and industrial. But in the medical field, we can use X-ray to diagnose. We use it to treat. Yeah, we use it to treat cancerous cells or abnormal growth within normal tissues, and we use it to diagnose, and we use it to record performances of internal organs, right? Then whereby we'll be able to detect whether there's any foreign objects in the body or so before surgery is also carried out. But one conception I quickly want to clarify is the conception of X-ray. You know, many a times in our practice, you will say to your colleague, please give me the X-ray of the shoulder, let me look at it. That is actually a very wrong word to say. X-ray is not the film they are giving you because X-ray is an electromagnetic radiation. Nobody can even hold it. So if you say, give me X-ray of the shoulder, you are saying a wrong thing. You rather say, give me the X-ray films or the plain films or the radiographs rather than saying, give me the X-ray. So you can see in this diagram where my cursor is, that is the X-ray machine. And this one is X-ray film, all right? Not the X-ray itself. Thank you very much. Now, let's quickly look into how X-ray machine produce X-ray because
please, why not make this in use the full screen?
Right. I was thinking, thank you. Let's try it. Okay, is it better now, doctor?
Yes, yeah.
Oh,
It's
thank
okay.
thank you very much. Okay, now let's quickly look into how the X-ray machine itself produces the X-ray. You know, a total knowledge is better so that we know where we're coming from and then we know where we're going through, right? From basic knowledge of physics, you see a filament on the diagram on the left-hand side. On the lower part, you see the filament. Filament is negatively charged cathode, emitting electrons, all right? Then there's a positively charged anode that is rotating in the X-ray machine. That's the big one with arrows surrounding it. You can see that, the curved arrows. So as the electron hits the anode of tungsten, the anode is usually made up of heavy metal tungsten. So as the electron hits the tungsten, there will be energy release. And the energy that is released is called photons. Those are the one that looks like wave going downward. And that is what constitutes the X-ray. Do you understand? So if a body is now placed between this X-ray and a plate, the X-ray will hit different tissues in our body, causing ionization. If the X-ray hit this tissue with neutral number of electrons, it will knock off some electron in some of the tissue to cause positive and negative ions. But apart from causing ionization, it will also release more photons. It will release more photons. So the more the photons release will determine how the object will look at on the screen. If a tissue in the body is not good in absorbing the photons, all right, that is, it reflects the photons, then more photons will be released onto the film, and that object will look white, for example, bone. But if the tissue is good at absorbing photons, so all the X-ray photons will be absorbed and the dark shadow will be casted on the film. All right. So that's just a little background into how the X-ray itself is produced. Now, quickly want to look at the use again. So if we go to industrial use, you know, it is used, medical field is also industrial. And it is used in industrial workplaces for security purpose. For example, if you want to pass through the airport, you pass through a red light at the entrance to check whether you're carrying a metal or not. Those are X-ray being put to use. X-ray is being used as scanners in different scanning machines and all that. All right. And in the hospital, diagnostic and therapeutic purposes is one of the imaging of choice, particularly when we're dealing with bones, isn't it? Like fracture and in dislocation. But beside fracture and dislocation, it's also useful to see tumor, infection, abscess. All right. And it also has therapeutic uses, you know, like in dealing with cancer. If chemotherapy has been given, radiotherapy can also be administered in order to deal with the growth of abnormal cells within our body. So all these are preambles, I believe, that we are already used to. Now we're moving. Just before we request for an X-ray, what are the things that we need to know? You know, we're moving into the main work now. So we're focusing on X-ray and fractures now. We're going to move to other parts later. But just before we request for an X-ray, what are the points that we have to bear in mind? Number one, don't request for one view. You have to request for at least 2 views. There are more than 2 views in radiography. So depending on the part of the body you are dealing with, some even have up to 7 or 8 views. I hope my colleagues that present in the morning would have made mention of that. But the 2 most common views we are used to is the AP and lateral views. So never request for 1 views when you are requesting for an X-ray. At least you will request for AP and lateral views. All right. There is this saying that 1 view is as worse as no view at all. Because when you request for 2 views, you'll be able to see all the relevant area that you are supposed to see. You are going to see an illustration of that very soon. The other point is that the X-ray requisition that you are sending must specify the area of the pathology. All right. So you want to write request X-ray of the neck of femur, AP and lateral. That's a standard request. Than just to write X-ray lower limb. Where's the area of pathology? So it must specify the area of pathology. The third point, as far as pelvis is concerned, the convention is that you make a request for bilateral pelvic or hip injury so that you can compare one side with the other. But people are still taking imaging of one side. Some radiographers still do that. But the convention is that we take and request for the X-ray of both pelvics, okay? So we're looking at what to do just before we make a request for X-ray. Then the other point, just before we make a request, is that I think I've said that at least two views, that is AP and lateral. Now, for some part of the body, like the hand and finger, we find that our oblique view is also very good. We are going to see some of these things in our presentation. We just keep it in mind so that when we have to request, we will give them a very good surprise. That physiotherapists are also, very conversant with the areas that we manage. Not that we want to become a radiographer, but we just have to demonstrate that we have a good knowledge of what we're doing. Then the joints above and the joint below must be captured in a very good X-ray. So the very first thing you do when you receive an X-ray is to look for the appropriateness of that X-ray. If a radiographer take X-ray of metacarpophalange joint for me, this is metacarpophalange joint, and I can't see the proximal phalanx and I can't see the wrist joint, then it's not a good view, because the area of injury should be in the middle. The X-ray should capture the joints above and the one below the area of request. These are the things we have to bear in mind just before we request for an X-ray, okay? Now, which part of the body could be X-ray? Virtually any part of the body could be X-ray. They carried different risk ratio, but there's no part of human body that cannot be X-ray for medical reasons, if X-ray is the best modality to handle that part of the body. All right? Now, we're moving on. We're going to look at the standard views of X-ray. What are some of the standard views of the X-ray? And you know what? We're going to make a start with shoulder joint. Then later we'll go to elbow. Then we'll look at the forearm and the wrist and fingers. Then we'll go to lower limbs. Then we'll go to the spine. Okay. Then we'll end up our discussion today with MRI of the spine. Okay. All right. So let's go. Standard view. Now there could be anterior posterior view. Yes. You know what is meant by that. In anterior posterior view, practically the patient will stand facing the X-ray and backing the film. All right. So the X-ray will be hitting the anterior part of the body and the image will be producing on the film kept in the posterior part of the body. That's why it's called anterior posterior. You know, I've said it before, the X-ray will hit all the tissues there. Soft tissue, specifically, they like to absorb X-ray. So they release less photon and they appear dark, all right, or gray. But bones will not do that. Bone will reflect, so it produces more photons and it appear whitish on the film. But we're coming to details of this one very soon. So that's anterior posterior view. X-ray is coming from the front and the image is casted at the back. We could also have posterior anterior view. All right. So in posterior anterior view, the patient is backing the source of the X-ray and the film is casted on the front part of the body. Okay, so that's a diagram of the posterior anterior view. All right. Then we could have lateral view. For example, lateral view X-ray of the elbow. The X-ray beam is exposed from the lateral part of the body and the image is casted on the opposite side to the direction where the view is coming. So we've talked about anterior, posterior, posterior, anterior, and lateral view. You know, just like I said, there are some other parts of the body that have up to 8 different views for different reasons. I will be discussing some of these things as we'll get there. General indications. X-ray have general indication in orthopedic or musculoskeletal physiotherapy, as you know. Joint fracture dislocation, degenerative changes, post-surgical rehabilitation. Before we rehabilitate post-surgery, it's a good idea to always see X-ray. After every trauma, if there's any history of trauma, whether it involves road traffic accident or a fall, if a patient comes to our clinic for rehabilitation, we should ask for an X-ray that is not older than 3 months. When we're suspecting infection, like osteomyelitis of the bone or vertebral osteomyelitis, tumors and infection, we can ask for X-ray. Postural and structural abnormalities, that is our own area in orthopedic and musculoskeletal. The neuro guys, the neurophysiotherapy will also require it for skull fractures, and the cardio just need it as much as the ortho guys will need it. But X-ray have limitation, you know. It might not be able to give us full detail of the soft tissue dysfunction. We might need to back it up with MRI in order to be sure, or take different views sometimes, okay? Then X-ray can also not give functional or dynamic information, you know, like what will be the changes in the appearance of the lumbar spine when transiting from flexion to extension, you know, looking at the joint space, how can we use that now? X-ray might not be able to provide all this dynamic information. It's a static imaging that we get. But I think there's improvements on that dynamic bit because national, orthopedic hospital in Dalakano, they now produce dynamic X-ray, right? So I think there's a bit of improvement in that aspect, okay? Now, just before, you know what we said before is just before you ordered, isn't it? Now, we are going to discuss how to read this X-ray, but just before you read the X-ray, what determines appropriateness of that X-ray just before you read it? Probably if those things, if these features we are going to discuss are not present in an X-ray, you should just drop it, all right? And ask for a repeat X-ray. Number one is patient detail. You have to look at the X-ray, look out for the patient detail before you read it, confirm the patient name, the full name of the patient must be there. And not just the full name, the date of birth should be there. If there's an hospital number, it should be there, like for inpatient. But at least if that one is not there, the full name and the date of birth should be there so that we'll be sure that we are not reading the X-ray of Peter and we are giving the interpretation to John. We can't be overconfident in this area. Look out for the patient detail, please. That is very important just before we interpret. The other detail we have to look out for is the film details, okay? Apart from patient details, we have to look for film details. What do I mean by the film details? We have to confirm the details of the radiograph. Which date was this radiograph given? And which area of the body is scanned? All right, and is it adequate? I've discussed something about adequacy of radiography. For it to be adequate, there's got to be at least 2 views. For it to be adequate, the joint above and the joint below the area of pathology must be reflected. If any X-ray film you want to read lack any of these 2 major features, that's the patient detail and film detail, you could as well ask for a repeat imaging, all right? So just before we interpret again, how do we orient? What's the orientation of the film? You know, just imagine somebody sitting in front of you. You will realize that the left hand of that person is where your own right hand is, isn't it? So when you are holding the imaging, you will hold the left part on your right hand so that you will not be confused. And using a view box is the best practice. Don't always put the film near the light in your office or bulb in your office. Get a view box. You'll be able to read better without making avoidable mistake. Okay. Now we're going into reading and interpretation. There are different mnemonics that we use to interpret X-rays. There's ABCS, there's ABD, but I think the most popular so far is the ABCS, where A stands for adequacy and alignment, B stands for bones, C stands for cortex and cartilage, and S stands for soft tissues. So you look at this thing one after the other, and then you report your findings, and that will constitute the findings for that radiograph. ABCS, please, don't let us forget. Adequacy, alignment, bones, cartilage, and soft tissues. All right. Now, adequacy. What do we mean by adequacy? Again, we are repeating it again. You see, it keeps coming again and again. What makes an X-ray film to be adequate? There must be at least a minimum of 2 views, AP and lateral views. the joints above and the joint below the area of pathology must be seen. Do you understand? There's one hand up. Abbas Sufian, I've just seen your hand up. Do you have a question? Abbas Sufian, I see your hands up. If you have a question, please leave it a bit.
I think the hand has been up for long, bro. It was
okay. If there's no question, you can drop the hand or I will just ignore it. But if you have a question, please keep it till the end because time is not our friend in this presentation. I will not be able to stop and take questions in the middle. Otherwise, we would not be able to accomplish our mission. All right. So adequacy of the X-ray, there must be minimum of 2 views. The joints above and the joint below the area of pathology, as well as the area of pathology, must be seen. If you don't see this one, please ask the patient to go and repeat the X-ray and put that note for the radiographer or the radiologist to take notes. I don't think a radiologist will make that mistake anyway, but you never know. Now, you know, A, what do we say is A? A is alignments. Look for the alignment of the radiographs. That's very easy. Just trace the outer margins of the X-ray, like from the lower part to the lateral to the medial. Is there any break in the continuity of the bone? Is there any break in the congruency of the joints? That is what is referred to as alignments. Okay, but we're using A here for what? Alignment and joint space. Let's talk about alignment first. Like this upper diagram you are seeing there, you see automatically that there's a break in alignment in the continuity of the bone. And what do we call that? Oh, sorry, I'm sorry, I've pressed a wrong button now. Let me go back to where I am. I want to move something and then I press something else. So A is alignment. And what do we have in the alignment? You see there's a break in the alignment. Definitely, you know, there is a fracture. That's a fracture. We're going to talk about the language of fracture in a short while. When you look at the lower diagram, you'll also see that the alignment of the vertebrae is not smooth. Yes, you know, when the bones in the lumbar spine is almost like a rectangle, when the rectangular shape change to triangular shape, that's a transition from lumbar to sacrum. So the first one that look like a triangle or a prism is X1. But there should be no shifting in the continuity. It should be perfect. So what you are seeing in the lower diagram here, you see that L5 has shifted forward. And that's as a term that we're going to discuss in a short while. So we can see from alignment that something is wrong with the first diagram, which is fracture. Something is wrong with the lower diagram, which is dislocation. The L5 vertebrae has actually moved out of the place where it should be. We're going to talk about this more in a short while. All right. Can you still see my diagram? Because, okay, yes, I've been able to control my system now. Sometimes my system misbehaves. So this is where we are. You know, that's A. The B aspect is the bone. B stands for bone texture. And we're going to keep repeating these ABCs throughout our presentation today. All right. The B is looking at the bone texture. And what do we look in the bone textures? Look at the margin of the bone. Can you see, if you follow my cursor, I don't know if you can see my cursor, you see the margin of the bone. Every margin of the bone have an outer part and inner part. The inner part is called the trabeculae, and the outer part is called the cortex. So you carefully look at the outer part. Is there a disruption? That's very similar to what we do under alignment. But you now come and look at the inner lining of the bone. That's the great bone texture. Does it continue? Is there a change in color? Is there a disruption within the cavity of the bone that you'll be able to read and interpret? So under bone texture, we pay attention not only to the cortex, which is the outer part of the bone, we also look at the trabeculae. If you look at the diagram I'm projecting, if you look at the image on the right-hand side, the one on the right-hand side, you see that you cannot see the cortex continue with one another. And if you look at the trabeculae is appearing sclerotic and distorted. That could have been a bone that have suffered from infection, like osteomyelitis or something like that. But that's not what we are discussing now. We're just saying that, number one, when you hold an X-ray, look at the alignments. make your findings. Number 2, look at the bone textures by considering the trabeculae, the inner part, and the cortex, the cortical part, which is the outer part of the bone. All right. So yes, we are still on the bone texture. Let's have a look at this diagram. What can you see from here? We're going to have a series of what do you see, and then we'll be explaining. You can see from this diagram I projected that all is not well with the trabeculae. Yes, this is not how a proper trabeculae should look like, and this is not how a proper trabeculae. Even at the point where the arrow is pointing, the cortex is inflated, isn't it? You can see the cortex is inflated, and the trabeculae is not proper. The trabeculae is not proper. So these are signs of infection. All right, but we're getting there very soon. So look at the alignment, look at the bone, and we're considering the bone, consider the cortex, consider the trabeculae. All right, we're going to have a look at more of this thing. Now, C could stand for cartilage and cortices. Okay, cortices is still the outer part of the bone, which we have looked at under alignment. So if you are taking C to be cortices, take a second look at the outer margin of the bone and see whether you can still see a crack or a fracture. All right. Now it could stand for the cartilage as well. Now, what do we say under cartilage? Can we really see cartilage with X-ray? No, cartilage is not visible on X-ray. If you consider the diagram I'm showing now, you see cartilage well represented between the bones in the image on the left-hand side. You cannot see cartilage the way it looks on X-ray. What you will see, because cartilage absorb X-ray, like I said earlier on, those structures that absorb X-ray will produce less photons and they will cast a dark shadow on the film. So you see that dark area on the image by the right-hand side, that dark area on the image by right-hand side represents the cartilage, all right? So when we say cartilage, you'll not be able to see cartilage. Cartilage will be represented by joint space on X-ray. So you take the joint space to be the cartilage. If the cartilage has been wear off as a result of osteoarthritis, there will be narrowing of the joint space. If the cartilage is still intact, you're going to see a normal joint space. So you check for A, you check for B, you check for C, cortex, and cartilage. Okay, we don't talk more about this thing, but this is just laying the foundation, isn't it? Now, what can we see about the joint space? Sometimes the joint space can become wider than normal, and sometimes the joint space become narrower than normal. What are those situations that could make a joint space to be wider than normal? It could happen if there's a congenital malformation that leads to, like epiphyseal dysfunction that leads to the joint space being widening. If there's fracture, the joint space could become wider. If the ligaments holding the bone together has been severed, then the bone will be able to move separately in different directions and the joint space could be widening. But we don't commonly encounter this one, all right? Like the diagram you are seeing on the diagram is the diagram of epiphyseal dysplasia. That is abnormality with bone formation. You can see that the joint space here, if you are used to seeing X-ray of the knee, this is abnormally wide, isn't it? The normal tibial spike is not there. Look at the condyles of the femur. Instead of it appearing curved, it's more or less taking a flat structure. So this is a widened joint space. I would say joint space represents cartilage. So if the joint space is large, it could be as a result of what? Bony deformity, accumulation of fluid, or joint edema. It could be as a result of fracture. It could also be as a result of ligamentous injury. It could be as a result of ligamentous injury. Okay? All right. So let's go on. So we are on ABCX. All right? We're still on C. Let's have a look at this diagram again. Figure 1 and figure 2. You'll further appreciate what I'm talking about. Figure 1 is showing a normal joint space in the knee joint. We're still coming to analyze this one in greater detail when we get to the knee joint. So you can see the joint space. That indicates that the cartilage is intact. If you look at figure 2, you see that the joint space is narrowed. on the medial aspect of the femur. The medial tibiofemoral joint space is narrower than the lateral tibiofemoral joint space. How do I know the lateral from the medial? Look for the fibula. You can see the fibula down there, that small bone underneath. And fibula is always on the lateral aspect. So you can always make a distinction between the lateral and the medial aspect. So don't forget, we're still on C, which is talking about cartilage and joint space. And we're still carrying that mission of looking at the joint space. Look carefully. What I'm saying on this slide is that you should look carefully at the joint space, all right, and identify the following. Is there a joint space narrowing, GXN? Like you can see on the diagram above, the medial tibiofemoral joint space is narrower than the lateral tibiofemoral joint space. So there's joint space narrowing there. Now look at the cartilage area. That's very close to that dark area. Is there anything appearing white or sclerosis? Is there anything like sclerosis there? If you get something like that, you should take note of it. Look at the margin of the bone here. Is there a little bone spores or an outgrowth, which we call osteophytes? All right. Is there whitening or sclerosis at the joint space where the cartilage previously occupied? And within the whitish sclerosis, do you find some dark spots? Those dark spots are called subchondral cysts. And all these things are signs of osteoarthritis or degenerative changes. When there's joint space narrowing, when there's sclerosis of the joint margin, when there's subchondral sclerosis, these are all signs of osteoarthritis. If you look at that diagram below, that's for the spine, right? You're supposed to see some joint space between those vertebrae, but they are no longer there. The joint space have collapsed. We're going to talk more about this, trust me, in our subsequent diagram. Just have a quick look. We're just talking in terms of joint space now. The joint space is gone. Osteophyte is formed at the margin of almost all the vertebrae. So this is a sign that something is wrong with the joint space and probably osteoarthritis. But don't worry about diagnosis. We are coming very soon to diagnosis. Look at joint space issue even on this diagram. See, the joint space is not the same thing on both sides of the joint. So that is joint space illustrated here. And if you look at this also, you're going to see the joint space issue. In most of osteoarthritis of the knee, it is the medial joint space that is more affected in most cases. But there are some few cases like the one you are seeing in this diagram whereby the lateral joint space is affected. I say, how do I know it is lateral? Because fibula is there. So it must be the lateral. And you can see because the joint space is narrowed, the femur has bent outwardly, and that has created increase in the Q angle. Q angle is the angle formed between the perpendicular through the middle of the patella and a straight line from anterior superior iliac spine to the mid part of the tibia. So because of that narrow joint space, the Q angle has increased, and that will predispose the patient to, pain and symptoms affecting the knee, simply put. Okay, so we're still on joint space, guys. Look at joint space issue also in this knee joint. Can you see the knee joint? Look at the right knee joint. The right knee joint, the joint space is very obvious, even though there are a little bit of sclerosis at the acetabular margin, but the joint space is very obvious. Look at the left hip joint, the joint space is gone. And there's sclerosis, that is those whitening thing. Look at osteophytes at the margin of the acetabulum. So all these are classical signs of osteoarthritis. Don't worry, we are coming to it very soon. We're just laying a background or stating introduction. So we've seen A, B, C. A, alignment and appropriateness. B is the bone structure. C could be the cortex and cartilage, which also lead us to joint space. Now, soft tissue. The S aspect of the ABCS is soft tissue. Just like the cartilage, we cannot see soft tissue with X-ray. They absorb X-ray. So they cast dark shadows or gray shadows, all right? But sometimes, if soft tissue is involved in trauma, the way it will appear on the X-rays to look like fluid. Okay, it will appear as fluid on the X-ray. And sometimes there's imminent fracture, and the fracture will not be obvious on the X-ray, but you will see fluid surrounding the joint. And that kind of fracture is what is called occult fracture, hidden fracture. But you will see the swelling and the fluid. Let me just illustrate a few of these to you. Now, let's take a good look at this image. There's some advertisement blocking my my tools. Unsolicited advertisements. Okay, I've been able to take it off. So you can see this diagram better, can't you guys? Now you see the whole area the arrow is pointing to is a bit light grayish in color. That is fluid though. It's due to pressure or swelling, maybe a proceeding from inflammation or infection. If you look very carefully, at where the fluid are pointing, you see something dark that seems to be displaced anteriorly and posteriorly, isn't it? Those are soft tissues that the fluid has displaced. And that's showing the enormosity of the fluid that is produced during that injury. So this could give anybody reading the X-ray an impression that there could be fracture that is not very obvious on the X-ray. And that's what we call occult fracture. But generally, fluid in the joints or soft tissue will appear gray. If there's inflammation, it will look light grayish in color. So that's the ABCS interpretation. Let's look out for more fluid. Okay, again, this is also like the last image I projected. You can see the fluid around displacing a fat part, both anteriorly and posteriorly, and that's an indication of fluid pushing that fat. It could also be an indication that a fracture has taken place, but it's not very obvious on X-ray, so we call it sign of occult fracture. So we say that is a sign of occult fracture. Okay, let's look at fluid again. Let's look at this joint now. See, what do we see in this joint? Look at the ankle joint, all right? You can see the ankle joint. You can see the calcaneum here, although calcaneum is fractured. And as a result of fractured calcaneum, you can see the yellow arrow looking light grayish in color. That is fluid. You can see the white arrow again, light grayish area is referring to the presence of fluid. All right, soft tissues are dark, but fluid appears light grayish in color. So sometimes you don't see the fracture, you see massive swelling in the X-ray. You have to be careful about managing that patient because there could be unsuspected fracture. Maybe you should ask for another view or you should request for MRI, which will show it better anytime you suspect that there is accumulation of fluid around a joint. Even the upper diagram is illustrating fluid. You can see where the black arrows are pointing to in that upper diagram. And obviously, there is intercondylar fracture of the femur. You can see that the condyles of the fracture of the femur, they are out. So it's that fracture that produced that massive fluid that displaced patella even more superiorly. And you can see the fluid right under the patella. So guys, what I'm trying to say is that when you see the light grayish color like this, suspect fluid. And if you don't see any fracture, maybe you should order for a different view, or you ask the patient to get MRI. If you are not making progress with the treatment, there could be a hidden fracture somewhere that the X-ray is not able to pick. Okay. All right. We are moving now. Let's start analysis. Let's look at this short diagram before we go to other parts of the body. What did you see? That's the question that I asked. I said, what did you see? I'm sure you know this is lumbar going to sacrum and the pelvis, isn't it? You're going to notice that the vertebrae are fused together, isn't it? The margin of the vertebrae are fused together. You can't see any joint space at all. So this is ankylosis. It's fusion. There's fusion of the joint space. You can see the osteophyte at the margin. The osteophyte at the margin. The impression with this diagram is that the annulus fibrosus, you know, the annulus fibrosus is the outer part of the intervertebral disc in the joint space. The annulus fibrosus have become calcified, all right? And so it has joined one vertebrae to the other. So you can see that, you can see the rectangular shape of all the vertebrae looking so straight, In a normal radiograph, it should not look so straight like this. So you can see shiny corners, isn't it? You can see shiny corners of the vertebrae. All right, these shiny corners, rectangular shaped vertebrae, ankylosis or loss of joint space are all features of ankylosing spondylitis, which is an inflammatory arthropathy. And you know, it also affects the sacroiliac joint. So if you look at the sacroiliac joint in this diagram, again, you will not see any joint space. So this is a classical view that we can use. This is a classical view that we can use to demonstrate all the features of ABCS, that we have been talking about. Marginal osteophyte is present. The fusion of the osteophytes is what is called syndesmophyte. So we can see the syndesmophyte. Please mute your microphone. I can still hear some voice at the background. Please, it's disturbing. Please mute your microphone. You can speak when you mute your microphone. It will not be disturbing the presentation. But if you keep your microphone on, then I'll be hearing. Some people are still talking at the background. Please keep your microphone silence. All right. So in the diagram, we can see the marginal syndesmophyte. That is what fuse the vertebrae at the margin. We can see the squaring of the vertebrae. We can see the shiny corners. Yes. If you now look carefully at this diagram again, guys, you will see that the interspinous ligament has also been classified. Interspinous ligament is the ligament that bound the spinous process. So if you look at the middle of the diagram, you see that interspinous ligament looking a bit whitish at the center. And if you trace it up now to the side of the rib cage, you see two dark areas of soft tissues. So if you combine those two dark areas of soft tissues with the calcified interspinous ligament, it will give you the appearance of a dagger. So to diagnose ankylosing spondylitis is not hard at all, especially at the chronic stage. Number one, there will be loss of joint space in the SIJ. There will be loss of joint space in the vertebrae. There will be fusion of the vertebrae. There will be syndesmophytes. That's the vertebrae joined together. There will be squaring of the shape of the vertebrae, and there will be interspinous ligament calcification, which will now give a dagger spine. All right. Okay, that's just to illustrate the ABCS. Now, the appearance of the spine in this image is resemble the appearance of a bamboo. If you check out for the bamboo on the left-hand side, you see that one segment of the bamboo is joined to another. It's inseparable, and it goes up like that. So that's why sometimes the image of ankylosing spondylitis is also called a bamboo spine. All right. Now, let's talk about language of fracture. We're going to go to language of fracture, and then we'll look at fracture of some selected parts of the body. What are the language of fracture? All right. We're going to look at that in a short while. When you are trying to describe or report a fracture, all right, maybe in presentations or when you are teaching your junior colleagues, the language of fracture is that you state first whether the fracture is open or closed. That's the first thing you have to state. Then the second thing, the language of fracture, is to mention the anatomic location of the fracture. Is it intratrochanteric fracture? Is it a shaft? Is it the distal shaft? Is it the proximal shaft? But the first thing to state is whether the fracture is open or closed. You state the anatomic location. Then you can state the fracture line. If the fracture is transverse, oblique, spiral, or comminuted, they must follow in that order. First, the communication with the outside, whether it is open or closed. Secondly, the anatomic location. And thirdly, the fracture line. That is how fracture should be reported. So let us now report this fracture together. So I haven't said the language of fracture. How are you going to report this one? All right. Remember, the first thing is communication to the outside. Is this open or closed? It's a closed fracture, isn't it? We don't see the bone piercing through the skin outside the body. So this is a closed. And you remember the second thing is what? The anatomic location. Now, fracture is usually reported. Fracture is usually reported giving preference to the distal part of the distal fragments. So what is the distal fragment here occupying? Like distal 1/3, isn't it? You can say proximal to third and distal 1/3, but the preference is to say distal 1/3. That's the second thing. And what's the third thing? Third thing, the fracture line. And you can see this fracture line is more like oblique. It's not really transverse, it's more like oblique, isn't it? So if we put all these things together, how are we going to report this fracture? We're going to say is what? It's a closed distal 1/3 fracture femur with or oblique fracture line. So that is the language of fracture. Whether it is open or closed, the anatomic location, and then the fracture line. Okay, all right. It's still the same diagram I'm emphasizing here, but we have already reported it. You can see it's still the same thing we're talking about. I just wrote on this slide that the main thing I want you to take from this example is the description of the location. Distal 1/3, open or close, and then the fracture line. Okay, right. Let's look at this now. So you should be able to report this one for us as well. If you look at this structure, what would you say? It's still a closed fracture. There's no indication that the fracture site is communicating with the outside. So we're going to say what? It's a fracture. What's the anatomic location? Mid-shaft, isn't it? Humerus. And what's the fracture line? Transverse. So if we put all this together, we're going to say is what? It's a closed mid-shaft fracture of the humerus with transverse. Or we can say closed mid-shaft transverse fracture of the humerus. Okay, all right. So we're stating the location, we're stating the fracture line, and we're stating the communication with outside in the first instance. Okay, so you're going to see the reading here just the way we have analyzed it. Okay, it's a closed mid-shaft transverse humeral fracture. All right, now let us look at this. What are you going to call this one, guys? Considering those fracture languages that we have reported, it is still closed, though. It's not communicating with outside, so it's still a close. Okay, and it is the surgical neck of the femur that is fractured. All right.
Yeah. Yes.
So we're going to say it's a closed fracture. Is a closed surgical neck fracture of the femur. Simply put, using the fracture language. Okay, so that's how we're going to interpret that. And you can see what we're saying there, okay? It's a closed intratrochanteric, okay? It's intratrochanteric and it's comminuted fracture because we have more than 2 fragments. So it is comminuted fracture, all right? So we take the communication into instance, we take the anatomic location, then we take the fracture line into consideration. Now let us have a look at this. Let us have a look at this diagram. We're still talking about the fracture language. Now, what did we see? You see the, what do they call it? This thing female put on their wrist. You see the wrist bangles there. That underlines the importance of asking patients to remove it because after fracture, there can be swelling and that object will be difficult to remove. But that's not the focus of this presentation. What I want to emphasize in this slide, if you look at the diagram on the left-hand side, there is a fracture of ulnar, isn't it? The distal end of the fracture, the ulnar styloid process is fractured. And we can see that one in the AP view. This is AP view. But when you go to the lateral view, that's the diagram on the right-hand side. You will see the radius too is fractured. All right? You're going to see that the radius is also fractured, which is not very obvious in the AP view. That is why they said we must request for at least 2 views. All right? So these are actually 2 fractures here. There's fracture distal end of radius, and there's fracture ulnar styloid process. Okay. So that's this point emphasizes the importance of asking for multiple views. And you can see the solution here. That's the solution to that diagram. What did you see on that slide? Now let's have a look at this one. We're still talking about fracture language. No fracture here, isn't it? What we have here is dislocation. Is that it? Is that not it? So we know this is taking place in the knee joint. Now, you know, I said that in fracture, preference is given to the distal fragment, even in dislocation. When you want to report dislocation, you will report the movement of the distal bones. So what are we going to call this one? Dislocation of the knee joint with anterior tibiofibular displacements. That's the correct interpretation. We're not going to say posterior displacement of the femur. That is wrong. We're going to say it's dislocation of the knee joint with anterior displacement of the tibia and fibula. So that is fracture and dislocation language, okay? And you see the answer here. The answer to what did you see is on the next slide. Now, this is ankylosing spondylitis again. We have already seen this one before, so don't let us waste time on that. We have already reported all the features you will see to report ankylosing spondylitis, the shiny edges signs, the syndesmophytes, which is characterized with fusion of the vertebrae. The dagger sign is also there. So you can't miss ankylosing spondylitis and the fusion of the sacroiliac joint. Okay. Right. So we want to now discuss the radiographs. Sorry, guys, we'll soon go on break. As soon as I finish this one, I know a lot of you must have been tired sitting down. You know, I'm also an ergonomic physiotherapy. It's not conventional to sit for more than 30 to 45 minutes. But you have to bear with us. As soon as I finish this session, we're going to have a 1 hour break, and then we can come back for the next 2 presentations that we have. All right. So let's focus on the vertebra now, the radiographs, X-ray of the vertebral spine. We have laid the foundation or stayed the preambles. Now, before we go into reading the radiographs of the vertebral spine, let us revise our normal osteology or the anatomy. All right. Clearly, these are the vertebral body. You can see the vertebral body there. You can see the intervertebral disc. And we know the outer part is annulus fibrosus. It has a role to play in the radiographs. For example, in that ankylosing spondylitis, the annulus fibrosus gets calcified. It's the one that joins the vertebrae together to form the syndesmophytes. So we can see the annulus fibrosus. We can see where vertebrae above meet with the vertebrae below, this place. And below and above that, we have intervertebral foramen, where the nerve root exits. I just want us to have a quick revision on this one. And looking at the superior view, of course, we know nucleus pulposus is inside, the annulus is outside, before we go into the radiograph of the spine. Now, you know, we said the most popular format of analyzing is ABCS, isn't it? Let's quickly apply that to the vertebrae. When you're applying that to the vertebrae, there are 4 different lines you will have to look at when you are trying to read the alignment. What happened? Why am I seeing a blank? Okay, it's showing me a blank page. Why now? I want to put it in presentation mode. Oh, and it's showing blank. Okay, it's on show, what do they call it? Film show or showcase design, which I don't like. I would have put it off. So anyways, let me project everything, then we'll talk. So you can see in the spine, there are about 5 lines you'll have to consider when you want to discuss the alignment. The first line is called the anterior prevertebral soft tissue line. It doesn't touch the bone at all. And then the next one, which is the pink one, is the anterior vertebral line. That's the anterior vertebral line. That is touching the anterior margin of the vertebrae. Now, between the prevertebral and the anterior vertebral line, it's just soft tissues. And that's why that area looked dark. You remember what we said? Soft tissue absorb and they cast a dark shadow. Now, between the very pink and the fishy pink line is the posterior vertebral body line. That is where the vertebral body are placed. So you can look in between those lines and see whether that line is maintained or whether one vertebral body has shifted relative to the other. So we can say something is wrong with the alignment. Then the last line you have to look at is the, what can I even call this color? Say, orange color. The orange color is right in front of the lamina. You know, it's the lamina that projects to form the spinous process. So the spinous process is the last gray image you will see posteriorly, but it's the lamina of the body that projects to form the spinous process. So that orange line is called spinolaminar line. That's a line between spinous process and lamina. So you can now look at the alignment of the lamina within that area. If it is fractured, you will know. All right? And that is about where one vertebrae articulates with another one. So if there's any fracture on that line, you will know. Then lastly, you will look at the yellow line, which is the spinous process line. All right? And if there's any shift of the vertebrae, definitely this other line will also be affected, and we can make accurate diagnosis. This is based on alignment. And this is based on having a lateral view of the spine. What if there is AP view? Then we only have two lines to consider. If it is anterior-posterior view, two lateral lines are the one that we have to consider. So that should not be a problem to be able to analyze the alignment in that situation. Now, we are still on alignment, guys. We are still on A for alignment in the vertebral body. Don't forget this. We are discussing vertebral body radiographs now. Look at this alignment, guys. Now, before we go into alignment, let's do a little bit of radiographic anatomy so that everybody will be on the same page. When you take the lateral view and you are looking at the alignment of the lumbar spine, it curves inwardly. And I said they are like rectangle in shape. You can see L3 like a rectangle, L4 like a rectangle, L5 like a rectangle. The first bone that moves inward and is assuming a rather triangular shape is the first sacrum. Do you understand? And that perfect line, anterior vertebral line, should be continuous. It should not be broken. But if you look at this diagram, you see that anterior vertebral line has been broken. Why? Because L5 is not perfectly aligned with X1. L5 is like going forward. You can see the X-ray, while X1 is like going backward. So we can pick that from the alignment. What is this clinical condition called? Ordinarily, you can call it dislocation, but in medical term, we call it spondylolisthesis. This is a listhesis. Listhesis implies dislocation. All right. This one also has a language of interpretation. The language of interpretation of this is to report the displacement of the upper segment, not the lower segment. So in this situation, we are going to say the listhesis has taken place anteriorly because it's the upper segment we are considering. And the upper displacement and the anterior displacement is called anterolisthesis. If the listhesis has if the vertebrae has shifted posteriorly, we're going to say it's posterior dislocation, and we call it retrolisthesis. Do we understand? So this one also has its own language. We're going to talk more about this towards the end of this slide. All right. So we're discussing alignment, isn't it? Let's have a look at the next slide. Okay, doctors, look at this radiograph here, and you'll understand better. Supposing your patient comes to the clinic with low back pain and they presented with a radiograph that look like this, and you look at the posterior vertebral line, you can see that it's not continuous. You can see the last rectangular lumbar vertebrae, that's L5. Then you can see the triangular one below it, that's X1. You see that the posterior vertebral line is not continuous between L4 and L5. So how do we report this? You remember I told you, consider the upper fragment when you are reporting. So we're going to say this anterior displacement of L4 on L5. We're never going to say it is posterior displacement of L5 on L4. That is wrong. So it's going to be anterior displacement of L4 on L5 or anterolisthesis. Do we understand? Now, if you look at the second diagram, we're going to say that is what? You will see that even the posterior vertebral line is not continuous. All right. How do we read this one out? Can you pick X1, the triangular bone? Above X1 is what? L5, L4, L3, L2. So where the problem happened is between L2 and L3. All right. So L2 seems to have moved backward because it's the upper vertebrae that we considered, not the lower vertebrae. So how are we going to interpret the B radiograph? We're going to say is what? Posterior displacement or retrolisthesis of L2 on L3. Okay. All right. Now, Radiographers should not only report listhesis, they should also tell us whether that listhesis is up to the extent that can cause spinal instability. Any listhesis, whether anterior or posterior, that is more than 4 millimeters, is going to cause spinal instability. What do we mean by that? That means if the patient assumes a weight-bearing position or transition from weight-bearing position to another, there's going to be clinical symptoms. All right? That means the spine is no longer stable. For example, if I stand up from sitting, that compression from sitting to standing should not cause me to have pain in my lower limb. But in a situation whereby the listhesis is more than 4 millimeters, the patient will have signs of spinal or clinical instability. So we are very clear with, what's it called? We are very clear with anterolisthesis and posterolisthesis and condition to define it as instability. Now, type of spondylolisthesis, we have already discussed it. I am very conscious of the fact that you are tired and you need to take a break. So we'll act very fast. At least we can come refreshed for the second part. So you still agree with me, this is anterolisthesis of L4 and L5. And this is retrolisthesis of L3 on L4, just like we have described. We have already described this one, so no problem with that. Now, I need your attention here, doctors. I need your attention. I need your attention here. Listhesis are graded. There are two different types. I've said there's anterior and retro. They are also graded as grade 1, grade 2, grade 3, grade 4. When radiologists want to grade listhesis, they will look at the segment below. You know, I said we name it based on the segment above. But when you want to grade it, you look at the segment below. If X1 is the segment below, you will divide that segment below into 4 equal parts. All right? You will now look at how far the segment above has moved relative to that division that you have done. If the segment above has moved to cover only one of the segments from posterior end, you will say that is grade 1. That is, there is 0 to 25% of dislocation. You say that's grade 1 spondylolisthesis or grade 1 anterolisthesis. If the segment above has covered 2 portions of the area you divided into 4, that is covering between 25 to 50, you say it is grade 2 listhesis. If it has covered up to 3 portions, you say that is 50 to 75, that is grade 3 listhesis. If the vertebrae above is completely, if the posterior part of the vertebrae above is completely touching the anterior edge of the vertebrae below, that is 75 to 100, and that is grade 5 spondylolisthesis. And if there's complete separation between the vertebrae above and the vertebrae below, no more contact, that is grade 5. And that is actually called spondyloptosis, not spondylolisthesis again. That is called spondyloptosis. And the clinical implication of this is that when patients come to our clinic and they bring their radiographs and we see listhesis, and somebody is having grade 3, grade 4, you don't have to manage that. It will not respond to physiotherapy, let me tell you the truth. Grade 1 and grade 2 are the ones that mostly respond to physiotherapy intervention. If it's getting to grade 3 or grade 4, there could have even be other problems like compression of the fat, like stenosis. There could even be other problems like compression on the spinal cord. So you don't even want to mess around grade 3 or grade 4. If the patient is having grade 1 and grade 2, then you can try different things like traction, core stability, flexion-based exercises. All those things might be able to help them. They are managed just like a patient having spinal stenosis in the real clinical experience. But that's not the purpose of this discussion anyway. Maybe when we have our presentation, the next presentation, we'll be able to talk more about that. So this is just to enable us to know that it should be graded, and going ahead to manage it depends on the grade. You only manage grade 1 and reluctantly grade 2. Grade 3 and grade 4 should be referred for surgical intervention. Okay? Right, you can see also what I'm trying to say here, the treatment and the prognosis. All right, indication for surgical management of spondylolisthesis. If You know, I said physiotherapy could manage grade 1 and grade 2. But if there is symptomatic grade, even in grade half of what should have been grade 1, that's the vertebrae just shifted slightly. It's not up to grade 1. And you have managed the symptoms for 6 months. There's no improvement. That patient should go for surgery. Don't continue to waste time on that grade 1 or less than grade 1 listhesis. If it has been managed conservatively for 6 months, no improvement, is an indication for surgery. Now, you know, I also said physiotherapy can manage grade 1. But if you have a grade 1 listhesis, this week you are managing it, next week you are managing it, by chance there's no improvement, you now ask the patient to do a repeated radiographs, and you now find that the listhesis has moved from grade 1 to grade 2. That means the listhesis is progressing. Such a patient should go for surgery. Don't waste your time managing that patient again. And you know, I also told you grade 3 and 4 are originally meant for surgery. But a progressive grade 1 should go for surgery. A refractory to conservative care, even if the grade is less than 1, should go for surgery. And if there's instability, the patient should go for surgery. How do I describe instability to you? We can determine if there's spinal instability radiologically. If there's more than 4 millimeter displacement, we can determine it clinically. If the patient stand up and from standing to sitting, pain began to radiate, and abnormal sensation began to radiate, weakness begin to fissures from transiting from one position of weight bearing to another. All these conditions are indication for surgical intervention. Remember, we are still talking about alignment, and we are going ABCS, isn't it? Now look at this one. This will further illustrate what we have been saying about this grade. If you look at this diagram very well, you see that L5 has moved about 25% of the total area of X1. So this is going to be a grade 1 listhesis. Grade 1 anterolisthesis. This is grade 1 anterolisthesis of L5 on X1. And if you look at this one, I want you to tell me what to see. If you look at the diagram on the left-hand side, it's also grade 1 listhesis, isn't it? It hasn't moved more than 25%. But if you look at the diagram on the right-hand side, you see that L4 has moved by up to almost 50%. This could be grade 2 anterolisthesis of L4 on L5, okay? We're still talking about alignments, and I'm trying to caution myself not to talk anything else apart from alignment at this level. Now, if you look at the diagram now, we are done with the A for alignment. I salute you for your endurance. This section will soon come to an end. Please just bear with us. Now, we are done with the alignment. We are moving to the B aspect of the BCS. B is looking at the bone, isn't it? Now, what are the things that we stand to see at the bone? You will look for the bone density. You look for the facet joints. You will look for the vertebral canal where the vertebral artery proceed. All right? And you look for other alignment. That is what you have to look at when you are talking about bone in the spine. You look at the bone in the spine are uniformly shaped to a large extent. They all the lumbar spine have the same shape. All thoracic spine have the same shape. Most of the cervical spine have the same shape. So if the shape of one is different from the other, you will suspect fracture or infection. Do you understand? So the first thing is to consider the bone density. Okay, let's go on after each so that I don't waste much of the time with explanation. Let us consider, this slide is saying that what? In the lumbosacral spine, the height of the vertebra are uniform, all true. They're all of the same height. The intervertebral disc are uniform, all true. The bone density are uniform, all true. Don't forget I'm talking about B now for bone, components of the bone. Whereby you now find that the height of one vertebra is not like the other, then you suspect something. Whereby you now find that the intervertebral disc is narrowed somewhere than the rest of, you can now suspect something. And we have to look for facet joints and some other points too. We're getting there. We're getting there very gradually. We're getting there very gradually. Now, the facet joints. No. Before we go to the facet joint, we're still talking about vertebral body. All I've said so far is that you look for the height of the vertebral body. If one is shorter, suspect a problem. Then look at the joint space. If one is narrower, there's problem with the vertebral body. Now, sometimes we can also see what is called a small nodes on the vertebral body. A small node is just an area of indentation on the vertebral body, whether at the superior margin or inferior margin of the vertebral body. It could be a congenital anomaly, or it could be as a result of trauma. You just see a little indentation, like you are seeing on this diagram, where the red arrows are pointing to, and you can see it in the red diagram, a little indentation on the superior margin of the vertebrae. That's what is called small nodes. Usually it is asymptomatic, but some patients can come to your clinic with low back pain, and you ask them to go and do X-ray or MRI of the spine. You see these small nodes, and apart from the small node, you cannot see any other pathology. If that is the only thing you see, in such a situation, that the patient should go to surgery to remove the small node, because sometimes intervertebral disc can slip into this small node and produce symptoms. But in most situations, it is asymptomatic. All right. So that is small nodes. We're still talking about the vertebral body. Apart from the small nodes, no, I want to talk about the minor pathology that we can see in the body before we now talk about the big one, which is very obvious. The next thing we can see is apophysis or libus. Usually, this is seen at the superior margin. You know, small node is seen at the center of the superior margin or inferior margin, whereas the apophysis is seen at the lateral end of the superior margin of the vertebrae. If care is not taken, you can mistake it to be a fracture, like this diagram you are seeing now. Actually, it is not a fracture. The apophysis is one of the ossification centers in the vertebrae as we grow. And in some patients, the apophysis did not ossify completely. And then it will appear like that on X-ray. And if it's constituting symptoms again, you can't see any other abnormal signs that should explain your patient low back pain. It's only the apophysis you are seeing. Then please, you refer the patient for surgical intervention. We're still talking about the vertebral body. Now we're going to the facet joints. How do we pick the facet joints? I thought I should discuss with a schematic diagram before I now go to radiograph. Now, facet joint is where one vertebrae articulates with another one. If you look at this diagram, if you can see my arrow, you see where one vertebrae is articulating with another. So you can see it there, and you can see it in this place as well. This is vertebrae above articulating with vertebrae below, where my cursor is now. And to analyze if there's any problem with facet joints, we use this sign called the Scotty dog sign. Can you see this image here? I'm trying to trace it with my cursor. It looks like a dog, isn't it? And it is called a Scotty dog. We'll always see that when you look carefully at the lateral view of a vertebrae, something that looks like this. All right. Now, this is one vertebrae articulating with the vertebrae below. Which joints are these joints? Now, when you look at the Scotty dog, the hair of the dog is the superior articulating facet. Anterior to the ear is the transverse process. The two projections below are the inferior articulating facets on both sides of that vertebrae. I wish you take your time to study it more so that you'll appreciate that, because you need it to be able to analyze if there's any problem with the facet joints. You can still see the Scotty dog here. Before we go to the radiograph, the superior or the ear end of the dog is the superior articulating facet of the vertebrae above us is the inferior articulating facet of the vertebrae below. All right, facet joint is formed by the superior articulating facet of the vertebrae below and the inferior articulating facet of the vertebrae above. So this is the superior articulating facet. When you look to the front of it, you will see the transverse process. So when you get the Scotty dog, you can easily analyze if something is wrong with the articulating facet, and by extension, the facet joint, if something's wrong with the transverse process. And the leg of the dog represent the inferior articulating facet on both sides. Okay, so we're going to see this sign of Scotty dog very soon. All right, now let's have a look at this diagram. Let's have a look at this diagram. You can see the Scotty dog. Look at where the black arrow is pointing. Can you see where the black arrow is pointing? And if you trace it round and round, you'll see the Scotty dog here. You can see another Scotty dog above. You can see another Scotty dog above. We use it to interpret problem with the facet joint. So you can see the Scotty dog. The arrow is pointing directly to the neck of the dog, Abby, and that is where superior articulating facet meets with inferior articulating facet. That is where the facet joints take place. Okay, what do we have to see on Scotty dog appearance? Look at this next image. Okay, if you look at my two white arrows here, okay, you will see the Scotty dog around those two white arrows. Can you see it? And I've told you that the neck of the dog is where superior articulating facet and inferior articulating facet meet, facet joints. All right, so there must be no breakage of that line. As we are seeing in this diagram, there's a kind of thin dark line there. That shows there's a fracture in that joint, and that is what is called pars interarticularis fracture. That could be all you are going to see in your patient with back pain, and you know they have to be referred for surgical intervention. All right. Any chain, it looks like a chain is put around the neck of the dog. Any of such chain is point to pars interarticularis fracture, and it calls for surgical involvement. Okay, we are rounding up on the radiography for the spine. Now, sometimes the radiograph will come in form of infection. All right, patient is having infection and they are referred to physiotherapy, whether they are referred or they refer themselves. All right, and you ask them to go and do X-ray, and this is like what you are seeing. What do you see here? Something has already eaten up the intervertebral disc and the bone. All right, you can see that they are not looking their normal self. The intervertebral disc and the bone is eaten off. So this is what is called vertebral osteomyelitis, or you can call it spondylodiscitis, because it affects the bone and the disc. You can call it spondylodiscitis, or you call it vertebral osteomyelitis. Look at the intervertebral disc. It's looking whitish because of the infection. It's fluid though. It is fluid that make it to look that whitish. And you can see the normal shape of the bone has been lost. The normal rectangular shape of the bone has been lost in that green arrow area. If you also look at the red arrow area, you see that the bone is not of its normal self. So there's an infection that is spreading around the vertebrae here. So it will not be wrong to say that this patient is having vertebral osteomyelitis or spondylodiscitis. Okay, so that could be a kind of image that the patient will also be presented to. And you know, again, they have to be referred to doctors so that we don't keep on managing patients blindly. And they will say physiotherapy is not working. It's not that physiotherapy is not working, it's the choice of patients based on inability of some physiotherapy to read the imaging. So the interpretation of the last one that I gave to you is what you are going to see here. All right, this is an infection involving the intervertebral disc and the bone. So it is rightly called spondylodiscitis or vertebral osteomyelitis. That is the term. All right. Okay, let's go. So what are you going to call this? In case I ask you, what are you going to analyze there? All right, to analyze this one also is not hard. You're going to see where the arrows are pointing to. That's the space between two Scotty dog. There could be, let me make this small a bit so that you can see my cursor. Scotty dog is here. There's always a space above and below the Scotty dogs. All right. You know, Scotty dog's neck is here. That's where the facet joint is. We said it must not be dark, looking like a chain around the neck of the dog, because that's pars interarticularis fracture. But if you look at the space above and below the Scotty dog, that is vertebral foramen, where the spinal nerve exits. Now, if you look at this diagram, you see that the white arrow, the space are clearly demarcated. If you look at the area of the red arrow, you can't see the space again because something is blocking the space. And this could be the presentation you will have in a patient with spinal stenosis. Do you understand? So that could just point, this diagram could just point to L5X1 spinal stenosis, all right? So we should be able to read this also when our patient is presented with that condition. You know, I always ask, what do you see? And I give the interpretation in the vertebrae below so that you can still do your revision, all right? Unlike what we had last year, I just ask, what did you see? And I explain. But I find out that some people will still have to go over the notes. So you can actually try yourself on what did you see, then look at the slide below and get the interpretation. So the red arrow area indicates blockage of the vertebral foramen, and that could be stenosis, and could lead to pain and paresthesia in the patient that is affected. All right, you know, we are AB. We have talked about alignment. We have talked about bone structures. Under the bone structures, we talk about vertebral body, we talk about scotty duct for the facet joint, we talk about the foramen, and we talk about infection. All this one relates to the body. Now we're going to the C, which is the cartilage and the joint space. All right. Now this is also for teaching. We're going to read the radiographs later. Now I think by now we are all very conversant with what we are seeing. We know that the dark area between the vertebral body is the joint space, isn't it? And they should be uniform throughout if there's no pathology. But if you look at the diagram on the right-hand side, you see that between L5 and L4, the joint space is narrowed. You'll also see a bony spurs at the margin of L4 and L5. The bony spurs are referred to osteophytes. You can also see a whitening, a sclerosis at the articular margin of L4 and L5. That is called articular sclerosis. Wherever these three signs are present, joint space narrowing, articular sclerosis, osteophyte, they are all clinical signs of what? Osteoarthritis. It's just an introduction to analyzing joint space. Let's look at more slide to illustrate joint space pathology. Can you see this one? I say, what did you? You're going to start from X1. The X1 look down here. I'm coming. The X1 look down here. So you can say L5, L4, and L3. Okay? We can say L5, L4, and L3. So the arrows is actually between L4 and L3, isn't it? So when you take a look at that, you see the joint space still look okay, isn't it? It's only the joint space between L2 and L3 that look narrowed. And the joint space between L1 and L2 is also narrowed. But the joint space between L3 and L4 look okay. But there is marginal osteophytes. You can see there's marginal osteophytes in the anterior margin of L3 and L4. All right. And all these are pointing towards osteoarthritis, or what we call spondylosis in the vertebral spine. So this is the interpretation of what did you see there. Anterior marginal osteophytes, L2, L3, joint space narrowing, L1, L2. Okay. So all these are pointing to spondylosis between L1 down to L3. Okay. Let's have a look at this one. What did you see in this diagram, sir? What would you pick up in this diagram again? Okay, without minding word, you see that the joint space between L5 and L4 is narrowed. That's very obvious, isn't it? And then there is marginal osteophytes at L5 and L4. So simply put, we can still see marginal osteophyte between L2 and L3, but the joint space is still okay. You can see a little scroll molds. The scroll molds we'll discuss at L1. So the disc can even descend into that space. So the most salient finding here will be what? Joint space narrowing between L4 and L5, marginal osteophyte L4, L5, L3, L4, even L2, L3. All right. And these are still classical signs of osteoarthritis or spondylosis. So The interpretation is there. Possible diagnosis will be lower lumbar, L4, L5, spondylosis, okay? All right, so ankylosing spondylitis again. Yes, I'm glad we have already discussed this one. In all cases of ankylosing spondylitis, look out for the ankylosis of the sacroiliac joint. The sacroiliac joint is ankylosed, no joint space again, and you can see the sclerosis there. Look for the vertebral body looking like a square rather than a rectangle. You know, normal one is rectangle, but this one is now looking like a square. Look for the syndesmal phytes, which joins all the vertebrae all along to the top. And look for the shiny corner signs, and look for the dagger spine signs. Then you'll be able to diagnose ankylosing spondylitis. All right, we're still talking about what? The joint space, all right? Okay, I've already dealt with this one. This is still part of ankylosing spondylitis. You see the sacroiliac joint space is gone. The joint space is gone. All right, and here in the upper diagram, the joint space is gone with sclerosis. The hip joint is even having sclerosis and reduced joint space. The sacroiliac joint is also, the sacroiliac joint space is narrowed and the sclerosis there. So these are the early signs of ankylosing spondylitis. In the advanced stage, that's when you see the bamboo spine being affected. But in the early sign, it is only in the sacroiliac joint that you are going to see it. Okay, thank you very much for your endurance. This is going to be the end of the first part. And I hope to see you in the, I think it's by 2 o'clock, so we can have a break 1 to 2, walk around, rinse our face, and then we'll get to see in by 2 o'clock. We're going to look at all the joints, radiographs, and then finally we're going to end up with MRI of the spine. Thank you very much. See you soon.
Thank you so much, sir.
Thank you so much, sir.
Thank you, sir.
You're welcome.
Thank you,
Thank
sir.
you.
You're welcome.
Thank
See
you,
you
sir.
soon.
Thank you very much.
Thank you
God
all.
bless.
Thank you all. Thank you all. See you soon. See you soon.
Daddy, I forgot to copy from here.
See, you have your writing 9. So you wrote it up. Why not copy from here? This is your 9. Be writing 9 like this. Okay.
This is not my room.
I was shaking. I was breathing somehow. Maybe I wasn't lying well. I feel so.
All right, good afternoon and welcome to our presentation. Please give me a response if you can hear me now.
Yes, sir.
Good afternoon, Prof.
I hear you.
Good
All right,
afternoon, Prof.
Thank you very much. Without wasting much time, please let us proceed. We are still discussing radiographs. We have laid a very good foundation for the principle according to the topic. We have also applied it to the spine. That's radiograph. Now we're going to look at other joints before we now proceed to look at MRI of the spine. So in this second part, we're going to make a start with the shoulder joints. We dealt with the spine. So let's see the radiograph of the shoulder joints. Well, clinical usefulness. A shoulder radiograph series may be needed for a particular condition, such as for the evaluation of arthritis in the shoulder, trauma, dislocation, and instability. Those two work together, and impingements. I hope this session is being recorded by Ray Physiotherapy so that people can have opportunity to listen to it after, if need be. Please let us remember to put it on record. Thank you. Now, this could be the passive clinical usefulness of radiograph of the shoulder. Let's quickly look at the radiographic anatomy before we go into the radiograph. Let's remind ourselves of how different parts that we are going to see, what they represent in the real anatomy. Okay, this is almost like what is going to come out. We will remember that this is the clavicle. Okay, as far as radiograph of the shoulder is concerned, you only see half of the clavicle. So the clavicle extends from here and stop here. The rest part is covered by the spine of the scapula. So from the midpoint, you always see a junction here. And from the midpoint down here is the spine of the scapula. I know the spine of the scapula ends with acromion. You understand? So this junction, where the two meet, that is where the ACJ joint, acromioclavicular joint, is located when you are looking at X-ray. So you see the clavicle, you see the spine ending in acromion. That's very obvious. Then below acromioclavicular joint, you'll always see the coracoid process. You see the coracoid process below the acromioclavicular joint. We're just revising the anatomy. Then you're going to see the glenoid cavity, all right? In ordinary AP view, you will not see the, glenoid cavity is supposed to be a complete cycle, isn't it? In ordinary AP view, you will not see the complete cycle. You only see like one part. The head of humerus would have blocked the half part, but we're going to explain all this in our subsequent view. All right, so let's come down to the humerus then. So we're going to see the greater tubercle or greater tuberosity, superolateral, and we're going to see the inferior tubercle or inferior tuberosity. Maybe not very obvious on the AP view, but we are going to see it in the AP view with internal rotation. This is AP view with external rotation. Don't bother yourself with that because we are going to explain that. Then, of course, we have the clinical head and we have the surgical neck and we have the lesser tubercle here. So that we just remind ourselves. Now, let's go into normal radiograph. When a radiograph of the shoulder is being taken, AP view, it can be done with shoulder in external rotation or with the shoulder in internal rotation, depending on what depending on the request, okay? This is what
full screen.
Oh, all right. Okay, thank you very much. This is what it will look like. Please mute, keep your microphone silent. Now, this is what it will look like if it is AP view with external rotation. All right, with external rotation, just involve keeping your elbow straight and moving your palm outwardly. Okay, before the view is taken. So that is when you are going to see half part of the glenoid cavity. If you look at the picture above, you see half part of the glenoid cavity. You see the dashes line represent what should have been the other part. Okay, that is usually in external view. All right. You see, you can still appreciate the clavicle, and you can see where the clavicle ends. You can see where the clavicle ends, it continues as acromion. Then you can see that it still continues as acromion. So you can see the acromioclavicular joint. See a little letter G there is representing the greater tubercle or greater tuberosity. All right, if you look at the diagram that is slightly below, you will still see the clavicle, and you see the acromioclavicular joint, very obvious. You will see the greater tubercle. So if the intention of the investigation is to see the acromioclavicular joint, is to see the greater tubercle, you know, a lot of rotator cuff are attached to that greater tubercle. We have 4 rotator cuff, and 3 out of these 4 are attached to that greater tubercle alone. Supraspinatus, infraspinatus, teres minor. The whole 3 of them are attached to the greater tuberosity. So if we're doing that kind of investigation, you will have to use external rotation view of the AP. Okay. The other thing that is very obvious or that is desirable with AP view, if you look at the upper diagram, I'm not sure whether you can see my cursor. My cursor is going straight to the area. You know, when you put it on presentation mode, sometimes the cursor is not showing. If you look at the diagram above, all right, the one that is above, between the acromion and the head of humerus, just look at that region, between the acromion and the head of humerus, you see one vertical dark line. That line is called the acromio-humeral distance. All right, and the normal distance in adults should be about 7 millimeters or greater. Either 7 millimeters or greater than 7 millimeters. That's the normal acromio-humeral distance. So all these things you will see in external view of AP. You are going to see the relevance of all these points that I'm making by the time we go into looking at some pathological condition. So this is the AP view of the shoulder in external rotation. Then again, in external rotation, if patient comes to your clinic with external rotation of the AP view, you will see that the humerus head will look like an axe. And that's why it is called an Indian axe. But if they do AP view, with internal rotation, it will not look like that axe. It will look like the cone of ice cream. So we can always differentiate between AP external view and AP internal view. So with AP external view, you see the Indian axe. You see greater trochanter very clearly. You will see the acromioclavicular joint very clearly. The only thing you will not see very clearly is the glenoid cavity. You know why? Because part of the head of humerus is blocking almost half of the glenoid cavity away. So please take notes of this. Now we're going to look at the internal view. If the internal view is what is requested and the patient comes to your clinic with an internal view, this is what you are going to see. You see now that this is still AP view, but with internal rotation of the shoulder. You see this time around that the head of humerus look like a light bulb or the cone of ice cream. It doesn't look like an axe anymore. Yes. You'll be able to see the lesser tuberosity very well. All right. See the lesser tuberosity here is more prominent here than in external rotation. And you know, it's only one of the rotator cuff muscle that is attached to lesser tuberosity, and that is subscapularis. So if you are suspecting lesion with subscapularis, you probably will order for AP internal rotation view. But most of the film they take to the clinic is external rotation. Because this one has less request than the one of external rotation. But so the main purpose for the internal rotation is to get the lesser tubercle, really. Okay. You still are not seeing the glenoid cavity in its full form, even with this internal rotation, but we can still see the clavicle. We can still see the acromion. I said half of that straight horizontal line above the shoulder is clavicle. The remaining half is acromion. That's the way it appears on X-ray. And the junction between them is the acromioclavicular joint. Okay. So we can appreciate all this one. That is AP view in internal rotation. There's yet another view called the Rockwood view. All right. There's yet another view called the Rockwood view. Rockwood view is just like AP view. Okay. It's like anterior posterior view, but the radiation is coming at an angle. It's not perpendicular. It's coming at an angle of 30 degrees to the shoulder joint. And that is done so that there will be proper perception of the subacromial space. So this will still be useful if you are querying rotor cuff impingements. All right. Some people say in rotor cuff impingement is the tendon that's affected, and tendon is not visible to X-ray. You are right. But in the chronic stage of rotor cuff impingement, there could even be severance of the rotor cuff tendon, in which case the head of humerus will move abnormally high, almost rocking on the acromion. And you see in all the images that we have considered earlier on, there is none of them where the head of humerus is rocking on the acromion. So sometimes there could be a Rockwood view to see the subacromial space and to diagnose rotor cuff impingement. We're going to see example of this one also in a short while. Now, this is like the image you will get with a Rockwood view. All right. You can see that broken line. Can you see one broken black dot line? That is the area of interest. You can see it span from the inferior aspect of the clavicle and it touches the inferior aspect of the acromion. You can see the head of humerus is not actually touching the acromion. But if there's rotor cuff impingement and the tendons are weak or cut off, deltoid muscles will pull the head of humerus unopposed. And you see the head of humerus is rocking the acromion on that surface. All right. So this is just the Rockwood view so that we know the view to ask for when we are sending our patients to do their radiograph or the X-ray. Yet there's another view called the Grashy view. Grashy view is what we can call the true anterior-posterior view. You know why I said that? Because in Grashy view, you will see the whole of the glenoid cavity. It's not blocked. Grashy view is done just like the AP view, but with the shoulder in 30 degrees of abduction. So that 30 degrees of abduction will enable the whole glenoid cavity to be captured. It's not like the external or internal rotation where we are only seeing half of the glenoid cavity and the head of humerus is blocking the remaining half. So you see that this Grashy view will be required if you are suspecting osteoarthritis of the shoulder, because you want to see the changes like the joint space narrowing, like the sclerosis, like the osteophytes in the glenoid cavity as well as head of humerus. So you want to see the glenoid cavity clearer, Grashy view will be the request. And this is what it will look like in Grashy view. By the time you get the X-ray, see that the glenoid cavity is well represented here. It's not like half of it is seen, the remaining half is blocked, where the black arrow is. So it's particularly useful when you are thinking of osteoarthritis of the shoulder. We're going to see a lot of this later. What else can we see on this film? Look at the clavicle. Can you see the clavicle again? And the acromioclavicular joint has be a wide sclerotic tissue, so there could be ACJ arthropathy going on. But that's not the purpose of this slide. I'm just saying. The purpose of this slide is to show us that with the Grashy view, you can have a better view of the glenoid cavity, unlike the AP view with either external or internal rotation. Yet we have another view called the axillary view, in which the X-ray is projected to the axilla, under the axilla, and the film is captured above the shoulder joint. This view is particularly useful when you are querying subluxation or dislocation. Subluxation or dislocation, then the axillary view is the most desirable. Let us see how the film could look like in axillary view. See, film could look something like this. I'm sure you still agree with me that this is glenoid cavity here. I hope you can see my arrow. That's the glenoid cavity there. And you can still see the head of humerus. You can still appreciate the clavicle. And at the end of that straight line where clavicle is, that's where we have the acromion process. And then the coracoid process is just halfway. The coracoid process is just halfway in between them. Anyway, that's not where we are going really. We just want to prepare our mind before we get to our final destination. Now, this table that we're seeing here is just an overall specific utility of shoulder radiograph. If you order for normal anterior-posterior, it could be because you just want to have overall impression of glomerular joints. If you use Grassi view, maybe you want to see glomerular cartilage space. Axillary view, that's what you will order for if you're considering subluxation, dislocation, and the rest of them. You can see Rockwood view for subacromial space or impingement. And you can see some other view that are used for something entirely different from what we have mentioned. So you can have this table to refer to in any situation where you want to order for X-ray of the shoulder. All right. Now, the approach to analyzing it is not different from what we have said, and that is still ABCS, where A stands for alignment, B stands for bone density, C for cartilage, and S for soft tissue. The same approach that was developed by Froster and Nancy. They are the one that came up with that ABCS approach. As we use it in other one that we've discussed in our first lesson, the same thing is still going to apply here. So let us start with A. We are on shoulder. A is talking about what? Disturbance in alignment. All right. Before we look at the radiograph, let's do a little anatomy of that disturbance of the alignment. Now, disturbance in the alignment of humerus can be discussed under two headings. We say the proximal humerus and then the distal humerus, isn't it? But you see that in the proximal humerus, about 4 things could go wrong. All right. The anatomical neck could get fractured. The surgical neck. The surgical neck is the one that links the head to the shaft. The surgical neck could get fractured. Greater tubercle or greater tuberosity could get fractured, and lesser tuberosity could get fractured. So when you are considering radiograph of the proximal humerus, these are the 4 things you are actually looking out for to see which one has happened. And the situation whereby 2 or more of them had happened, you can simply revert to the pathology as Neer's fracture. You know, like we do Neer test, N-E-E-R''S. But if there is no 2 of them, then you have to tell us specifically, is it fracture of the anatomical head, of greater tuberosity, of lesser tuberosity, or surgical neck, or fracture of the shaft. If we go a little bit down, then we're going to have fracture shafts. If you go a little bit down, you are going to have intercondylar fracture. You know that the humerus has medial condyle and lateral condyle. So we can have epicondylar fracture, that's above the condyle. Then we can have intercondylar fracture. Basically, these are the different forms of fracture you get for the humerus. And for the glenoid cavity, you can have fracture of the glenoid cavity as well in very severe traumatic injury. So I thought we should just talk briefly about it before we now look at the radiograph. Now look at this radiograph and probably think about it for a few seconds and tell me what you feel. What do you feel is happening here? If you look at it very closely, all right? If you look at this radiograph very closely, you see that the surgical neck of the humerus is not there again. It's fractured, and you can see the upper fragments, and you can see the lower fragment. They are going in different directions. And you know, I told you that in the language of fracture, you emphasize the lower or the distal fragments. So this probably will be called fractured, a closed fracture, okay, of the surgical neck of humerus, with the humerus being displaced superiorly and anteriorly. You see that the humerus is moving superiorly after the fracture. It's like it's going to touch the acromion, and it's also coming anteriorly. If it had gone posteriorly, you would have seen that something is blocking it, like that acromion is in front of it. So this basically is illustrating fracture, closed fracture of the surgical neck humerus with the humerus being displaced anteriorly and superiorly. That is in the fracture language. And what I've said to you is already written. Okay, there's a bit of interaction with network, but we are back again. So I'm trying to I am trying to explain this one. It's a fracture of the surgical neck, not anatomical neck. You know, anatomical neck is inside the socket. So it's a fracture of surgical neck with the humerus being displaced superiorly and anteriorly, because we emphasize the distal fragments whenever there's fracture or subluxation or dislocation. You can see that there's a gap in the acromioclavicular joint if you look at it very well. You see where the clavicle ends, you see the continuation of acromion.
Your slides are not showing, sir.
The what? The slide is not showing.
Yes.
I think that must have to do with that interruption that we had earlier on. Just give it a minute. Let me see if I can reset it. Oh, that must be due to the slight interruption that we have, but we'll go over it again. Don't worry. Yes, this is where we are. Can you see my slide now?
No, sir.
You still cannot see my slide? And okay, maybe I have to join up again. That's a problem. I don't like having problem when I'm presenting. I'm coming. Just let me see what has gone wrong. It's the slight interruption of internet supply that caused this.
We can see it now.
Okay. It was that slight interruption that caused this. We are on this slide. We are on slide number 17. All right. Based on what we're saying, I said a lot of things. I hope you get what I said earlier on. We are considering what could go wrong in the proximal aspect of the humerus. And I said about 4 things. The surgical neck could be fractured. Anatomical neck could be fractured. Greater tuberosity, lesser tuberosity could be fractured. The glenoid cavity could be fractured. Those are the things we'll be looking out for when fracture happen in that place. Is it of anatomical, surgical, greater tubercle or lesser tubercle, or glenoid cavity itself? And if we leave the upper part, we'll go down a bit, we'll be looking for fracture shaft. If we go down a bit, we'll be looking for epicondylar fracture. And at the end of the humerus, we'll be looking for intercondylar fracture. It's as simple as that. Okay? This particular one that we are on before the interruption is the fracture surgical neck of humerus. The part of the humerus that cut off is not inside the glenoid cavity. That's the surgical neck. And there is a displacement of the distal fragments. And I said earlier on that preference is given to the distal fragments when you are explaining. So how has the distal fragment get displaced? It has been displaced superiorly and anteriorly. You can see that humerus is pushed against the acromion now. So if you are going to report this one, we're going to say is what? Closed fracture, surgical neck of humerus with humerus being displaced superiorly and anteriorly. Then I'm just paying your attention to something. If you look at acromioclavicular joints, here I've shown you the clavicle, and then look at acromion is the end. There's a gap. This gap in acromioclavicular joint is too much. So there must be a kind of disorder with ACJ that the patient will complain of as well in this radiograph. I hope it is cleared. And that is what I have written here for your revision, in case you want to revise that. There's a fracture through surgical neck of humerus. The shaft of the humerus appear displaced anteriorly and superiorly, queried ACJ arthropathy because of that gap in the acromioclavicular joint. Okay? All right, so we go on. What about this one? What would you see? What could you say is happening here? Look at those 4 possibilities I told you in the proximal humerus. Which one of them is fractured now? Greater tubercle. I'm sure you can see that very clearly. This is fractured greater tubercle. The thing with this radiograph is that the more you look at it, the more your eyes become very sensitive and picky. But if you don't look at it all the time, it seems as if you are not seeing anything. But looking at this one straight away, you can see that the greater tubercle is fractured. Abi? So that's not hard. It's a minimally displaced close fracture of the greater tubercle because there's no displacement, but we can see the fracture. So that is what is happening here. And that's what you have here. fracture in the greater tuberosity in the left humerus. Okay, go to the next one. Now, what are you seeing here? This is not very obvious, I must say, but look at where the arrow is pointing to. We thought something as fracture in that area, and we thought it should be the lesser tubercle or the lesser tuberosity, but it's not very clear. It's also looking as part of the glenoid cavity. So see the way I reported it, I just simply say this is probable. This is a probable fracture of lesser tuberosity. We will need another view to be able to confirm this. Then I said anything else apart from this. Can you see anything else in this radiograph? There's something else that is abnormal. You remember the acromiohumeral distance I told you the other time in the internal view? The acromiohumeral distance, that is the distance between acromion and the head of humerus. It's not here at all, because the head of humerus is resting directly on the acromion. So that's an abnormality as well. And I have said earlier on, this kind of thing only happens when the rotator cuff muscles are weak or they are cut off. When the rotator cuff muscles are cut off, that's when you have the head of humerus rubbing on the acromion. So there will even be, and you know that under acromion there is a bursa, subacromial bursa. So this kind of radiograph can come with a patient with shoulder pain due to subacromial bursitis, rotator cuff impingement. We need to find out, because the head of the humerus is already rubbing on the acromion. So it could be rotator cuff impingement, or it could be what? Subacromial bursitis, apart from what we are querying. Okay. Now let's have a look at the next one, still on the shoulder. Again, I'm trying to ask that, what did you suspect in this radiograph? This is also not a very clear one, but there's a bit line of fracture in the anatomical neck, not in the surgical neck. You know, the surgical neck is very close to the shaft. Now, the other neck is inside the glenoid cavity. That's anatomical neck. So it's not looking proper to an extent in this radiograph. So this probably will be fractured anatomical neck of humerus, okay? All right, there's minimally displaced transverse fracture of the anatomical neck. That is what this is saying, in case we have that. If you look at the acromioclavicular joints here also, the joint space is now narrowed. Unlike what we saw where we queried AC arthropathy, the acromioclavicular joint here, the joint space is narrowed. So narrow joint space always come with degenerative changes anyway. So it could be ACJ degenerative arthropathy that is happening here as well. Don't worry, you'll still enjoy the rest of the slide. These ones are not very clear, but there's quite some interesting one that we're going to see very soon. Okay, let's have a look at this one together. What do you see? Honestly, everybody should be able to diagnose this one. I'm sure you can see the greater tubercle. Look at the area of greater tubercle, superolateral end of the humerus. You see there's a crack. That's a fracture of greater tuberosity. All right, that's how it will look like, because it's minimally displaced. All right, if you look at the down one, it is displaced. The greater tuberosity is well displaced, but the upper one is not displaced, but you can see still see the crack. The surgical neck is also fractured in the upper one, but it's not very clear. But in the lower one, you can see that the surgical neck is fractured because the humerus is going anterior and superior again. All right. So combination of two or more of those four areas in the proximal humerus is called near fracture. So you can call the upper one near fracture with minimal displacement, and you can call the lower one a two-part near fracture. All right. We'll get used to it. The more of it we do. Okay. Let's go to dislocation. Now we want to talk about dislocation. Let's have a quick talk before we now look at the radiograph, still in the shoulder. You know, shoulder dislocation is the most common type of dislocation in the body. It's the most common type of dislocation in the large joints. And there are three types. Some book will say there are 4 types, but there are three major types. There are 3. Somebody's microphone is still on and is disturbing. Please mute your microphone, please, if your own is still on. So the three types of shoulder dislocation, we have anterior, posterior, and we have inferior. And after this lecture, you should be able to diagnose it without missing words, okay? All right. Anterior shoulder dislocation is the commonest. 95% of cases of shoulder dislocation is anterior. Only 5% is posterior. Posterior happen with such a great traumatic force. That is why it's not so common. Whereas anterior shoulder dislocation could happen with a fall on an outstretched hand. Then we have inferior or subglenoid dislocation, rarely occur, and that is about 0.5% of cases of dislocation, almost zero. It is also called luxatio erecta. That is inferior. Some book will also say there is a subclavicular or intrathoracic subluxation. You really get that. I'm sure if you get it, you'll be able to diagnose it. It's not going to be a problem. Let's still go on. We're still talking about this dislocation. Causes of this dislocation, anterior dislocation, that's what we're talking about now. It could be due to trauma. For example, when somebody is falling from a height and is going with the head towards the ground, he now stretches out his arm to reach the ground. You know, the arm will be in abduction, external rotation, and extension. Those are the three mechanisms of movement that usually cause anterior dislocation by trauma. It could also be as a result of congenital deformity, especially in children. If there is a deficiency in the anterior part of the glenoid cavity, which is called Bankart fracture, or a deficiency in the posterior part of the glenoid cavity called the Isaac deformity. This will mean that the glenoid cavity will not be very deep to accommodate the head of mirrors, and the head of mirrors will be popping in and out like child play. All right, so there can be dislocation or subluxation anytime there is this congenital deformity. So apart from Bankart's deformity and Isaac deformity, trauma is another thing that could cause dislocation. All right. Now, let's still have a look at the anterior dislocation. If there's anterior dislocation, what are we going to see? Now, we all know that the shoulder is surrounded by capsule, Abi. Now, the capsule of the shoulder is weakest at the inferior margin. All right. The inferior part of the capsule is the weakest part. So anytime dislocation is said to happen, usually go out through that inferior part. So if it's anterior dislocation now, it's go out through the inferior part and move to the anterior part of the glenoid cavity, as you are seeing in this diagram, inferior, anterior, and medial. That is how you are going to see it in the X-ray. You see the head of humerus has moved inferiorly, it has moved medially, it has moved anteriorly, relative to the glenoid fossa. Anytime you see that, you know it is anterior shoulder dislocation. Clinically, you know that roundness we have around our deltoid, the roundness will disappear, and there will be fullness in the anterior part of the shoulder. You see, the anterior part of the shoulder, where the anterior fiber are, will get full. The lateral parts will become flat. That is what we see clinically. But radiologically, the head of mirrors have moved inferiorly, anteriorly, and medially relative to the glenoid fossa. And it's wide view that is normally used. Wide view of X-rays is what is normally used to get this anterior dislocation. Okay, let's now look at the radiograph. You see exactly what I'm talking about now. So I'm sure next time anybody bring this kind of X-ray to you, you'll know straight away it is anterior shoulder dislocation. You can see here the head of mirrors is what? Displaced anteriorly, medially, and inferiorly relative to the glenoid cavity. So that is there. Let's see whether anything has happened to ACJ. The ACJ still look normal. Nothing has happened to it. Nothing has happened to glenoid cavity or the scapula. So that's all right. It's just anterior shoulder dislocation. All right. That is what we have there. Now we can talk about posterior dislocation. Now, what happened? Let's talk about posterior dislocation before we look at this radiograph. Also in posterior dislocation, it doesn't usually happen because it requires a great amount of force for it to happen. This type of dislocation usually happens as a result of a very big fall, one, or when there's electrocution. When somebody gets electrocuted, gets thrown away and hits the floor very hard, or when someone is undergoing epilepsy fits and convulsing. because it's usually due to the imbalanced pull between internal rotation and external rotation. And you know the muscle that does internal rotation among the rotor cuff muscle is the subscapularis. Subscapularis will come with such tremendous amount of force that the external rotator will not be able to balance. And as a result of that, the head of humerus will pop inferiorly and go posteriorly. You know the subscapular muscle itself is posterior in orientation. So when it contracts forcefully, it will move the head of humerus posteriorly and superiorly. So that is what characterizes posterior dislocation. Then the other thing you would notice when there's posterior dislocation is that the head of humerus will look like a bulb. You see straight away looking like a bulb, and it has moved posteriorly and superiorly. Unlike anterior dislocation, where the head still maintains its shape, and it has moved inferiorly, anteriorly, and medially. All right? So that is what we have in posterior dislocation. Let's look at this. All right. This is exactly what I'm saying to further illustrate it before we look at radiograph. So in posterior dislocation, the head will look like a bulb, light bulb sign. The space between the head and glenoid cavity will be widened. It increases. All right. And then you see the whole head moving what? Superiorly and posteriorly. All right. Even if it doesn't move posteriorly, it's not going to come below the glenoid cavity. So you are looking at the head, it's looking like a bulb, and the space between the glenoid cavity and humerus has been altered. You could as well begin to suspect posterior dislocation. But when you are assessing all this dislocation, please just take a look at the ACJ and see that it has not been affected. The ACJ joints, where I place my cursor in this view, is perfect. Nothing has happened to it, but we can see the light bulb sign. We can see the widened glenohumeral distance. So most likely there's posterior dislocation. Look at this, guys. What do you think this will be? I'm sure everybody can diagnose this one now. Look at it. Look at the light bulb sign. Look at the gap between the humerus and the glenoid cavity. So this is straightforward posterior shoulder dislocation. Okay? We can't miss this location again when we see them on X-ray. All right? That's what they're talking about. Now, the inferior dislocation is the one also known as lossatio erector. The lossatio erector. This lossatio erector, well, it's almost very similar to anterior dislocation because the head of humerus come under the glenoid cavity. But it will not be like the way you put your arm to your side. It must be in abduction. Even when the X-ray come, the arm will be in abduction and then the head will be under the glenoid cavity because of the mechanisms that lead to lossatio erector. All right? It happens when the arm is in abduction, hyperabduction, and extension. Like when an athlete is attempting to do overhead shot of rackets, and then he heard a sound, pump, and the hand just remain in that position because of pain and spasm. So even if they take radiograph in that position, this is what you're going to see. So nobody will miss inferior dislocation because the head will be under glenoid cavity and the arm will be in abduction. All right? It's only that type of dislocation that produce this kind of fissure. And you can see it here, okay? And you can see it here. It's also known as lossatio erector. All right, okay. Now, we want to talk about the disturbance in bone density. We've talked about alignment, right? I'm sure if you see fracture shaft of humerus, you will know. That's why I didn't bring those one. If you see fracture epicondylar fracture, that is above the epicondyle, you will know. And if you see intercondylar fracture of humerus, all of us will know that one. So that we'll be able to save time. Now, let's go straight forward to disturbance in bone density. Disturbance in bone density, all right? And the first disturbance, we are on B now. The first disturbance in bone density we want to consider is avascular necrosis. If the patient is presented with avascular necrosis, I know that the hip joint is much more affected than shoulder joints, but sometimes it will also affect the shoulder joints. Now, let's talk about the causes first. It could be caused by sickle cell disease. That's the one we know mostly. A patient that is on long use of corticosteroid can also come down with AVN. or it could be a post-traumatic sequela as a result of a complication from trauma to the shoulder joints. It could also happen. Now, what are the radiological features we'll be looking out for if there's avascular necrosis? It varies, and it depends on the stage of the AVN. In the early stage, the whole head of humerus will look like dark ash. That is, it will be lucent, subtolucency. In a bit further, that subtolucency will be replaced by sclerosis. Or you see the lucency above and you see area of sclerosis below, within the head of humerus. And after some time, you see a dense sclerosis. The sclerosis will become much. You see the lucency, you see the sclerosis. And later, it could break up as if there's fracture within the head of humerus. And other things could follow. But these are the three classical signs that you see in avascular necrosis. You know, I said there could be sclerosis and dense sclerosis. That dense sclerosis is sometimes known as snow cap sign, like a cap that is made with snow. You know, snow is whitish somehow. And then it's a cap because it's found within the head of humerus. We are going to see it now in our radiograph. Okay, let's have a look at this one. This avascular necrosis. Can you see the sclerosis under the lucency? The upper head of humerus is showing some translucency. Then underneath it, you see a whitish line. That's the area of sclerosis. So this like a mid-stage of avascular necrosis. So this is a case of avascular necrosis. There's no collapse at this stage. Even the sclerosis is not very dense. And there's no collapse or fracture within the head. But we can see the area of lucency, and we can see the sclerosis, sclerotic area underneath that. Now have a look at this one. This is more or less like an advanced stage of avascular necrosis. So you can see the sclerosis. You see the area of lucency at the top and see the sclerosis in the middle. It is much more well established here. This is like what you will see in avascular necrosis. There's also sclerosis of the glenoid cavity, but that could be due to osteoarthritis. So we should be able to identify this when next we see one. And I'm asking you, what did you see here? You see the snow cap sign. You see a dense area of sclerosis in the head of humerus, looking like a cap for the humerus. And that's what is called the snow cap sign. There are other abnormalities too, because the head of humerus should not be touching the acromion, I told you. So there can be impingements in these patients as well, beside the avascular necrosis. All right, let's move fast. Now look at this. Okay, this is just the reading of the last radiograph that will show a snow cap sign or snow capping. I just define it here. And it's a feature of avascular necrosis, so you can read on the definition. It's just an appearance of dense sclerosis over the head of humerus. It can also happen in femur. If there's avascular necrosis in femur, the feature is the same thing, whether humerus or femur. Okay, that's how we diagnose avascular necrosis. All right. Can we talk about disturbance in the cartilage? We're going to talk about disturbance in the cartilage a little bit for shoulder joints. Now, you know, cartilage and joint space go together. Abi, we look at disturbance because cartilage is responsible for the joint space, like we said earlier on. Now, okay, in patients with rheumatoid arthritis, if a patient is presented with rheumatoid arthritis, the cartilage is there. The joint space is there. You know, it's not a primary problem of the cartilage. Osteoarthritis is the one that attacked the cartilage first. In rheumatoid arthritis, the cartilage is there. And if the cartilage wear off, it will be uniform. So the lot of joint space will be very uniform. It's not that you see an area will be narrow, the other area will be widened, an area will be narrow, the other area will be widened, as we have in osteoarthritis. All right? It's a uniform cartilage space narrowing we have in rheumatoid arthritis. You can mark that as number one. Number two, in rheumatoid arthritis, you see area of osteopenia. Osteopenia refers to bone loss. You can see some dark area on the head of humerus there, where those three arrows are surrounding. Those are the area of osteopenia. It's due to bone loss. It's osteopenia that will later result into osteoporosis. So osteoporosis is an advanced stage of osteopenia. So osteopenia is the initial bone loss, and if it gets advanced, the diagnosis will change to osteoporosis. So you will see osteopenia in rheumatoid arthritis. You see a uniform joint space narrowing. And it doesn't have to come with sclerosis. It doesn't have to come with osteophytes, except if rheumatoid arthritis is coexisting with osteoarthritis. But in the classical rheumatoid arthritis, there's no sclerosis and there is no osteophytes. All right? Okay, so that is what I will expect that you look out for in such a situation. Look at this image. There's a very thin line of differentiation between rheumatoid arthritis. There's a very thin line of differentiation in the head of humerus when you have rheumatoid arthritis and avascular necrosis. So you'll have to balance things up by your subjective assessment. You know, during subjective assessment, Clue would have told you whether it is rheumatoid or avascular. But the radiograph could be somehow very confusing because it's somehow very similar in nature. Okay, that's what I'm trying to say. Because here you can still see the area of lucency like we see in AVN, but there's no snow capping area, there's no sclerosis under. So this is practically rheumatoid arthritis, not AVN. All right. Okay. All right, then we'll go to slide number 47. I'm asking you, what do we see here? You can see the region of osteopenia. You can see the osteopenia here and there. You can see bone loss where my cursor is now. There's an area of bone loss in the superolateral aspect of the humerus. You can see that thing that looks like a C shape. That's area of bone loss. All right. So this is rheumatoid arthritis, maybe with a little touch of osteoarthritis, because the joint space is not very uniform. And you know, in elderly people, they can coexist. Look at this slide number 48. We are going to osteoarthritis now. All right. We're going to discuss osteoarthritis, another cartilage and joint space problem. I'm glad we are very familiar with osteoarthritis radiography. It's the simplest, and it's long a time you would have been talked to about this. And the cardinal sign of osteoarthritis is joint space narrowing, subchondral sclerosis, marginal osteophytes. You can see marginal osteophytes here. You can see the sclerosis. You can see joint space narrowing. But I've told you, classically, the joint space narrowing in rheumatoid arthritis is uniform. Classically, in osteoarthritis, it is not uniform. The early morning stiffness, if we are talking about clinical sign, the early morning stiffness in osteoarthritis is less than 30 minutes. But if the early morning stiffness is more than 30 minutes, then it is rheumatoid arthritis. So we can balance things up with our clinical features with the radiographic information to arrive at a very tangible diagnosis. But what we are seeing before us here is classical of osteoarthritis. There's no osteopenia. There's no area of undue lucency. All we can see is joint space narrowing. We can see sclerosis at the articular margin, and we can see osteophytes. So this is practically osteoarthritis stage. So we're still talking about joint space and cartilage. So what do you see here? I'm sure without confusing anybody, this is osteoarthritis, all right? Maybe some other features are there, but classical, it is osteoarthritis. That's the focus. It's osteoarthritis that we can see there. Now let's move on to the S. Disturbance in the soft tissue. We've talked about alignment. We've talked about the bone. We've talked about the cartilage and joint space. Disturbance in the soft tissue. And this is very important too. When you are dealing with shoulder, a lot of cases of shoulder that we think is adhesive capsulitis or rotator cuff impingement, if you treat them more than 6 weeks, they are not making any progress. Please ask them to go and do X-ray, because some soft tissue easily gets calcified in the tendon of the rotator cuff in the shoulder joint. That's why this discussion of soft tissue here is very important. And I have some few notes I want us to read together before we go to the radiograph. Shoulder is the most common site of calcific tendinitis, all right? Calcific tendinitis is the position of calcium compound inside the tendon. And this usually happens in the shoulder, all right? In the very acute phase, you will not see anything on the X-ray. And the patient will be complaining of pain. You use all physiotherapy modality, the pain will not go. If you just wait a little bit, going to about 6 weeks or so, if you repeat the X-ray, you will see the calcific deposition. Do you understand? And it's usually happen within the tendon of rotator cuff muscles. I know rotator cuff muscles are 4, like you said before: supraspinatus, infraspinatus, teres minor. These 3 are attached to the greater tubercle. Supraspinatus, infraspinatus, teres minor. They are attached to what? Greater tubercle. Subscapularis is attached to lesser tubercle. Now, among those 3 that are even attached to greater tubercle, supraspinatus is anterior. Infraspinatus and teres minor, they are posteriorly arranged around the greater tubercle. And this information is needed when you want to make X-ray diagnosis of the calcific tendinitis. Let's have a look. Okay, this slide is just giving definition to calcific tendinitis. It's also known as calcific tendinopathy or tendonitis. A self-limiting condition due to what? The position of calcium hydroxyapatite within the tendon, usually rotator cuff. All right, we said that before. Okay, doctors, let's look at this radiograph. Tell me what you feel. You can see calcific tendinitis here. You see, you agree with me, this is greater tuberosity here. So this must be calcific tendinitis in the supraspinatus. Yeah, there are 3 tendons here: supraspinatus, infraspinatus, teres minor. But supraspinatus is the one that's more anterior. Okay, teres minor and infraspinatus are more posterior, but they will, if there's any tendinitis in them, it's almost at this spot that it will happen. If you are seeing tendinitis in the lesser tubercle area, then that should be tendinitis in subscapularis, because subscapularis is attached there. If you are seeing tendinitis in the shaft of the humerus, you are seeing tendinitis calcification. If you are seeing calcification in the shaft of the humerus, that will be due to calcification in the long head of biceps. You know, it's the long head of bicep that passes through bicipital groove in the medial part of the humerus. Okay? You can see how significant and how important our anatomy is now. Every aspect of what we have been taught when we're in school is important one way or the other, even biochemistry. The day something about biochemistry will hit you in your physiotherapy practice, you just be thanking God that you have paid attention when it was being done. Anyways, let's concentrate on why we are here today. Look at this diagram, sir. What would you think? You can see calcific tendinitis, can't you? And it's also in the region of greater tubercle. But this one is more posterior than the last one that we see. So this can be calcific tendinitis in the infraspinatus tendon. If you still stay in supraspinatus tendon, you are not wrong, because it will still receive the same treatment, because both of them are attached to greater tubercle. But if you look at this somehow, you see that it is more posteriorly displaced. That's why we can say confidently this calcific tendinitis should be in the infraspinatus. All right? Now look at this one also. The same thing. Same thing. This is also more posteriorly oriented. This calcific tendinitis. This is also calcific tendinitis in around the greater tubercle area, but it's more posteriorly placed. So it must be inside the infraspinatus. Okay? Now look at this one. Doctors, look at this one. You can see the calcific tendinitis. It's like it's spanning from, it's not even touching the greater, it's not very close to greater tuberosity. It's going on and getting under the coracoid process and acromion. What is under coracoid process and acromion? A bursa. So that means the calcific substance is inside the bursa. When you see a diagram like this. So what will be the diagnosis here? Calcific bursitis. You will try all modalities, you know, everything you know in physiotherapy, it will not work. Just ask them to go and take X-ray. If you see something like this, take them to remove it for them. This is calcific bursitis, sir. This is a perfect case of calcific bursitis, okay? And that is what you have here being illustrated. All right. Now let's talk about rotator cuff tear. All right. Rotator cuff tendon is a soft tissue. You are never going to see that one on X-ray. You will not see anything on X-ray if it is rotator cuff tendon inflammation. But in long-standing cases of rotator cuff injury and rotator cuff tear will mean that deltoid muscles will pull the head of humerus unopposed. You know, it's the supraspinatus that are supposed to oppose the pull by deltoid muscles. So if that tendon has been torn or is very weak, as in chronic rotator cuff impingement, you'll be seeing the head of humerus making contact with the acromion. So anytime you see an X-ray like this, and you don't see a distance greater than 7 millimeters in the acromiohumeral distance, then you are very at ease to diagnose rotator cuff tear and subacromial bursitis, because the head of humerus there is going to inflame the subacromial bursa. It's as simple as that. When you see that kind of X-ray, so that's what we are going to go for. Do you see exactly what I'm saying here? The head is rocking on the acromion. So we can think of rotator cuff, chronic rotator cuff injury, or rotator cuff tear, or subacromial bursitis with this diagnosis without fear of contradiction. All right? It's the same thing that we are talking about on this slide. All right? You know, we're on soft tissue now. So this is still subacromial shoulder impingement. I'm sure you understand that. We've been saying it for many times now. Now, a bit of winding up on the shoulder. Let's look at this. What is this, for goodness sake? This is called synovial osteochondromatosis. It's like a growth. It's like a growth from the synovial capsule, from the synovial membrane. All right? It's like a growth turning itself into cartilage, and then the cartilage getting calcified. All right? When the growth transforms itself into cartilage, it will be called chronoid fragments. If the cartilage is not calcified, the patient may not even have symptoms, and you will not be able to see it on X-ray. But this one that we are able to see clearly like this shows that the chronoid fragment has become calcified, and the patient will be presented with pain. And you will try all the physiotherapy intervention, or you'll get little or no result, or the pain will go down to come up again because it needs surgical intervention. You see, that is why we have to be very good with our radiological imaging, at least not for everything, but for the conditions that we treat as MSK physiotherapists. All right. So this is a case of synovial osteochondromatosis. All right. It's not calcific tendinitis, because calcific tendinitis is not well spread like this. And you see calcific tendinitis only around greater tubercle or lesser tubercle. All right. Okay. So you can still talk about synovial osteochondromatosis here. That's what we are still having on this slide. And then let me ask you, what did you see here, sir? What do you think we're seeing here? I know the X-ray is not perfect one like we have seen, but you can see the humerus very clearly. All right? You can look at the humerus. Now look at what we said about the trabeculae and the cortex of the humerus earlier on when we do first presentation. You see the whitish part of the cortex. If you go inside, you see the inside, somewhere around the inside where my arrow is dark. That is infection. And that is humerus osteomyelitis. It's an osteomyelitis infection inside the trabeculae of the humerus. That is what this image is representing. It's not the best area to illustrate osteomyelitis, but it could happen. It could happen as well. So that's what we are seeing here. See the result here. It's osteomyelitis infection, typically bacteria of bone involving medullary cavity. That's why we have that little curved black line inside the humerus. All right, we're leaving humerus alone. We're going to look at the elbow very briefly. We look at the wrist very briefly because of our time, and we'll spend more time on the hip again because that's another potential area for diagnosis. Let's quickly look at the elbow. Let's do anatomy. In our anatomy again, we know this is the humerus. All right. This is the medial epicondyle. How do I know? Because ulna is there. Anywhere you see radius is lateral. When you see ulnar, it is medial. So medial epicondyle here, and you see lateral epicondyle here. That's what I'm saying, that if you have a fracture above the medial and lateral epicondyle, we call it epicondylar fracture. And if you have fracture cutting between medial and lateral epicondyle, you call it intercondylar fracture. We don't have to waste time on that one. We are even on the elbow joint now. So we're going around the anatomy, medial epicondyle, lateral epicondyle. So we can see the lateral humero-ulnar joint and medial humero-ulnar joint. Do you understand? Humero-ulnar joint, the joint between humerus and ulnar can now be compartmentalized into two. The articulation on the medial side is medial humero-ulnar joint. And on the lateral side, it is lateral humero-ulnar joint. You can see that one here. All right. Now, let's leave humerus alone. So on the humerus, you can see medial epicondyle, lateral epicondyle. We can see proximal radio. We can see the shaft of humerus. Let's go to the radius. Or shall we go to the ulnar? Let's go to the ulnar. On the ulnar, we can see the coronoid process, very close to the trochlea of the humerus. The trochlea and the coronoid process almost enclose the medial humero-ulnar articulation. Then we can see the radius on the opposite side. All right, let's look at the lateral view very closely. The radius is still there. The radius is here. You can always identify the head of radius. You can always identify the ulnar with the olecranon process and the olecranon fossa on the humerus. I'm sure we are conversant with that from our anatomy. Now, if I give you a test now, I say you should number 1 to 10, what would you say? Let's quickly run through it together. If I ask you to number 1 to 10, 1 here will be what? You can see that 1 is pointing on the humerus, very close to the ulnar, so that is trochlear notch of the humerus. If I say 2, what is 2? 2 is the head of radius, isn't it? What is 3? Neck of radius. I'm referring to the right diagram here. The right diagram, the one on the left-hand side. And 4 will be the olecranon process. Let's go to the left one. 1 is shaft of humerus. Where is 2? 2 and 3 could be the medial epicondyle, or you call 2 medial epicondyle, you call 3 the trochlear notch. 4 will be humero. It's going to be the humeroradial articulation. Thank you. Number 5 will be the head of radius. Thank you very much. Number 6 will be the neck of radius. 7 will be the shaft. 8 will be the shaft of ulnar. 9 will be the proximal radio-ulnar joint. And 10 is going to be, okay. Yes. 10 is going to be head of radius. The head of radius. 11 is the trochlear notch of the humerus, very close to the ulnar. 12 is the olecranon process. 13 is the medial epicondyle of the humerus. And 14 is the olecranon fossa. All right. Once we know the anatomy, to diagnose a fracture in the elbow joint is not going to be a big deal. It's just our anatomy that we need to brush on again. So if your patient come with this radiograph, what will you diagnose? It's simply, thank you, fracture of the olecranon process, displacement. It's the olecranon process with displacement. You can see nothing has touched radius here, but the olecranon process has been fractured and is also displaced. That is what we have on that slide. Okay, and it has been explained on this slide. It's been explained on slide 68. What about this one? When you have this one, what is going to be your diagnosis or differential diagnosis? A lot of things has gone wrong here, isn't it? Let's look at radius. Can you still see the head of radius for where? It's gone, it's fractured though, and it's displaced. The head of radius is fractured and displaced. Can you still see the olecranon process going to the olecranon fossa? No. It is fracture and it is also displaced. So it's a fracture of the head of radius and ulnar with displacements. That is what we are having in this very noble diagram. Let's have a look at this, my colleagues. What are we seeing here? Now, let's start with the uppermost diagram on the left-hand side. Usually, Fracture olecranon is usually treated with open reduction internal fixation, and that is why you are seeing the plate and screw on that diagram labeled C2. All right. Then the little shaded area, if you look at the soft tissue area, you know the soft tissue area. If you look at the soft tissue area, you see a mushy white color there. That is myositis ossificans. That's a little bone being formed within the muscles. So characteristically, patients will come with swelling and pain in front of the elbow joints. If you're having myositis ossificans, they'll come with swelling and pain. And if you take the X-ray, you see this mushy white appearance is due to myositis ossificans. It is also what is present in the diagram below, the middle diagram. You can still see the myositis ossificans. And even in the third diagram, the lowest diagram, the one on the right-hand side, you can see a well-formed myositis ossificans. You know, let us watch out for this because it's a common complication to mobilization and immobilization of the elbow joint. It could be caused by mobilization and immobilization as well. All right, so it is myositis ossificans. Now, what about this view, colleagues? What would you say about this view? You can see where the arrow is pointing to. It's pointing to the first carpal bone, very close to ulnar styloid process, and that is scaphoid. All right, that is scaphoid bone. You can see the crack in the middle. So, you know, this joint is very compacted. Even if there's fracture, there might be no displacement. So what we're having here is scaphoid fracture. The scaphoid is fractured. Basically, that is what we have in that part of the body. Now, let's have a look at the next one here. We are now in the hand. Very soon we go into the lower limb and then we go to MRI. Now, I'm sure you can interpret this one, right? Okay, what does this one represent? The first metacarpal here is the thumb, the one in the thumb area. So this is the first metacarpophalangeal joint, isn't it? Look at the joint. You can see sclerosis. Can't you see sclerosis? That whitening thing at the joint. You can see joint space narrowing. You can still see osteophyte around that joint. So, and where you have sclerosis, joint space narrowing, and osteophyte, it is what? Osteoarthritis. All right? Red arrow is pointing to sclerosis. The white arrow is pointing to osteophyte. So this is osteoarthritis of the first metacarpophalangeal joint in the hand. Basic. That is what it is. Okay? We're going to the lower extremities now. We'll spend more time on the hip joints and less time on the other joints so that we can enter the
MR.
My target is to spend 1.5 hours on this presentation and the remaining 1.5 hours on MRI. So let me work hard to be able to meet my target. So this is hip joint, guys. Let's go over the anatomy again very quickly of the hip joint. Something that we know before. You can identify with the pelvis. Above the pelvis, we have the ilium. You can see that ilium ends with anterior superior iliac spine. Okay, you can still see the femoral head and the neck. You can see greater trochanter. We call it greater tubercle in the upper extremities, or tuberosity. In the lower extremity, we call it trochanter. You can see greater trochanter, lesser trochanter, the femur, and all that. We are all familiar with this one before, so we're not going to waste time. Now, anterior-posterior view of the hip joint. This is how the patient will position supine. The X-ray is coming directly in front of the thigh, and the film is captured, posterior hip joint. Let's look at the radiological anatomy again. The radiological anatomy, I'm sure we are familiar with this. You can identify sacroiliac joints. Yes, from what we have been saying before, you know, mention these joints in ankylosing spondylitis. You can identify the ilium. You can identify the greater sciatic notch. You can identify the head of humerus. You can identify the acetabulum, where the head of humerus articulates. The little indentation at the center of the head of humerus is the fovea centralis. You can identify the ischial tuberosity, that is where we sit on, and obturator foramen, very close to it, and the femur, and so on and so forth. Let's move on to the main work. Now, there is yet another view of the hip joint called frog view. All right? Frog view is usually good to spot congenital deformity, especially in pediatric patients that have some congenital defects in their hip joints, congenital hip deformity that leads to frequent subluxation or dislocation. All right, so let's not waste much time on that one. So you can see what it looks like on radiograph, the frog view, right? With hip in abduction, we can see the joint space very clearly. Look at the difference between frog view of pediatric and adults. You know, in pediatric, it looks like the head is fractured. It's not fractured though, it's because the ossification is not yet completed. It's not yet completed, okay? Even though there seems to be some defect on the left side, there's no defect on the right side, but what looks like fracture is not fracture. That's why I put pediatric there, is incomplete ossification. But if you look at the top left one, you see that it is completely ossified. We are going to see the pathology yet. We're still building up. Now, there's yet another view called cross-table lateral view. In cross-table lateral view, this is how the patient is positioned, 90 degrees of hip flexion and knee flexion, and the X-ray is coming from underneath, passing through the hip joint. And this is typical of the radiograph that we are going to have. Let's move on to the most important thing. This is the most important one. I beg you to pay attention here. These are the important landmarks that we use to make diagnosis for the radiograph of the hip joint. There are several of them, and they have different usefulness. You can see the line in red is called the iliopectineal line because of where it passes through. You know, pectineus muscle is around here. So the line is coming from ilium to the area of pectineus muscle, so it's called iliopectineal line. The light blue line is coming from ilium going to ischium, that's ilioischial line. And the yellow line is, well, teardrop line. I don't know its particular usefulness, but maybe because it curves like that. The thing is that if something is wrong with any of these lines, something will be wrong with the rest of them. So that's why I have chosen Shenton line as my own line for diagnosis. This Shenton line is what I've picked. And if anything is wrong, can you see the Shenton line? The Shenton line is the orange line. And you can see it's like a continuous smooth curve from the shaft of the humerus of the femur, going to the neck of femur, entering into the obturator foramen. Nothing should distort it in a normal hip. If this line is distorted for anything, then either fracture or dislocation have taken place in the joint. So anytime my patient come with their pelvic radiograph, I go for the Shenton's line. And to make diagnosis will not be difficult after you look at the Shenton's line. Like I said, if anything is wrong with the Shenton's line, something will be wrong with the other lines too. All right? So the importance of this landmark, they are very good to diagnose fracture and dislocation. Sometimes you will not see the fracture and dislocation, but this line is already distorted. You remember what I said in the morning? It might be an occult fracture. That's a fracture that is hidden, that is not yet well manifested. You are going to see manifestation of what we're saying very shortly. Let's look at hip dislocation. Let's quickly consider hip dislocation. What do we have in hip dislocation? Now, you know, in shoulder dislocation, let me make reference again. We say anterior is the commoner, Abi. In hip dislocation, posterior is the commoner. All right, posterior hip dislocation is commoner than anterior hip dislocation. And you know what we said about posterior dislocation of the shoulder? We said the head of humerus will move posterior and superior. The same thing will happen here. You can see the head of femur moving posterior and superior. The same thing. So that will help you. Now, the other thing I want you to pay attention to is if you get an X-ray like this, look at the Shenton's line that I told you. The Shenton's line comes from the shaft of the femur. It goes to the neck of the femur and enter the obturator foramen. Can you trace that line in this radiograph? No, it's not possible. The line has been distorted. So the moment you try to look out for that Shenton's line, you see it's distorted, just be thinking about either fracture or dislocation. Now, how would we know? Even before we see the fracture fragment, how would we know it is fracture or dislocation? If it is dislocation, the Shenton's line will be distorted and the shaft of the femur will be in internal rotation, just as you are seeing in this diagram. If it is fracture, The shunting line will be distorted, and the shaft of the femur will be in external rotation. If you just go home with those 3 key points for the hip, you'll be able to interpret radiograph of the hip. Number 1, shunting line. Number 2, when shunting line is disrupted and the shaft of femur is doing internal rotation, that is dislocation. The commonest dislocation is posterior dislocation. And in posterior dislocation, the head of femur goes superior and posterior. If shunting line is disrupted and the shaft is doing external rotation, just go and look for fracture. Fracture comes with external rotation, dislocation comes with internal rotation. All right, let's move fast. Well, I have 15 more minutes for this one, according to schedule. Now look at this image and tell us your differential diagnosis. Can you see the head of, look at the shaft of femur. Is it doing internal or external rotation? You agree this one is doing what? External rotation. And I've told you with external rotation, what happened? Fracture. Where is the fracture? Neck of femur. Very easy. The shunting line is gone. There's external rotation. So that tells you fracture. Can we look at the fracture? Fracture neck of femur. So the diagnosis, very easy to make. Now look at this one also. What can we read in this one? Again, the shaft is doing external rotation. No, it's not doing internal rotation, but the fracture is the fracture of the labrum. Is the fracture of the acetabulum. Sorry, there's nothing wrong with the head or neck of femur, but the acetabulum is already fractured, and the femur is doing external rotation. So in all cases of fracture, the shaft of femur will go into external rotation. If it's dislocation, it's going to do internal rotation. Okay. Now let's look at osteoarthritis. Osteoarthritis radiographic feature is the same in all the parts of the body. All the parts of the body, osteoarthritis show the same way. What do you see? Joint space narrowing. Joint space narrowing. You will see sclerosis. You will see osteophytes. All right, and they are all present here. So you don't need anybody to tell you that this is osteoarthritis of the shoulder. Sorry, of the hip joint. This is osteoarthritis of the hip joints. And this looks like a normal hip joint. We can see the joint space is gone here. Sclerosis is there. Osteophyte is also there. Okay. Now, what about this one? We have seen something very similar to this one in our previous slide. You can see the translucent area very close. And you can see the sclerosis is, I hope you can follow my cursor. You can see the sclerosis is just developing. Translucent before sclerosis is equal to avascular necrosis. Okay. In a very advanced stage, you will see that the bone would have broken within the head of femur. Okay? All right? This is still a form of vascular necrosis. This is avascular necrosis. You can see the broken line. On the diagram on the right-hand side, look at the diagram on the right-hand side. You see sclerosis, you see translucent area, and you see the broken line within the head of femur. So that's avascular necrosis. I'm sure everybody here should be able to diagnose this one. This is fracture shaft of femur, almost like mid-shaft femur with internal displacement of the distal femur. That's how we interpret it. Don't forget, emphasis is on the distal fragment. Can we quickly look at the knee joints? Let's quickly look at the knee joint. Let's quickly consider the anatomy of the knee joints. All right, this is the joint space where the cartilage and the meniscus are. The middle part is tibia spine. It's not osteophyte, like some of my students will say. Some of my undergraduate students will be referring to the tibia spine as osteophyte. It's not osteophyte. It's just a normal spine that is there. The osteophytes usually form at the margin of the bone. And like I told you earlier on, the medial aspect of the knee joint is more affected by osteoarthritis. In most people, not in all people. And like I told you earlier on, if it is osteoarthritis, the joint space narrowing will not be uniform. If it is rheumatoid arthritis, it will be uniform. There will be no sclerosis. There will be no osteophyte. But if you see joint space narrowing, you see sclerosis, you see osteophyte, my brother, just diagnose osteoarthritis. Now, this is just to remember the point. I'm sure you can do that. One is the medial epicondyle of the femur. 2 is the tibia spine or tibia spike. 3 is the medial tibiofemoral articulation. 4 is the tibia itself. 5 is the fibula. 6 is the head of fibula. 7 is tibiofibular joints. Tibiofibular joints. 8 is the lateral articulation between humerus and tibia. 9 is the lateral epicondyle. 10 is the patella. 11 is the shaft. So we can identify that. And on the lateral view, also, I'm sure we can identify this position on the lateral view. Now, let's talk about this one. What did you see here? Everything looks normal. You can see the patella. This is a normal X-ray. This is a normal radiograph. The patella is there. It's very clear. The first line here is the shaft of humerus. Nothing is wrong with it. Patellofemoral articulation is very clear. It's not narrowed. The head of femur is perfect. Fibula is perfect. Tibia is perfect. Tibia tuberosity, the line below the patella. Can you see that line below the patella? That is tibia tuberosity, and that is where patella tendon is inserted. So there's no problem with all those areas. Now, if we look at this one, what can we see here? Now there's a problem here. Let's see what we can see. Let's look at the A diagram. Patella is fractured, isn't it? So there's patella fractured here. There's fracture condyle of tibial as well. There's fracture condyle of tibia. There's patellar fracture. There seems to be fracture intercondylar of femur as well. So this is a multiple fracture. The trauma must be very severe in this diagram. It is also being presented in the AP view. The B is the AP view. The A is the lateral view. It shows fracture patella. You can see that the fracture patella is not very obvious in the AP view. Look at the B. You'll be missing it. You think that line is for actually femur, but it's a fracture line, that dark line. That's why it is good to get the two view. So you can see clearly, lateral view show fracture patella, fracture intercondylar of femur, fracture of the tibia condyle, like fracture head of tibia as well. And we can see it better in the AP view. That's what we can see in those diagrams. Now let's have a look at this one. This is just a fracture of the lateral condyle of the tibia. Look at that region and look at the dark line of the lateral condyle of the tibia. That's the fracture that is being shown in that place. Then the next one, what do you see here? I even say, what is your differential diagnosis? You can see that the tibia is fractured, isn't it? The tibia condyle is fractured. The head of fibula is also fractured. So it's multiple fracture involving the head of fibula and the tibial condyle. That's why I said, if you know your anatomy very well, reporting fracture in the lower extremities will not be a problem. Now here, what is this one? Myositis ossificans as well. Essential thing we want to show in this diagram is myositis ossificans. All right, just like we have it in the elbow joints. Okay. Now, what do we see here? This is osteoarthritis of the knee. I need to talk a little bit more on this one. You can see the joint space is not equal on the medial and lateral aspect. The lateral joint space is already collapsed. The medial one is still obvious. The medial one is still obvious. You can see sclerosis. Somebody's microphone is on. Please. Somebody's microphone is on, please. It's producing echo here. Please. Producing echo here. Please mute your microphone. I can't hear myself. I can't hear myself. Somebody's microphone is on. Please. Somebody's microphone is on. Please mute your. All right, I'll just continue anyway. You can see the reduced joint space on the lateral. You can see the reduced joint space on the lateral aspect. And you can see the osteophyte. So this is a classical case of osteoarthritis of the knee. All right. Please mute your microphone. Check your microphone. Mute.
Kauma Haruna, mute your microphone.
All right, thank you very much for that. All right, now let's have a look at this. I'm still hearing myself. Let's have a look at this. I'm still hearing myself. I hope the person concerned knows how to handle the microphone. I hope the person concerned knows how to. It's really very disturbing.
Kamal Haruna, mute your microphone. Kamal.
Very disturbing. Is it Kamal or what's the name? Please mute your microphone. Kamal or what's the name? It's very disturbing. Okay, let's carry on. Okay, thank you very much, Kamal, for doing that. Now, this is still osteoarthritis. Oh gosh, this echo will still continue. This is still osteoarthritis of the knee joints. You can see here between the patella and the femur, the joint space is lost. Look at the white arrow. The white arrow on the top is pointing to osteophytes. The red arrow is pointing to loss of joint space. All right. And the blue arrow is like a loose body in the soft tissue, something like the ossificans. That is what we can see in that aspect of the joint. We are nearly done with this section. I have 5 minutes to the end of this section. Then we go to the ankle joints. Now, this is the calcaneus. That's the bone that we stand on. All right. This is the radiological anatomy. Please go over it. Let's look at the radiograph and make some interpretation. I'm sure we can read this one with convenience. This is the calcaneus and it's fractured. So diagnosis here will be fractured calcaneus. It's fractured calcaneus here. All right. So we have fractured calcaneus on that radiograph. Oh, my imaging is freezing. And we are nearly, okay, I've got it back. So that's fracture calcaneus. I can move to the next one. Again, what did you see here? Still calcaneus that is fractured, all right? And then the second red arrow here is pointing to talus. It's just anatomy, basically, this thing. So the calcaneus is fractured. The vertical arrow is pointing to fracture calcaneus. And the oblique arrow, the arrow that goes at an angle is pointing to fracture talus. So this is fracture calcaneus and talus in the ankle joint. And what we have in this 105, just before the last slide, is osteoarthritis of the first metatarsophalangeal joint. It's the osteoarthritis of the first metatarsophalangeal joint. Again, we can see the reduced joint space narrowing, we can see sclerosis, and we can see osteophytes. We should be very used to this one now. So this osteoarthritis of the first metatarsophalangeal joint. Well, thank you very much. Enough of this radiograph. We are going to MRI now. I'm sure in another 1 hour or 1.5 hours, we'll be free to move about. So please just keep your question, and you can post your question to me even after the presentation. If you have 1 or 2 questions, I'm sorry, because of the time limitation, it's not possible to stop in the middle and entertain questions. Otherwise, we will not be able to finish all that we have. But I will entertain any question that you have even after the presentation. So I'm going to take this one off. I'm going to stop sharing this one and project the third one. Please don't go anywhere, just stay where you are. Few minutes, please. Right. Just a few minutes, I'll be with you. I think this one is a bit more interesting. Okay, doctor, I'm sharing my last presentation with you. And I can say I titled the Radiological Principle in Orthopedic Physiotherapy 3. This is basically about MRI, and it's basically about the spine. Maybe because I'm more of a spinal physiotherapy, I seem to have flair for this one more than the peripheral, but it's our duty to read everything and understand what we are doing very well, and also be able to teach our younger colleagues that are coming after us. So let's quickly go to slide number 2, MRI introduction. MRI is an excellent evaluation. You know, we said radiograph is for bone, X-ray is for bone. MRI is not only for the bone, it will also give us excellent information about soft tissues and fluid, including spinal cord. That's why it's better than X-ray. And MRI did not use electron knocking out, causing ionization like we discussed in X-ray. MRI uses radio waves. So the body to be MRI will be pushed inside a magnetic field. It will be hit with radio waves, and the radio waves will be used to form the image of different organ or tissues in that body, whether it be bone, be it muscles, be it fat, be it water. That's how MRI works. That's what makes it different from X-ray. Now, this slide is pointing to the fact that there are 2 major types of MRI. You can see MRI with TI images. They will say weighted T1 image. Or you can see MRI with T2. They will say weighted T2 images. They are all the same thing. It's just that they are looking, their priorities are different. In T1 images, the emphasis is to get fat tissues, mainly. So in T1 images, you are going to see what it will look like. Let me just do the introduction. The emphasis is to get fatty tissue. T2 images, the emphasis is to get fluid. All right? So more fluid than fat, but T1 is more fat than fluid. That's just the basic differences between these 2 weighted images as the reports will come to us. Now, if you look at this diagram here, you look at this, where we are going to explain the different component later, but this is like the anterior part of the body. This is the vertebral body. And after the vertebral body, the dark zone you are seeing here is the central canal and the spinal cord. Okay? I know spinal cord passes through, is in the midst of cerebrospinal fluid, but everything looks dark. Anywhere you look at the image and you see the central area where the spinal cord and cerebrospinal fluid is looking dark like this, it is a T1 image. The emphasis is on fat, not on fluid. Do you understand? If you look at the second diagram, you see that the central part is not dark. It is grayish white. And that is still where spinal cord and cerebrospinal fluid passes through. So that will be a T2 image. T1 image, the central part look dark. T2 image, the central part look grayish white. Let's not forget. Now let's do a little bit of radiological anatomy so that we understand the different part before we begin to read. So what will you tell me? Will you say this one is T1 or T2 images? Definitely T2 images. If it is T1 images, all the central parts will look dark. All right. Let's take it from the anterior going to the posterior. All right. I wish you can see my cursor from anterior going to posterior. This is the anterior part, okay, of the vertebrae. All right. And that's where we have anterior longitudinal ligament. That dark, the dark zone just before the vertebrae is the region of anterior longitudinal ligament. I hope you can see that. Then after that, we have the body of the vertebrae, all right? Then after the body of the vertebrae, we have another dark zone before you get to that whitish area where spinal cord is. Can you see the another dark zone after the body where they label PLL? That is illustrating posterior longitudinal ligament. You know, anterior longitudinal ligament is in the anterior abdominal wall. Posterior longitudinal ligament is in the posterior abdominal wall. I'm still going to show you a picture of vertebrae so that you'll appreciate all these things very well. Then the central area is where we have cerebrospinal fluid and spinal cord, all right? Then after that, you know, spinal cord extends from C1 to L1. Anything you see, continuation in that central part after L1 is cauda equina. Anything that looks dark in that area going down is cauda equina. It's no longer something we call spinal cord. And the most posterior object you are going to see, the most posterior dark gray area is the spinous process. All right. Now we have shown 3 ligaments. The first ligament just close to the body, dark zone close to the body, ALL. That's anterior longitudinal ligament. The dark zone after the vertebral body, PLL, that is posterior longitudinal ligament. You can see those one on the diagram. Then you can see the spinous process, Abi, in the diagram. Now, the dark zone after the spinal cord and cerebrospinal fluid is ligamentum flavum. These three ligaments are very important in the pathology of the lumbar spine. Maybe when we have to talk about the pathology, common pathology of lumbar spine, you will know the significance of these three structures. All right. But even interpreting the sagittal view, this is a sagittal view of MRI of the lumbosacral region, we need to take cognizance of all these parts. Now let's go to the vertebral body. You can see the vertebral body. I think that's the most obvious part. All right. As it transits from one level to the other. And in between the vertebral body, you see a light gray area. That is the intervertebral disc area. So you can see the intervertebral disc area. If you go down on that sagittal view, you see where the rectangular shape, I've told you since morning that lumbar vertebrae is rectangular in nature. You can see where the rectangular shape transits to triangular. That triangular one, the first one is the X1. So that means the vertebrae above it must be L5, L4, L3, L2, L1, and so on and so forth. All right? We're just trying to do a little bit anatomy for these T2 weighted images. And we're going to do more of that. Again, you can check this out and you'll have more understanding of what I'm talking about. Look at all the vertebrae. The rectangular shape changed to triangular shape. The first triangularly shaped image is the X1. You can see the vertebral body between L5 and X1. You can see all the vertebral body, right? If you look at the bone on the left-hand side, can you see the bone on the left-hand side? You see the most posterior object there is the spinous process, and you can see where the spinous process is labeled there. This will help you a lot to understand the sagittal view of MRI of the lumbosacral spine. So the first dark area before the vertebrae, anterior longitudinal ligaments, you have the vertebrae. The next dark area is posterior longitudinal ligaments. Then you have the spinal cord, all right? The spinal cord is covered by meninges, or what MRI radiologists we call thicker sac. They will call it thicker sac. You know, quite often in their report, they will say there is lumbar disc herniation compressing on thicker sac, or causing stenosis, or compressing on spinal cord. We are going to make reference to all those ones in this presentation. You can see ligamentum flavum. You can see the spinous process. Let's go on. This is just the anatomy. We are coming up. Now, again, this is T1 imaging. I think I've talked about it. Another slide is coming up. In T1 imaging, central part looks dark. In T2, it looks white. All right? We've talked about that. No problem. So we can go to the next slide. This is T2 images. We've talked about that. So let's go on. Now, this is also still trying to describe the radiological anatomy of the sagittal view to you. Compare it to the bone that you have on the left-hand side. You'll be able to have more understanding. Can you see the vertebral body? And you can still see the vertebral body in the sagittal view. After the vertebral body, you have the central canal, where you have cerebrospinal fluid and the spinal cord. I told you, if you see anything in that central canal after L1, it is what? It is cauda equina. Spinal cord stop at the level of L1, all right? Okay, and you can see the spinous process, all right? So that is just preparing us for the task ahead. The same thing is what we have here. Now, there's another view apart from sagittal view, and that is axial view. Apart from sagittal view, we have the axial view. And I want you to pay attention to this one also. Many people do not like this one. The sagittal view is easier to read than the axial view. But our duty is to understand everything, just like I said. If you consider the bone that is put on the left-hand side here, can you see the bone set on the left-hand side here? The vertebrae, superior view of this bone, you'll be able to understand the orientation of the axial view. Can you see the spinous process in the axial view pointing downward? And that area is the area of the spinous process, and compare that to the spinous process in the axial view. Can you see where spinous process is put in the axial view? You see, after the spinous process, you have the vertebral foramen, where spinal cord and cerebrospinal fluid passes through. You can also see that here, the central canal. And after the central canal, you have the vertebral body, where the disc is placed. And you can also see the vertebral body here. Those are almost the important part that you need to relate with. And go back to that easier view, look at the spinal process, and to the side of the spinal process, you will see paraspinal muscles, erectospinae, multifidus muscles, iliocostalis, spinalis, those ones are here. But you need to be able to identify spinal process, central canal, and the body. Do you understand? You need to be able to understand that, to be able to read the pathology in the axial view, okay? So we go on. Now, this diagram is asking you, what did you see? It's asking you, what did you see? I don't know whether you are able to see my cursor with presentation mode. Otherwise, I would prefer to make this one big and then you follow my cursor to see what I'm talking about. Let me do it this way first, then I'll go to presentation mode. If I'm sure you can see my cursor now, this is the spinal process, sir. This is the spinal process. And after the spinal process, you have the central canal. This white area here, looking like a triangle, is this white area here, looking like a triangle, is where the central canal and the spinal cord are presented. Okay, and the next area here is where the vertebral body and the disc are presented. And the shape, all right, the shape of that vertebral body area should be perfectly oval. It should not diverge to the side or diverge to the center. Anytime you see a dark area diverging to the center, that vertebral body area, that dark area coming to the center, that means the disc is herniating posterior-centrally. The disc is coming towards the spinal cord at the center. And anytime you see that dark area of the vertebral body diverging to the lateral side, that means there is posterolateral disc herniation and it's going to compress on the nerve root. So we should be able to have this simple and basic understanding. Let me show it in presentation mode. Spinal process. This is the central canal and the spinal cord. And the dark zone, oval, almost oval or love-shaped, that is the vertebral body. That is where you are going to find the intervertebral disc. I'm going to show you some other salient feature before we start interpreting. All right? Now, the spinal nerve root is what I want to show you now. I want to show you the spinal nerve root so that I'll be able to identify spinal nerve root when we see it. Let me try and make this diagram bigger first and use my cursor. Then I'll do presentation mode. Now, I'm sure this is a bit bigger so you can see. Now, this is what I'm saying, sir. This is the spinal process, not very obvious here. This one is the central canal where spinal cord passes through. Yes, and this is where the vertebral body are located. Now, if you look at the side, oh, I'm sorry, this is the spinal process and this is the central canal. Okay, where the spinal cord passes through. If you look at the side of that central canal, you see a little white circle with black dots, a little white circle with black dots. Those are the nerve roots that come from the side of the spinal cord. Do you understand? What I'm saying to you is that this disc at the back should be perfectly oval in shape. If you see the dark disc at the back coming centrally onto where the spinal cord is, you are having a posterocentral disc herniation. If you see the dark spot, the dark area of the back, coming laterally to come and you can identify the nerve root now. Coming to come and compress on the nerve root, we are having posterolateral disc herniation. We're going to say the consequences of that in our future presentation on pathology. All right? Okay. All right. I promise I will use it like this, then I will do the presentation mode. The same thing is still what you are seeing here. Concentrate on the diagram on the right-hand side, please. Now, you see the first love area that look bounded with whitish area. Then you see a dark area behind that. That is where the spinal cord passes through. So to the side of that dark area, you see tiny white circle with a black dot at the center. That is where the nerve roots. You know nerve roots come from the side of spinal cord, yeah? That represents the nerve roots because we are going to need that information in describing certain pathology very soon. All right, look at what I'm trying to say here. Please pay attention to what I'm trying to say here. This is not an MRI. This is just a slide for teaching. Now you see the spinal process going up. You see the central canal That's that cycle. And you see the body where the disc is. Now, in this diagram, the disc is projecting posterolaterally. Can't you see it's moving posterolaterally? What is it going to compress on? It's going to compress on the nerve root. That is like posterolateral disc herniation. If you see this disc going to the center, that is posterocentral, is going to compress on the spinal cord. So it's not very difficult to understand. So let's just go on, shall we? Now, let's have a look at this one now. After all those preamble explanation that we have given, what will you understand here? Okay, you can see the spinal process. I'm sure you can identify that. Look at the whitish area. That is where spinal cord and cerebrospinal fluid are located. You are comfortable with that? Can you see those tiny whitish with black dots that I've just shown you? What did I call them? Nerve roots. Are you okay with that? Now see where I describe as vertebral body area. Can you see that that vertebral body area is not perfectly oval? Part of it is splitting out and is going towards the red arrow where the nerve root is. So that's like a posterolateral disc herniation tending to compress on the nerve root. That is what you have on this slide. So you are seeing a posterolateral disc herniation that is already compressing on the nerve root. So you know such a patient will have back pain and pain radiating to the leg based on the area of supply of that particular nerve root. So I hope you appreciate what I'm trying to say now. Now look at this one. Looking at this diagram, look at the sagittal view first, and then we look at the axial view. I want you to look at the sagittal view on the left-hand side. Look at the region where spinal cord should normally be. You can see that. Look at where the vertebral body should be and look at the intervertebral disc. Now go to LX1. You can see the X1, the triangular shape. Go above it, you see L5. Can you see that F5? Now go on top of that F5 and look at the intervertebral disc. You see that the intervertebral disc is already compressing into the space that should be occupied by the spinal cord. Can't you see that there? It's very obvious. So between L4 and L5, there is disc herniation. Can you see that? It's very obvious on the sagittal view. Now, when you now look at the axial view, what kind of disc herniation it is? Is it posterocentral or posterolateral? Now, let's now look at the axial view. Now, look at the diagram on your right-hand side now. You see the axial view? Now, this is the region, you can see a perfectly oval. You can trace that dark oval shape out. And at the top, in the middle of that oval shape, that's the area where spinal cord and cerebrospinal fluid should be. But that area is supposed to look whitish, all true. But it's not whitish, all true. Part of the dark area is already extending into that area. So that means the disc is herniating posterocentrally, tending to compress on the spinal cord and the thicker sac or the meninges of the spinal cord. That is how it is read. All right? Okay. This slide is just to tell us a little bit about spondylosis with MRI. With ages, the intervertebral disc will lose its water. You know that now. And as it loses its water, the nucleus pulposus will be pushing on the annulus. This will be the object of our discussion in my next presentation on the pathology of lumbosacral area. It loses its water. It tends to become like annulus fibrosus, compress on the annulus fibrosus. The height of the intervertebral disc will be reduced, joint space narrowing again. There could be sclerosis. There could be osteophytes. And then the nucleus, the disc can bulge either into the central or posterolateral. That is what you see in spondylosis as far as MRI is concerned. Now let's have a look at this image. What can you see in this image, please? Can you see anything of significance? This is a T2 image of a 70-year-old man. A T2 image. Let's start with the vertebral body. You can see the vertebral body. Let's look at the intervertebral disc. You see them? Now go back, go down and pick X1. Can you pick S1? Now count up L5. Above it, L4, L3, L2, L1. Now look at between L1 and L2, all right? Between L1 and L2, can you see the vertebral body encroaching on the area where spinal cord and cerebrospinal fluid could be. So this is disc annihilation. Do you understand? Whether it is posterocentral or posterolateral, you will need axial view to be able to know. And you know what? The manual therapy for posterocentral and posterolateral, they differ. So we need to understand before we go and do a wrong manual therapy and patient pain increases. You understand what I'm saying? Now look at the diagram on the right-hand side. Again, look at the diagram on the right-hand side. Please go back to X1 since we can all identify X1. Now look on top of X1, what do you see? L5. On top of L5, you see L4. Now look at the intervertebral disc between L5 and L4. It's already encroaching into the space of the spinal cord. So it can compress on nerve root. It can compress on posterior longitudinal ligaments. It can compress on the spinal cord. We only know when we do axial view. All right? That is X1, L5, L4. Look at L3. Now look at L2. Between L2 and L3 again, you can see a very mild protrusion, a very mild annihilation. So we can diagnose all these things and call it mild spondylosis with very mild posterior migration of the intervertebral disc. But if we see the axial view, we'll be able to know whether it is posterocentral or posterolateral. Now you are going to enjoy this one. Let me make this one into presentation mode. Just go and look at the vertebral body, sirs. Look at the vertebral body. You can see it. Now go to X1. Now above it is what? L5. Now above it is what? L4. What do you notice between L4 and L5? L4 is anteriorly displaced. What do we call that pathology? Spondylolisthesis, isn't it? We have seen that one. Now look at between L4 and L5. Joint space narrowing. Can't you see joint space narrowing? That is spondylosis, isn't it? Now look at between L4 and L5 again. The space that is meant for the intervertebral disc is already compressing on the area that should be occupied by spinal cord. So that's going to cause radiating pain, radiculopathy. It can even cause stenosis. It can even compress on the spinal cord. But we'll be able to know when we see the axial view. Just trace the margin of the vertebrae up like that. You see everything that I've been talking about. All right. Now let's look at the next one. I think this is another interesting one. If you see this one, you'll be able to read it. There's no issue at all. Just go to X1. You've seen X1. Look at L5 and X1. Again, look at the joint space. It's narrowed. Spondylosis. Look at the disc. It's mildly compressing on the thicker sac. It's not much. Now look at L4 and L5. The joint space look all right, but look at the disc. The disc is even compressing more on that area that should be for spinal cord. Now look at L2 and L3. You even see more disc protrusion there. All right. So all these are signs of degenerative changes. All right. Okay. Wait, most time we still have more important one to see. No, this is just basic teaching. Now we're going to reading now. The reading of the MRI proper. And you know, in our reading, we'll still follow what? ABCS, isn't it? Where A stands for alignment, B is for this and that. Let's watch out for the alignment. Can you see the posterior vertebral line? In the first diagram by the left-hand side, posterior vertebral line is perfect. So there's nothing wrong with the alignment. Look at the diagram on the right-hand side. Look at the posterior vertebral line. It's not perfect. It's not continuous. So there's spondylolisthesis. Is that not it? How do we describe spondylolisthesis? We mentioned the vertebrae above relative to the one below. So what are you seeing here? You are going to say anterolisthesis of L5 on X1. How do I know it's L5? Is the next one, is the upper one to that one that look like a triangle. Lumbar vertebrae are rectangular, but when you get to sacrum, it changes shape. So we can see that here. If you look at the diagram below, you will see another listhesis. But this time around, it is L4 that is moving backward. So this is retrolisthesis of L4 on L5. I hope you understand with alignment. That's what you look out for in the alignment. A, B, C, S. Now we are on B. B is what? B is the bone. And which bone are we talking about? We're talking about the vertebral body. The vertebral body should be perfectly rectangular. If you see anything less than rectangular, if you see it dark, it is infection. That could be osteomyelitis or tuberculosis. We are going to wash it out as we see in the next diagram. All right. So we're talking about the vertebral body here. So you can see the vertebral body from L1 to L5. Now look at the small diagram that was circled. Look at that particular vertebral body. It's not rectangular like others. You can see some fragments of the bone there. So it is possibly a fracture, compression fracture, or infection that is taking place there. The clinical history will enable you to make differential diagnosis. But something is definitely wrong with that vertebrae where the blue circle is, because it's not perfectly rectangular like other vertebrae. Maybe fracture, maybe infection. Clinical information during subjective and physical examination will enable us to be able to make that decision. Okay, now let's have a look at this one. All right, we're still talking about the bone. Now let's go and look at the cartilage. That's intervertebral disc and the space. I'm sure you can identify and appreciate where the disc space is. They should be perfectly uniform in all instances. And just trace the intervertebral disc space to where spinal cord should pass through. You'll be able to know whether there's compression or there's no compression. But it's almost looking like a normal study. Not until when we get here, we'll be able to see some pathology. All right. Can you see the red arrow in the A diagram? Even though the disc appearing to be protruding, but the alignment of the spinal cord, the shape is still okay, especially at L5, X1. L4, L5 is a bit compressing, but the patient might still not be producing any symptoms. So we can simply diagnose this one as a mild degenerative changes. But if you look at C diagram, can you look at the C diagram, please? Can you look at the X1? I'm sure you can see the X1. Even the X1 bone is not the same size compared to the lumbar vertebrae. And between X1 and L5, look at the joint space. Can you see the intervertebral disc compressing massively on the area the spinal cord should be? So this is not a mild spondylosis. This is a very severe spondylosis that might have nerve root compromise. There might be nerve root compromise. So there can be spondylosis without nerve root compromise. There can be spondylosis with nerve root compromise. If spondylosis is very mild, the disc problem or the osteophyte is not compressing on nerve roots. That is without nerve root compromise. But if the spondylosis is massive and the osteophyte or the disc protrusion is compressing on nerve roots, that would be with nerve root compromise. Okay? All right, what did we see here? What did we see here? This is a very good one. I'm sure you'll be able to relate with this one as well. Let's look at the D diagram. Can we look at the D diagram, everybody? So go to X1, then go above it L5, look at the intervertebral disc. The joint space look normal, and there's no much pushing on the space for spinal cord. But look at L4 and look at the joint space. It's narrower, and you can see the intervertebral disc is already compressing on that area of the spinal cord. There are three consequences of such movement, like I told you. It could lead to compression on the nerve root. It could lead to compression on the posterior longitudinal ligament. It could lead to narrowing of the place where the nerve root passes through, which is what we call spinal stenosis. And all these things will produce symptoms. But how we are going to differentiate between their symptoms, please join me in the first week of August for the pathology of the lumbar spine. Now look at the E diagram. Can you see the E diagram? Look at X1, everybody. X1 is obvious. Look at L5. Now look at between L5 and X1. Can you see massive disc herniation? The disc herniated and is also going beyond its level. It's like it's migrating upward. All right? This is what is called disc extrusion or disc sequestration. And it has consequences on the symptoms that the patient will report. We're going to deal with this in the pathophysiology of lumbar disc problem as well. But at least we can see that this is a massive disc protrusion. We can all see that. So we should be able to diagnose that. And I've told you what is the consequences of this disc migration. Spinal cord compression, nerve root compression, spinal stenosis, compression on posterior longitudinal ligament, and all these compression can produce pain. All right? All right, let's look at the next one. Let's go to slide number 28. Now, what did I want to show you in this diagram? What did I want to show you? Now, can you look at the diagram, please, on the left-hand side, the sagittal view? There are two sagittal views there. The first sagittal view, look at X1, look at L5, look at the joint space, look at the disc moving out massively and is going beyond this level. Can you see that dark line going up? So the disc is exiting and is going beyond this level. It can either be disc extrusion or disc sequestration. And that's a massive disc herniation. And the symptoms is also massive. So let's just take note of that before we discuss the normal pathology. Now, the nerves. I've shown you the nerves in axial view. You can also see the nerves in sagittal view like this. The nerve is always like a small circle of white with a black dot in between. That's where you see the nerves, and you can see the normal disc. If the disc protruded posterior-centrally, it's going to the spinal cord. If it goes posterior-laterally, it's going for the nerve roots. So please, let's bear that in mind. Okay? Now, let's look at this axial view. What did you see in this axial view? What can you see in this axial view? This is a teaching slide as well. Can you see the central disc? It should be perfectly oval in shape. All right? The moment this oval shape is moving to the white love-shaped zone, which is for the spinal cord, that is compression centrally. That is central disc herniation. And the moment that oval shape is shifting, can you see where they put the blue arrow? Look at that oval shape is shifting. That dark zone is shifting laterally to go and meet the nerve root. That is posterolateral disc compression. If it's shifting centrally towards that canal, that is posterocentral disc compression. Okay? Now look at what I've been shouting about since. Can you see that here? You can see the disc area, that's the body, the disc area. It should be perfectly oval, but in this case, not perfectly oval. Can you see the red line? I'm not talking, the red arrow is pointing to the red line. And what you see in that red line is that part of the disc is already moving towards the central canal, where spinal cord is, causing central stenosis or central compression. And the same thing you are seeing in the D diagram, C and D diagram. C is very mild, D is very severe. Can you appreciate that? See the arrow in the D diagram pointing towards the curved red line. This object should be perfectly oval, but is already going towards the central, going for the spinal cord, either to cause stenosis or to cause other problem. And if it moves laterally, it's causing posterolateral disc herniation. So we actually need both the axial and the sagittal view to be able to have a perfect understanding. Now, please come with me and look at this. You will appreciate it now. Can you see a perfectly oval disc here? Can you see the yellow line? It's perfectly oval. Nothing is pointing towards the central canal. Nothing is pointing posterolaterally towards the nerve root. This is very, in the A diagram, I'm referring to the A diagram. But when you go to the B diagram, what did you see? Can you even see the nerve root here? You cannot see it again because the disc has already prolapsed and covered the nerve root on both sides. So this patient is going to have a severe stenosis, compression on the foramen where the nerve root exits. All right? Thank you very much. We're going to discuss more of that in our pathology. The same thing is still what we are illustrating here. All right? The pathology is still the same thing. Look at the red line. So there's a little central stenosis. All right? We can see that the green line is also pointing in the direction of the central, where the posterior longitudinal ligaments and ligamentum flavum are located. All right? So all those will still produce pain. Now, radiologic anatomy of the cervical spine. I want to quickly talk about this as we are approaching the end of the presentation. You know, you can read the vertebral level of the lumbar spine now. All you have to do is to go to the X1, which you can easily identify. From S1, you count L5, L4, L3, and so on and so forth. What about in the cervical spine? If you want to know the vertebral level of the, like in this diagram, in this MRI now, there's compression on the thecal sac, Abi, as in the cervical spine. How can we tell the level? You will go up next to the skull. You will see one bone that looks like a triangle. Can you see that? That bone that looks like a triangle is the odontoid process of C2. The odontoid process of axis. So that bone that looks like a triangle, just call it C2 and begin to count down from there. So you have C2, C3, C4, C5, C6. So what is the pathology here now? Look between C5 and C6. Look at the joint space. Look at the intervertebral disc. It's pushing centrally towards the thicker sac of the spinal cord. And you know the consequences of that. It could be on nerve roots, it could be on spinal cord, it could be on ligamentum flavum. All can produce pain. All right? Now, case presentation. Let's quickly look at this case. A clinical presentation of this case, and then we'll look at the X-ray. The patient is a 60-year-old woman complaining of headache, imbalance, lightheadedness, left leg numbness. She also complained of increasing numbness in her hands. So you know it must be a cervical problem, isn't it? With some hand discoordination. She has had significant leg, neck, and bilateral shoulder pain, possibly somewhat worse on the left side. On examination, she demonstrates paralysis of the biceps, triceps, triceps, wrist extensor, wrist flexors, and interosseous muscles. Do you know the implication of that? Maybe when we get to pathology, we'll discuss that. C5, C6 will be involved. They are the ones that control bicep, triceps, and wrist extensors and wrist flexors. You know, C7, C8, T1 are for the fingers. C5, C6 are for bicep, triceps, and the wrist. So that's where we'll be suspecting the compression. All right. So that's the little presentation. MRI was ordered. Look at what was seen on the MRI of that woman. This is what was seen on the MRI of that woman. Can we interpret it? Can you see the triangular area? That is C2, isn't it? Next to it is what? Below that C2 is C3. Below that C3 is what? C4. Below the C4 is what? C5. Now look at the intervertebral disc between C3 and C4. It's already compressing on the canal. The compression on the canal is more than half. So this is a massive compression. You cannot just say nerve root. The compression would have extended to the spinal cord at this level. Again, look at between C3 and C4. Look at between C4 and C5. Even between C4 and C5, the disc is still compressing on the central canal, but it's less than C3 to C4. That's why it's having this headache. C3 and C4 is the one causing a headache and all those problems with the head. C4 and C5 is the one causing the problem of bicep, tricep, and all this wrist problem. I hope you get what we are talking about. This woman is probably having myelitis or compression of the spinal cord, posterior-central, a massive one. And if you look at the axial view, can you see the axial view on the diagram B? That's the axial view. Again, you see the whitish area denotes where the central canal and spinal cord passes through. The dark area behind it is where the disc should be. Look at how much area that dark zone have occupied. It has almost obliterated the whole canal. So definitely there will be compression on spinal cord in these patients. Not just nerve roots, there will be massive compression on the spinal cord in this type of patient with this diagram being presented. Okay. Now we're rounding up. Look at this diagram, sirs and mass. What do you see? Again, look at the vertebral body. That's the vertebral body. Look at X1. I can identify X1. Look at L5. Look at L4. Can you even see anything that look like bone between L4 and L3? They are like written off, replaced by a different tissue. And it's turning white. And this white gray area is an indication of fluid. It should not be found in the bone. You can only find that in the disc because of nucleus pulposus. But now L4, L3 is looking like fluid. What do you think is causing the fluid there? It should either be inflammation or infection, or inflammation from infection. So this radiograph will be that of infectious spondylitis or spondylodiscitis that I told you in the morning, or you can say vertebral osteomyelitis. That is what you are having there. You can see that almost nothing is touching the spinal cord, but the disc and the vertebrae are already down with infection. So this could be vertebral mellitus or spondylolisthesis. Okay. Now, what about here? What do you see here? This is also very important. Please, let's pay attention. So you see here again, let's read X1, L4, L5, L4, L3. Right from L3, there is problem. Look at between L2 and L3. The disc is already moving towards the central canal. Look at L2, look at L1. L1 is deformed, isn't it? It's already broken down or deformed. And you know why we know it is port disease? Port disease usually form a gibbous. A long-standing port disease, when you look at the posterior end, it will form like a triangle, a sharp edge. You know that sharp edge of triangle? That is how gibbous appear on the posterior surface of the body. So when you see it appearing like that, or it has already appeared like that, you'll be able to know it's gibbous. And when it is gibbous, it is tuberculosis or port disease. Look at what I'm saying very clearly here. It is clearer here, isn't it? Can you see the area where the arrow is pointed at? The bone is already deformed, so there's an infection. But if you look posterior to it, you see that sharp edge of a triangle being formed. What is that? That is gibbous. And gibbous only come with the collapse of the vertebrae as it's happened with tuberculosis or port disease. Okay? Now, what about this one? My colleagues, what can you see in this diagram here? Could you say anything is wrong with the vertebral body? No, there's nothing wrong with the vertebral body. Look at the intervertebral disc. There's nothing serious happening there. The only thing that we can see is inside the central canal itself, where the spinal cord is passing through. And it's an abnormal cell, because it's not a normal thicker sac. It's not a normal cells of spinal cord. It's an abnormal cell growing inside the spinal canal. So when an abnormal cell is growing inside a normal cell, what do we call it? That's what we call tumor. And when it's malignant, we call it cancer. All right? So this is a simple illustration of what? Of spinal canal tumor. Whenever we see something like this. No problem with the bone, no problem with the joint space. It's just something growing within the central canal itself. So that is spinal canal tumor. Okay? Okay, we are almost done. What did we see here? What do you think? I'm sure you can read this one if you see it. Again, nothing is wrong with the bone. Nothing much. The whole problem is in that central canal again. You can see that gray mass inside the central canal. So that will still be spinal canal tumor. And this one, right? The vertebra has collapsed. Can you see the collapse of the vertebrae? After T2, the vertebra collapsed and you can see gibbous formation. That sharp edge of a triangle. So this is most likely coming from tuberculosis. And there's a bit of abnormal tissue inside the central canal again. So double diagnosis. Tuberculosis with tumor inside the central canal. What can I say than to say thank you very much for a long time for waiting to hear this lecture. Both to teach, we have all endured very well. Our passion and my own passion is that we should know everything that we are supposed to know, and we should be able to speak among all our colleagues with high shoulder. We are not encroaching into the area of practice, but we have responsibility to make sure that we understand everything that concerns the patient that we manage. So we are not going to stop at MRI. We are going further. We are doing acupuncture. We are doing manipulative therapy. We are going to look for more interesting things in our own area of practice that will improve our practice without necessarily feeling we're encroaching into other people. If we have this knowledge, we'll be a better person to manage our patients autonomously without any interference. And wherever we are not clear, we can ask our senior colleagues. Wherever the senior colleagues are not clear, we can go and ask the radiographers as well. But we have responsibility to develop ourselves in every area of aspect of management as it concerns our patient. So, ladies and gentlemen, brothers and sisters, this is where I am going to draw the curtain on our presentation. Thank you very much once again for your time. I wish to meet with you again. I think my second presentation has been slated for 1st of August. We are going to discuss the common pathology that affects the lumbosacral segments and how they manifest. It has some kind of bearings to this radiographic imaging too. Thank you very much. And this is where I say bye-bye.
Thank you.
Thank you very much, sir.
Thank you very
Thank
much,
you
sir.
so much, sir. It's been very, very wonderful having
Thank
you
you
with
very
us.
much, sir.
Thank you.
Thank you.
Thank you very much.
Thank you, sir.
Thank you
thank
very
you,
much.
Prof.
Yeah.
Thank you,
Thank you,
Prof.
sir.
Wow. Wow.
Thank you, sir.
Wow. Wow.
Thank you so
Okay.
much.
Thank you very much.
We appreciate you.
Thank you
Thank you,
very
sir.
much.
Thank you, sir.
We need more of this.
Yes, exactly.
Oh, yeah. We are done with this. Wow. That's a long day.
What a wonderful.
Okay, thank you all for being patient from morning. It seems there are people with questions, but as if Prof is no longer with us. So I think whoever has question can please drop the question on the WhatsApp platform so that we can pass it to Prof for response, please. So in the absence of any comment, I think we can close for today. Thanking everyone for participating and wishing to see you again and next time. Thank you all. Hafiz, I think we can close.